Good morning, everyone. It is my absolute pleasure to. It's not working. Yeah. Good morning, everyone. It is my absolute pleasure to welcome you all, my distinguished panelists, all people presented here, scholars and attendees, to this important panel on building resilient system to address hidden inequities in health, a multidimensional view. This panel has been organized by KHPT with support from Wipro Foundation. Now I take this opportunity to welcome our moderator, Ms. Chandrika Bahadur, to guide today's important discussion. Chandrika Bahadur is the CEO of Antra Foundation, bringing over 20 years of global experience in multilateral institution, non-profit and government organization. Her career spans over 20 countries, showcasing her international leadership. She chaired the Lancet Commission on COVID-19 Indian Task Force in 2021 and 2022, and she served as a president of Sustainable Development Solution Network. She is a founder director of SDG Academy, established the Reliance Foundation, and held various roles in United Nations. So I welcome you, ma'am, to please take over. Thank you.
Good morning, and a very warm welcome, and particular thanks to the audience today for coming bright and early so we can start on time. I'd like to invite the panel for today, and this is both a sobering and a optimistic topic that we're going to talk about, which is really how do we think about health outcomes for the people that are normally the last to receive services and the last to receive care of any kind. And that is going to be the focus of the discussion today. I am absolutely privileged to welcome as the chair of our panel, Dr. Himanshu Bhushan. Dr. Bhushan, if I can have you join us on stage. Dr. Bhushan is a seasoned public health expert. He's the former head of the Public Health Administration at NHRC, which is the technical support wing to the Ministry of Health and Family Welfare in the Government of India. He has also served as Deputy Commissioner and head of the Maternal Health Division in the Ministry. He has a background as a clinician and has worked in some of the areas that we are going to talk about today. He has also been a policymaker at the national level. He's led public policy work on the Indian Public Health Standards, the Public Health Management Cadre, Ayushman Bharat Health Infrastructure Mission, and the Nursing Roadmap. And his work has actually led to enormous strides in advanced emergency obstetric care, maternal and child health services, blood storage centers, nursing education skills labs, and quality assurance. He has been instrumental in key national programs such as SUMAN, PMSMA, and UHM, the National Oral Health Scheme. He's also contributed to international organizations like the WHO, UNICEF, UNFPA, and ICN, Indian Council for Medical Research, and held advisory positions with the World Bank, CDRI, and NCDC. Welcome, sir. It's wonderful to have you here. I'd like to now invite Dr. Abha Subbarao to the panel. Please welcome her. Abha is a faculty member at the Ramalinga Swamy Center on Equity and Social Determinants of Health at the Public Health Foundation of India. She's a social scientist with interdisciplinary training in family studies, human development, medical anthropology, and has spent over 2 decades on research and teaching experiences in these areas. And most recently, she's focused on maternal and child health interventions in rural Karnataka and the health issues of temporary women migrant construction workers and their health outcomes. Welcome, Abha. I'm delighted now to welcome Dr. Aruna Bhattacharya. Aruna, if you can come on the panel. Dr. Aruna leads the urban health systems policy research and health impacts of climate change at the Indian Institute of Human Settlements School of Human Development. She is a trained medical anthropologist with a PhD from the University of Delhi and has worked on health systems policy since 1998, focused on marginalized communities. Previously, she was an associate professor at the Indian Institute of Public Health in Delhi at PHFI, and has been part of the Government of India's review mechanisms for NRHM, NHM, and the Health Systems Global Shapes Consortium. Welcome, Aruna. I'm delighted to welcome Dr. Bevin Kumar. Bevin, if you can come here. Dr. Bevin is a public health professional with a master's and PhD degree in public health from Trivandrum, from SCIT from Trivandrum. His work focuses on structural discrimination experienced by marginalized groups, focusing on health and healthcare access, and he has experience in designing and conducting mixed method research and analyzing large-scale survey data. He's currently teaching at the Azim Premji University at the public health school of the Azim Premji University in Bhopal. And finally, I'd like to welcome Dr. Jiju Alex. Professor Jiju, if you can come join us here. Professor Jiju Alex is a member of the Kerala State Planning Board and a professor at Kerala Agricultural University. He is the former director of extension at the university and also on the board of management of Kerala Bank and chairs the state resource group for the decentralized planning. He's a graduate of the Kerala Agricultural University and a PhD from the Indian Agricultural Research Institute, where his focus through his career has been on decentralized planning, rural development, governance, and development. So even though Professor Jiju does not have an exclusive health background, the work that he's done has, as we will see during the panel, enormous implications for how we can think of and reimagine public health at the last mile. So that's a quick introduction to our panel. And before we start with the chair, I just wanted to get a sense from the room of how many people in the audience today have experience working with public health at the margins. Wonderful. That's a great setup for a wonderful conversation. So without much ado, I want to hand it over to Dr. Bhushan. Dr. Bhushan, for your opening remarks.
So, good morning and suprabhat to all of you, all the esteemed panelists on the dais, and also so many experts and the public health professionals who are here off the dais. I am really privileged to be here, and I am greatly thankful to the organizers and particularly Dr. Mohan and the team for inviting me at this place and giving this opportunity. The topic today, that is the building resilient system to address hidden inequalities in health. It's a very, very apt and important topic because, first of all, equity and access in itself is a big challenge. How to be equitable to the whole population. And India is a country where you can see the climate, you can see the culture, you can see the different type of environment, like you see in many countries, you can see here in India itself by going in the different parts of the country. So anything or any policy which addresses all these, is not an easy job. It's a very, very difficult job. And as a result, unless the partnership of all the people who are here and who are not here, both is very important to have with the government and the policy makers so that, access and fruitful access or inequalities can be reduced and other things can be improved. Now, if we talk of the climate, all of you are expert and I do not need to say about it, but everybody is seeing every day the paper. So many recent, things, cloud bursting, rains, floods, extreme hot, extreme cold, different types of weathers, pollution. So there are so many things which are there, but besides that also there are the things like disasters, fire, then earthquakes. So many aspects are there. Resilience is required for all these aspects. And if we talk of the resilience, then what is the first thing? Because there are so many areas where resilience is needed, and particularly first the infrastructure. Then how to access to those infrastructure, how the people will come to know. COVID was an eye opener where we can see that if all the hospitals were turned into COVID hospitals, and there were, as a result, many routine services suffered, and there were very high mortality and morbidity because of that, and particularly during the pregnancy and childbirth, lots of suffering took place. Then, if we want to see that besides infrastructure, we have the human resource capacity, advocacy. People's memory are very fastly evading. When the COVID was there, the behavior at that point of time, and then behavior presently, you can see the difference. But we are lucky that Government of India took so many steps and is still going on, so that those things are still there. So inequalities in the gender, access to the population, remote areas, tribal areas, urban areas, migrants, these are all very, very, very challenging. Irrational prescriptions, use of third generation, fourth generation antibiotics. During our MBBS time, we will only use ampicillin, gentamicin, amoxicillin, to the maximum. Hardly, antibiotics were being given. If a case of fever will come, we will not give anything. But if you go, from the first day, even people are going to the chemist and taking medicines directly. So all these things are attributed to the problems of the microbes and the antimicrobials. So AMR is also a very, very important area. Then there are, standard treatment guidelines, but hardly it is being practiced. There are so many private institutions. If you go there, people will get treatment and then come to public health institutions for an opinion, whether this opinion is right or wrong, so that they get the confidence. So all these things, how to address it? It's a big challenge. Biomedical waste, rapid urbanization, deforestation. So it's not only the health, even the social determinants of the health are also very important to be addressed. Although I was there very actively participating, and I was there in all the Indian public health standards, but the latest public health standards, that is the 2022, was basically drafted by me, and then, of course, by my team who supported me. So in that we have given so many climate resilient features, but these features are there in the book, but not being practiced. That is actually a big challenge. How to do this advocacy, how the people will understand that these are important things. Environment-friendly infrastructure, a scope for adequate natural light, water harvesting, solar energy, green belts, landscaping, strong infrastructure to meet the seismicity of the zone, use of rainwater harvesting, solar energy, low energy, LED, a lot of list is there. We have said that 60% of the total area should be reserved for the landscaping, and then the structure should be more vertical than the horizontal. So there are the list of the things, and these are very small lists. It's not a 10 page, 20 page, 1 or 2 page, but it's still not being followed. One of the challenge that I feel is that there are lack of funding also, lack of understanding also. I mean, it requires too much funding. So my also request will be to this audience and also to the organizers, that how low-cost solutions can come, what all innovations we can do. See, most of the health infrastructure is already in place. We cannot, break all of them. So retrofitting. So what all we do that retrofitting, low-cost retrofitting is done. If we want to implement fire safety, it's very costly. how low-cost things can be introduced, capacity building of the human resources, advocacy. So government will be interested in such innovations, low-cost things, a small booklet that these things you can do within your resources. These things you can plan for the latter. So these type of things will be really helpful for all of us. And then finally, this is very sure that alone government cannot do, because government has come out with several initiatives under PM Abhim, like critical care block, integrated public health lab, and so many other things, block public health units. All these things are there by the government, but unless a strong public-private partnership is there, unless everybody comes together, it is not possible to go to the last mile for improving the access. So with these few words, I stop here. It's a big topic. One can speak for a longer time, but we have esteemed panelists, and we want to give opportunity to the audience also. So thank you so much.
Thank you, Dr. Bhushan, for that excellent framing, and I think we're ready to go. I think just a couple of initial numbers, framing numbers, just for us to recognize that when we're talking about inequity, there are inequities in two different dimensions that we'll talk about today. One are the absolute differences that we can see in health outcomes between those sections of society that have resources, have access, are located in the center rather than the periphery, and those that don't. And that's a moment in time understanding of where we are in terms of the inequities in health outcomes. I'm going to give a couple of numbers primarily for tribal populations because those are fairly well documented. There's about a 20% difference in the under 5 mortality rate of children between those who are the average of the country and those that are the least, those that belong to the tribal population. For the IMR, the infant mortality rate, we are talking about a 15% difference in those outcomes. For the adolescent fertility rate, that's around a 12% difference. So these are pretty significant differences in outcomes at moment in time. And that's one framing I'd like all of us to keep in mind as we're thinking about this. But the other marker of inequity is the speed with which progress is made on these indicators between different groups, within different groups. And if you look at that, the gap in these differences, especially I'm talking about the Indian context, is widening over the last few years. So it's not just that there is a 20% gap, it is that this 20% gap did not exist 10 to 15 years ago. It's gotten wider. And that points us, that is a directive signal which is not an encouraging one, because it is telling us that incrementally the efforts of the state, of private actors, of civil society is going towards benefiting people that are more privileged than people that are not. So that's the second framing that I would like for us to keep in mind. And the third is the reverse effect of poor health outcomes and greater spending out of pocket of the poorest on health, which further impoverishes them. So that is the cyclical nature of inequity, where people that do not have access to services and need to purchase those services end up spending a much larger proportion of their income on those services, which ends up pushing them deeper in poverty. And so these are and then the fourth aspect is what Dr. Bhushan was referring to, which are non-health impetuses that come up, which disproportionately hurt the poor, climate change, microbial resistance, also linked to the overconsumption of medicines that are given without proper medical protocol, and other patterns of urbanization and economic growth that leave out the people at the margins. So that's the general framing that we will keep in mind as this panel proceeds. But I want to first ask Bevan, when we talk about the poor, the marginalized, the vulnerable, who are we talking about? How do we know who they are? And how do we, when I say we, how does the health system recognize them. If you can just talk a little bit about that first question, who's this group?
Thank you, Dr. Himanshu and Chandrika, for setting the context. So it's a very important question, because when you're talking about inequities and inequalities and measuring, it's important to identify who are these vulnerable groups. So we have a common understanding that we have different data sources, we have different information, that we need to go beyond the aggregates. So Chandrika just mentioned about a few figures, which is important to know because it tells us a trend, it tells us about a pattern. But it's important that if you have to identify where this vulnerability is concentrated, we need to go beyond these numbers to actually understand who are these groups which are more vulnerable. So I'll just take an example of the underweight. So when you look at underweight among children aged less than 5 years, globally we can see that the prevalence ranges between around 12 to 13%. But when we actually start from there and we start looking at it by different regions, we find that it's more concentrated in Western Africa and Central and South Asia and Southeast Asia, with almost about 25% in the South, and Central Asia region itself. Now, this is we just talking about on a global level, but when we are actually comparing countries, there we find that there's a wide range of inequalities that exist between countries themselves. Well-developed countries, they're doing better when compared to those who are not so developed. And when we talk about country in India, so the prevalence of underweight among children less than 5 is about 32%. And when we look at subnational estimates, when you go by states, there are different states have different kind of estimates, and the lowest is being Pondicherry, which is about 20 to as high as 45 in Meghalaya, and you can see that even within regions there's a kind of inequality that exists. Now, when we go beyond it, we can further disaggregate it. We can go look at the districts within these states, and some of these districts would be even having worse outcomes than the national average. So as we keep going, as we disaggregate information, it kind of tells us a story, and that's a starting place for us to understand about these vulnerable groups and where they're located. So we are able to do this kind of inequality analysis because we have the DHS survey data, which has been carrying in India. It is the NFHS, and we can make comparison across countries. And even in India also, up to the last 2 rounds of NFHS, we are able to even identify district level estimates. So we can even go as lower level to the district. So some of the common axes by which inequality is measured is, if you look at the history of health inequality research, it has started with the socioeconomic status. It started with wealth. So here also we see that in India, 40% of the children with underweight is concentrated among the poor when compared to the rich, which is just about 20%. Then when you're talking about geographical location, the classification that we use is urban and rural, a dichotomy. But even there we can see gaps with about 36% who are children who are underweight in rural areas when compared to 27 in urban areas. Then we also have other axes like social stratifications like caste. So when you look by caste, again you have a wide range of inequalities and gaps that exist, with underweight being more concentrated among the scheduled tribes and the scheduled caste groups. And if you take up the NFHS report, we have other axes. We can look at it by age groups. We can look at it by the mother's education and also the mother's nutritional status. Like if they are likely to be underweight, then the child also is likely to be underweight. And we have multiple axes by which we can examine it. So having said this, these are the levels up to which one can do a disaggregation. Now the questions of can we disaggregate or go even beyond this, because there are further vulnerabilities which again get masked in the averages. So for example, when you're talking about rural or urban difference, what about the area that is transitioning between the rural and the urban? What do we call as peri-urban or a peri-rural area? Quite a lot of cities, they don't have space to expand within the cities, and they are kind of encroaching into rural areas. So what about the vulnerabilities of the people over there? Okay, and usually when we make comparisons between urban and rural, we work with an assumption that the rural areas are deprived, they're disadvantaged, poverty is more concentrated there, but we are not talking much about the urban poor. Now, what about the poor in these urban areas? Okay, and these are also things which are masked in the data when we make comparisons between the urban and the rural. Similarly, when we talk about the gradients by economic status. Now, economic status by alone, it is a good starting point for us to examine, but it intersects with other identities. So how do we look at, somebody who's poor, who's staying in an urban area, and, or a scheduled tribe or a scheduled caste? So then we have this concept of intersectionality. So intersectionality helps us to look at how different intersecting identities produce these vulnerabilities or these inequities. But the problem with intersection, the way it has been handled in secondary data, is the problem of Cartesian reductionism, where we are trying to have understand a complex topic. We are trying to reduce it to categories. So it is useful in terms of helping us to identify certain areas, but also certain identities gets masked in it. Then the question of scheduled castes and scheduled tribes. See, we operate with the assumption that these are homogeneous groups in data, but in reality, they are not. A scheduled tribe in a northeastern part of the country, a central India, or even a southern India, they are very different. And even among the so-called broader categories, there are so many vulnerabilities, there are so many issues, historical disadvantages that communities face, which are not being picked up. So one example that I want to talk about is these groups which are denotified, or what is called as denotified groups. So these groups have a lot of historical disadvantage in terms of being labeled as criminal tribes by the British, and they still continue, even though the act has been repealed, the name associated with the stigma still continues. But where are these groups in the data? This is something that we know that they exist, but we don't know what is happening to them or what are the vulnerabilities that is being faced by these groups. So in addition to this, there are other identities like when we talk about employment. So in data, we broadly previously used to classify it as regular or daily wage or informal. But even within these two categories, when you talk about regular employment, there are people who have regular, who have contractual, this uncertainty with employment, and there are also the upcoming gig workers, who are engaged in different urban cities. So these are also vulnerable groups which are not very represented in the kind of data that we are looking at. Then there are also vulnerabilities related to occupation, like you have fisher folks. They have their own challenges because of climate change and also the health reasons because of their occupation. Then they are, for example, plantation workers. So these are all groups which are not identified in the data, but they do have their vulnerabilities. So one thing I just want to tell is, like, when we look at the WHO inequality monitoring database, it gives a lot of indicators. It gives so many countries for which data is available. But when you look at categories like disability, when you look at climate change, or even the elderly, the number of countries for which there are indicators, it reduces. So we do have a lot of emerging issues, but data helps us to an extent. It helps us in identifying these vulnerabilities. There is a limitation of how much disaggregation that we go, but if we have to identify and target vulnerable groups, then we need to think about mechanisms by which these are counted and making them count.
Thank you, Bevin. I think that was a very comprehensive description of, and it sets of the kind of vulnerabilities we're talking about. I'll come back to you in a bit, because I think we must understand also what are the ways this information can be meaningfully captured and what happens when we actually capture that information. But we'll come back to that in a later part of the panel. Let me now actually turn to Abha. Even as Bevin was saying, when we look at NHFS 5 data, what we see is that the gap in service coverage between the vulnerable and the average is actually less than the gap in outcomes, right? So we're doing better as a country in terms of making the services available but we are not able to see that translate into end outcomes. Uh, what are the main pathways that you see as explaining these differences from the effort that the state makes to what kind of an outcome we see? Is it a resource issue? Is it a design issue? Is it a capacity issue? What are these pathways and which sectors do they cover?
Thank you for setting the context so wonderfully. I think you're absolutely right. Is that there is the programs are there. The programs are there. They're training health workers. All of those pieces are in place. But for whatever reason, it seems like people are not able to access these programs. I think there's been a fair amount of research around, adolescents and the elderly, where there's a shortage of programs itself, and even when they are operating, they're not necessarily appealing, they're not accessible, they're not, acceptable perhaps to the communities here. But I think there's, I want to revisit this question through Bevin's lens, which is to again talk about the counting, which is that, we've not had a census in over a decade and a half. I think there's a large number of people who are not being counted. And even the ones who are being counted are not necessarily being counted very accurately. 1/3 of Indians, over 400 million Indians are actually migrants, within the country. And we don't know a whole lot about them. Frankly, this is a large proportion of the population that we have actually very little information on. I think he'll agree that, we know that women, for instance, tend to be captured in the context of marriage migration. Male migrants tend to be captured in the context of some limited form of labor or economic migration. But there's a large swathe of migrants that we're not actually understanding their pathways, how they're ending up, how they're able to access services, and so on at all. I specifically wanted to talk about, the temporary migrants, talking about intersections. So even within migrants, there's temporary migrants. The limited amount of research on migration suggests that those who move to urban areas, rural to urban migrants, tend to have poorer outcomes than those who are long-term urban residents, right? So women have lower access to sexual and reproductive health services, children have lower rates of immunization, there's a higher risk of communicable diseases due to the cramped conditions that they live in, and so on. But temporary migrants, and these are migrants who are increasingly being driven by climate change, are what we call short-term or circular migrants. So they come from a rural part of the country, they move to urban India for construction work or similar things for a short period of time, and they go back and forth. Now, they are not necessarily being counted in their place of origin, nor are they necessarily being counted in their, their temporary urban homes. These are people for whom it's very hard to capture entitlements and so on, because they might be registered in one place, living in another, half the family members are in one place, half the family members are in another. So they're registered for schemes. For instance, they might have a gas connection, or they might have taken advantage of some housing program in order to build a pakka home back in their rural area, but they are still not living in one in their urban area. So these schemes are there, but they're not able to access it necessarily. These temporary migrants tend to be disadvantaged by, once again, bringing up the question of intersectionality, is that they tend to be poorer, they tend to be from lower caste, they tend to have poor asset ownership, they have poorer, lower levels of education, and so on. And they come to cities, and they don't live long enough in cities to accrue the benefits of living in cities. There is some evidence that suggests that the longer you live in an urban area, that you might benefit, because you ultimately get folded into the health systems there, or local communities, and so on, or you're able to better navigate your chosen home. But temporary migrants never quite settle into that. If you follow their tracks, they might come from Chhattisgarh, 2 years they're doing construction work in Gurgaon, and then after that they're down in Bangalore doing something else, and then they're in Bombay. So they never quite live long enough to accrue the benefits of any of this work in any of the places that they live in. Furthermore, you look at, say, women. As I said, even women migrants, they tend to be captured as marriage migration, but they are not captured necessarily for the work that they do. They do have lower rates of employment than urban male migrants, but we tend to undercount what they're doing, and their needs are hardly resolved by anything. There's policy frameworks, there's programs for migrant workers, there's programs for workers in industries that are dominated by migrants, such as construction. And if you read the policy documents, the women don't come up at all anywhere. They're completely missing from this picture. So forget at an implementation level, I think we're not able to imagine what they might be able to contribute or not contribute even at a policy level. Um, it's really important to pay attention to this community because as rates of migration have actually gone down, permanent migration are actually decreasing, but that of this temporary circular migration is increasing over a period of time. So this is just a quick setup for how they end up in urban areas. There's so much to say about the kind of work that people do in urban areas, these temporary migrants. They do work which we call the 3 Ds. It's dirty, it's dangerous, it's difficult, and in the Indian context, it's often demeaning as well. All of these are linked to poorer health outcomes in pathways that I think are well understood and can imagine. And there's a sort of a psychic mental health aspect as well too for these temporary migrants living in urban areas, which is that they don't really belong. They are often harassed. I mean, I've spoken to people who will say that, I can't even go collect water from where I'm living because the locals come and harass me and say, you're not from here and why do you think you're entitled to the public taps here? Go collect water. So they're living here and they're still paying for water. They get a tanker to deliver the water or they're getting it by the bucket. So even these very basic services, even if they're legally entitled to them, there's a lot of social and cultural barriers to seeking. If they go seek care from a public facility, which is another issue because often they live in these peri-urban areas on the edges of the cities, they're not often able to access these public health services. But they say that they're treated badly. They say that you're not from here. They get dismissed routinely. So they're like, I'd rather pay 500 rupees a day to go visit a private clinic, even if it's a very temporary sort of fix. So I think I will stop here for now because I think I've kind of brought up a number of conditions. I think the last thing I did want to say was just about the living conditions, which is that a lot of these migrants, when they live in cities, anybody who's seen this anybody who's flown over any Indian city will see, oceans of blue tarps, right? And this is where the migrants are living. These are extremely temporary settlements built of bamboo and metal sheets and tarpaulin and so on. They are often in low-lying areas of the city, so they are higher risk for vector-borne diseases because it rains, there's water, there's mosquitoes everywhere. I think Aruna will speak a little bit more about sort of the climate, these living conditions. But I also just wanted to make the point that each of these things is worse when you're a temporary worker and when you're a woman temporary worker, right? For instance, when you're these temporary homes, so women are cooking in these temporary homes and there's no ventilation, they're at that much higher risk for respiratory diseases. They're living in these temporary spaces, there's no sanitation facilities, so you are using the outside spaces. They're at risk for everything from snake bites to sexual harassment because these are poorly lit spaces. There's more to say, but I will stop here. But thanks, Chandrika, for setting this up.
Thank you, Abha. I think very, very useful. I think we'll all walk away with the 4 Ds, which are so evocative of life in the urban slums. And it's a great segue, Aruna, for you to come in here. Abha's touched a little bit on the built environment and the social and economic environment, and then there is the environment, right, which is climate change and all of the changes that are coming with that. When you put all of this together, what does it mean for people who are already on the margins of community and of our world?
Hi, is it working? Thank you. I think I must thank KHPT for organizing this panel, and I'm honored to be here. And and also I'm happy to have these panelists coming before me. And I know we also have a position. I know the position we have always have some disadvantage and advantage, but I would talk about the advantages of coming after Bevin and Ava. So, okay, I'll step back a bit. So I'm looking at the salient feature of this panel. Like we have this term called resilient system, and then we also have the term equity. So I'd actually kind of pause and discuss how do we understand these systems? Of course, we understand health systems, but what kind of understanding that are we holding among us? From the policy making the chair, the table, that vantage, or the vantage of a vulnerable population or in a marginalized settings, or like us, the researchers who are kind of transitioning between these two. So that's an important position because we count numbers, we're really good at it. Can we look at the pockets within the pockets, or the layers within the layers? And if we do, how do we translate it? So I'm kind of also trying, listening to all of you, I'm kind of also reflecting, and it's going to sound autobiographical. Like, trained as an anthropologist, trained doing ethnographic research, we always ask these questions of how and why. And our colleagues just explained those hows and whys. And our policymaker senior also discussed that there is a problem. We know enough, but we aren't. So then how should we do? So I am trying to kind of pitch in my 2 cents here, saying we talk enough about intersectionality. We talk enough about multidisciplinary lenses, and we also use this interdisciplinary lenses. So let's break it down further. When we talk about understanding, like we're going into a peri-urban area, it is kind of marginalized. We understand what all, the morbidity pattern we kind of know from knowing epidemiology for so long, or for that matter, the health outcomes. But where do we start? Start as a migrant, start as a labor force, like an economic point of view, or as a resident? Because essentially, health as a right is equal to each citizens, right? And then oftentimes we see there is a disparity because where we are positioned, so I'm also playing with words here, with the positionality. Because being a migrant doesn't take away our rights to health or rights to citizen. And how, as a policymaker, are we counting that? Or how, as a researcher, we're able to weave those layers together? That's the task at hand. So I think coming to talk about how I was kind of guided for this panel is to talk about climate change, how it is creating disparity or how it is creating marginalization or vulnerability. So I'll actually take an example. Like, we try to constantly create recommendation. We always try to find a solution which will kind of close the gap. So this digital health, it's really interesting because we understand that there is easy portability. We have data at our hand. The dashboards are accessed everywhere. I am just back from Patna. I'm part of a climate change health multi-country research program. So this person, it's also a bit of health-seeking story. We have this beautiful, beautiful program, this ABPMJ, and it's very tertiary care, right? And of course, people are aware, but this person only puts money in the phone when this person has enough money. So the phone is of no value, the digitization. And a lot of people actually share the same phone number. So now, if is the story of hows and whys, how our policymaker friend would, so can we really create a cookie cutter model of a policy? So this is the problem at hand. Like, how many of us would suddenly go off digital, will be off radar digitally and will be more vulnerable the way we were mapped earlier? So how are we mapping? How is our intersectional diagram, like, this going through housing, going through the rights as a citizen, like what kind of resident I am right now? Am I in an unauthorized colony? I can be a migrant, but in an unauthorized colony, I am in an unenumerated, non-enumerated blue turp kind of a colony. So this also creates layers of vulnerabilities. And on top of it, like we are talking about climate change as if we didn't know it enough, we know it enough, but it would going to also create layers of vulnerability. And again, I'm not a number person, but I'm just thinking if we put together the kind of vulnerabilities that we would see would also kind of go around the caste lines and the tribe lines and the education line and the economy line. So it's no-brainer that we are not talking to each other. It's no-brainer that the systems thinking that we kind of preach in our classes or we know enough, we are not really practicing. Sorry, I don't know whether I disrupted it, but I hope I answered all your questions that you wanted to hear from me.
Thank you, Aruna. No, I think very useful, and I think that example of the assumptions behind which digital programs are designed don't necessarily apply to these populations is an important point, and we will come back to that. But I think it is time to look forward a little bit, right? So there is no doubt that there has been progress, and for a lot of people who were outside of the circle of care or the ability to take care of their own health, that we have seen improvement. But what are the principles of policy design and implementation that would prepare us to be more effective, both on the resilience front, but also on the access front, both of those fronts? And I want to turn to Professor Jiju. Kerala has given us a lot of important lessons on this, but I particularly would want this audience to hear about the experience that Kerala has had with making sure that healthcare is actually accessible to the people right at the last mile, and how the state has made that happen.
Thank you, Chandrika. In fact, I was very apprehensive when the invitation came. And also among the panel, I am the only person who has not specifically worked on health. But I have been working in the sphere of rural development, and we have got tremendous experience in decentralization, which I think would give answers to many of the questions which we have discussed here. And as I understand, the healthcare system and also the issue of last mile delivery of health services to the people at large requires the system to be decentralized. And there has to be an overhauling of the whole system of healthcare administration. And that requires a lot of political will, that requires a lot of financial devolution, that requires a lot of institutional re-engineering. I think I am coming from a place where many of these issues that Abha and Bevin have explained have become stories of the past. And that too, that has happened on account of the fact that we have believed the people. We have tried to devolve and decentralize the whole system. And you must be knowing, Kerala has got a very meticulous system of decentralized planning in line with the 73rd and 74th Amendment, when other states hesitated to devolve power and resources to the local governments. I would translate that into people. You take people into confidence. We decided to earmark as much as 30% of the total plan funds which we spend every year to the local governments. We have 1,200 local governments in different systems, in different tiers. And I would say I am a member of the State Planning Board dealing with decentralized planning. Last year, the budgetary allocation to local governments, which is prefixed and which is declared beforehand, it is not going to be cut down. Those resources would certainly go to the local governments. It is announced and published in the budget document. It is a whooping 9,000 crores for the entire state, plus the planned grants by the government, plus the centrally sponsored schemes, plus other external programs. So the kind of attention that we give to the health sector is tremendous. And what is the result? The local governments can design and devise programs which can cater to any section of the community. It could be the scheduled caste, it could be the scheduled tribe, it could be people who are nomads, it could be migrants as well, because we try to create data of our own, we try to address these issues at the grassroots level. We have got micro plans, household-based plans to address various health issues. So I would just cite one example. Out of these 10,000 crores, almost about 20% would naturally go to the health sector, invariably. And the rest of the money would go to productive sector, the infrastructure, etc. And the most important part is that they can devise their own programs. And we have made use of the Grama Sabha system. And we have made those systems transparent. And you must be knowing Kerala is a very politically sensitive state, and we have got high political consciousness. And we have started this program 25 years back. And see the results. The Kerala has topped in many of the health indicators, and that is much above the national average. And personalized health systems can be provided to people. Lot many things to tell you. Maybe in other rounds I would be able to explain how we actually approach this. So basically what happens is, during the Grama Sabha or during the consultative process, as much as maybe 300 to 400 people participate, and it is mandatory that all these sections of people, particularly from the poorer, SC, ST, and all those sections have to be mandatorily part of this Grama Sabha. And as much as 13 vital organizations have been transferred to the local governments. See, it is not only money. All these personnel, doctors, engineers, agricultural officers, veterinary surgeons, and the village extension officer, the child development officer, 12 officers and their respective hierarchical systems across the state, say from the block, maybe the district, all those people have been transferred to the local governments. And the local government president has got the authority to seek an explanation if somebody fails to deliver his duty. So this kind of a system wherein the local governments have direct access and control over various personnel who are deployed in various departments, plus the money, and also a robust system of devising the programs at the grassroots level. What we do is, we go for consultation at the Grama Sabha, people would say that such and such issues have to be addressed in various sectors. There are working groups under the doctors, and they sit together and formulate projects and plans, and they're all compiled. And out of the money that the state government gives, and also the money that they generate on their own, local governments have got own systems and sources. And this money would be pooled, and that would be divided across various sectors, and those projects would be implemented by the concerned officer, and that would be constantly monitored. The issue is, you have to enhance transparency, you have to enhance accountability. And money which is given by different levels of government could be integrated at one point. So the resources base would be much wider. And this is exactly the policy pathway which we have adopted to ensure that the money actually goes to the concerned person, healthcare systems are done and are implemented and delivered duly. And also I would say, there are certain other issues. Say, how can you integrate various programs? The programs can be complementary. The central government program may not be able to provide access to everyone. So we have a very good example. We have got the PMJY program. And in Kerala, we give health insurance assurance program for almost about 50 lakhs people concerned, poorer section, belonging to the poorer sections. But the central government, actually we require almost about 2,000, 3,000 crores for this. But the central government contribution is only 150 crores. Rest of the money comes from the state government. So it is your vision, it is your emphasis, it is your institutional mechanism which determines all these issues. And unless you have a radical look at how things work at the grassroots and what are the institutional mechanisms which are required, this issue is not going to be resolved. In spite of the fact that various governments are coming up with any number of programs, it is not going to come to them and to reach the people at all. This is my initial comments regarding this.
Thank you, Professor Jiju. And I think what you raise is both extremely enlightening, but also very hopeful. Because what it points to is the one thing that we did not talk about so far, which is the people themselves that we're talking about. What is their role in determining their own health? And I want to come back to the other panelists. We'll keep it open for now. Professor Jiju's talked about the policy mechanism for bringing in voice and responsibility and accountability to the communities and with the communities. In other places, either in India or anywhere else in the world, what have you seen that the power of the community and the power of the collective and their voice can do in making sure that they not only get quality care, but they are able to improve, some of the conditions that Abha, you were talking about in terms of the contributors to poor health?
This is it's a tricky question, right? I mean, we're asking people who are already quite disempowered to somehow find the power to collectivize and demand action or demand services or something like that, right? I don't want to sound so sobering, but I'm actually unable to pull up a good example of somebody who's was able to work. I'll tell you, there's been attempts at unionization, for instance, between I'll talk about construction workers because that's where a lot of my work has been, which is, as I mentioned, these are temporary construction workers who come and spend some time in urban areas, and they have very limited capacity for unionization because a lot of labor laws and so on apply to those who stay in certain sites for a certain period of time and a certain number of workers. So they don't necessarily have access to that. So what they do have is like these small self-help groups kind of situation where they put in a small amount of money. They have somebody who's trusted to manage their money. So in case there is an accident or in case there is some health situation that needs to be resolved, they can reach out to each other within. And it helps that these are often built around kin networks, these communities who come and do construction work in cities. So there are these sort of smaller things that can happen. I think this really speaks to the importance of having CSOs working in this space, because where it has happened successfully is when you have civil society organizations working on the ground, helping people unionize, helping them demand their entitlements, and so on. As I mentioned, they're often from other states. They might not feel like they have the linguistic capacity or even the cultural right necessary to seek care in a state that they don't belong to. So having CSOs to sort of mediate that space, to help them unionize, to help them seek services, is really, really key. I think the third thing, and I'm talking from the individual to sort of the community level to the government level, is, and there are a lot of programs actually on the ground, but making them work in spaces that they do not necessarily reach. As I mentioned, a lot of this happens in peri-urban areas, which, I mean, anyone who's worked in India knows that the urban health space is extremely fragmented. But urban spaces, there are a lot of health services, but they're extremely fragmented. And rural areas actually have a fairly well-developed and thought-out health programs. It's these peri-urban areas and the people who live in them that are not really served. So I think any sort of response to it will have to come, government or policy response from it will have to address these spaces. So how do you reach communities in these spaces? How do you count and reach communities who are necessarily moving all the time? So I think what Mr. Alex is saying is, it's so interesting, but I do wonder, and Kerala has done an excellent job at this. Actually, they have migrant programs specifically intended for migrant health workers, and so on. I think it helps that Kerala is also geographically perhaps a little tighter. A lot of spread out areas. I do wonder how one would actually do it. Enumeration is the first part of it, surely speaking, and I think we need that data before we can develop proper responses to it.
Professor Jiju, I want to come back to you with a follow-up. A lot of the responses to the Kerala success story are similar, which is that there are things about Kerala that are difficult to replicate in other places. So I wanted to talk a little bit about the challenges that setting something like this entailed, and one or two key success factors that you think from a design principle are replicable in any context in the world.
So I think how do we envisage the process of decentralization is something very important. In fact, we have been talking about our experience. We have been doing it for quite some time. We have been doing that for almost about 5-6 decades. The entire economy of the state has been on a redistributive growth model. The public sector investment has been huge in primary education and health, and that only has paid off. So I think there has to be a deliberate attempt on the part of the governments to see to it that primary education, health will have to be given more emphasis. I would even say that it has to be made mandatory, at least in light of the fact that this is something which should be taken up as a national goal. It should not be on centrally sponsored schemes alone. The state should come forward, and there has to be special programs to see to it that enough resources are devolved to the state government. And once the state government gets it, how do you participate other stakeholders is very important. Unless maybe CSOs are good and they are doing wonderful work. I know in many parts of the country where the public systems are weak, the CSOs have to be involved. But what exactly is the integration platform wherein such things can happen is the most important thing. Is it just substituting the government? No, I would say it should not be substituting the government. It should be complementarity with the different organizations coming together. I would say one example. We have taken up a program on palliative care grid. So this palliative care grid, we have found that this particular area is being supported by different organizations, the non-governmental sector, the private sector, etc., etc. And also the kind of services given to this society is different. Maybe the richer people would be able to have much better facilities, and the poorer people, particularly the palliative, that is one thing which we have not addressed. That issue is very, very difficult and very important. So how do the age, particularly in a state where the average lifespan is 75 plus, the age among the poor also is, the numbers are so big. So how do you give that? We have come up with a situation where all these organizations would be able to register in a palliative grid care, and a database is created, and this database would be of use to the concerned people, and they can register their requirement with the government grid, and services from any of these organizations. It could be private, it could be CSO, it could be maybe some religious organization, it could be the government as such. So these services could be given to the concerned beneficiary. So we can think of mechanisms. So mechanisms are not impossible, but only problem is that we should have some platform at the grassroots wherein all these activities could be integrated. I think we have to put our heads together and find out. And I would not say this is, as she said, this is not going to be one fit for all kind of a solution. We have to have customized, decentralized, and location-specific contextual solutions for each of these activities. We would not be able to prescribe that this is going to be the best solution for that. In Kerala, we have been able to do this due to political, historical, and there were so many other geographical, so many other factors, and that is not going to be the same. But there are certain states which can emulate some of these components. I would say, responding to your specific query, I would say the first and foremost guiding principle should be devolution. And secondly, it has to be institutions at the grassroots and strengthening the institutions at the grassroots. I would say the public sector should lead this, and that has to be compensated and supported by CSOs and other stakeholders who are at this level. That is the way out for us. That is my take on that. Thank you.
Very much. And maybe turning over, Aruna, to you. Professor Jiju's talked about the governance principles of equity. On other systems components, when you talk about capacity and information, accountability, what are some of those principles that you think can help us do better?
Thank you for this. We're trying to kind of weave through different prongs. So I would kind of try to reflect as I respond to this. We have, as Sustainable Development Goal 3, and we also talk about universal health coverage. And if you break it down, it means health for all, in simple terms, at all the time, at any place. And then we talk about our response to how we kind of look at our policy documents, and we say we have Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana. And if we kind of read through it, it is pretty much looking at tertiary care. Like if I have hospitalization, the out-of-pocket expenditure is less. So talking about equity, talking about, what are the other point you said, you mentioned? Capacity building, okay. I'll bring that later. So maybe I should ask it this way, that when we talk about health as a structure or as a system, and health, what comes to our mind? Is it a disease that we are trying to fix? Or is it like we are trying to create health and well-being? So where is our primary health systems? So I'm kind of touching base with rights to health as a citizen, equity, and then what is that information? When we talk about capacity building, the kind of word that rings in our head is training. How are we informing our people? These policies are for our people, and our people speak in different languages, read different ways, and are in different places. Are we able to map, or are we able to translate, not literally translate, but create that pathway? And where is that capacity building? Creating knowledge for different policies that are for people. So I would kind of do it in this way that oftentimes there are beautiful policies, beautiful program looking at the vulnerabilities, trying to close that gap, but actually not being, it's kind of standing as useless when it is going to that end user. Because oftentimes, I mean, from my experience of working among the urban migrants, and again, I'm using migrants very loosely, but urban population in different precarious situations are not aware about which are the programs, which are the social protection schemes that they can take benefit from. So this, I would think, a capacity building of a different kind, where I can think of an example. I remember there are organizations at the grassroots. They're doing conversation with the community, creating education about like how to complete those formalities of filling up those forms. The eligibility conditions, like I am eligible, but I probably need to kind of bring some papers, some documentation. So those kind of capacity building, I would kind of point out. And I'm not saying that it's not happening, it's happening, but we need to do more, because by the time people are getting aware or kind of becoming eligible, in quote unquote, already there is so much of out-of-pocket expenditure, so much of debt, so it is again of no use. So this universal health coverage highlighting, can we have our Ayushman Bharat program kind of getting into the primary health space, so that our first step of health seeking is not, we are not incurring, I'm not saying don't go to the private sector, please go. But where is that PPP model working for our marginalized section who shouldn't be paying out of the pocket? So that kind of capacity building of knowing our rights, knowing our policy documents, how to be eligible. And very quickly, I'll give an example. So we are now kind of, it is summer months. We are under heat wave. So this is this beautiful, I actually just got back from Bihar, so I'm repeating it again and again. We have this public health advisory that when the temperature goes up, it should be in the newspaper so that we know what to do. So now, it was 42 degrees last week, I think a couple of days ago in Patna. And there are CBOs who are also creating insurance, like, the work days where the 42 degrees, it is like 42 degrees is like the baseline, like it can go. So then there is a insurance thing, like you have to enroll for it. They'll be compensated for the work day, like some money, some money. And similarly for public, like I'm also counting myself as a public. How would I know where is that advisory? Which newspaper should I read? Or many of us are not even reading newspaper, how that advisory is even built in. So I'm kind of, I'm also kind of knowing like how policy has been made, how researches are done, and where is the gap. So these are simple examples I'm trying to say that, when we say capacity building, let's not stop at doing training programs. Let's do also this capacity building for information generating, so that people also, as a democratic, in a democratic setting, as a citizen, can we create equity with that lens?
Varuna, I just do want to sort of mention that the Ayushman Arogya Mandirs, the Health and Wellness Center part of the Ayushman Bharat scheme, is trying to focus on primary care. And with the frontline workers, with the ASHA workforce, that is the counter attempt with the balancing out secondary. But we know that it doesn't always reach everyone it needs to. But we'll leave that for discussion in the future. But I want to circle back to Bevin. Bevin, when you started, we said we'll come back to the point of what does one do with all this information, right? If you were to capture information in this to this level of disaggregation, first, from a state perspective, what are the practical challenges of doing that? But if we are able to get that information, how can it be put to most use? How can it be deployed most effectively so that some of the equity concerns that the panel has raised are actually addressed? And what is that information flow from the ground to the policymaker and then back again through program into making sure that the program's working?
Yeah, so just adding on to what Dr. Jiju was mentioning, see, he gave the example of decentralization and how information on migrants is like, with this information, the government has come up with, a sort of health system which is more responsive to migrants, which we don't see in many parts. So how are they able to do it is because, one thing, yeah, the state has an inflow of migrants, plus there is also information available at the local level. So that sort of a thing, they are able to make plans and sort of health system, interventions to make it more acceptable to them. So when you're talking about information, see, now we have policies in place, we have like structures in place, and we're talking about issues like not reaching the people. Now, from a data perspective, if we understand, like if we go to the level of disaggregation into identifying these vulnerabilities by which, which is preventing them or they're not able to access these services, now that can be at a local level, it can help in policy in terms of trying to understand a targeted approach towards these groups. If you're broadly focusing on, disadvantaged areas, yes, definitely, if you talk about vaccination coverage and things, it'll improve. If it is 60%, it might improve to about 80 or 90. What about the remaining 10%? So that is where, if we have a sort of a disaggregated information, that will really help in addressing these inequities. The other thing is, what we see for inequality, when we talk about inequality and inequities, we largely depend on quantitative data. So to understand inequality, we need quantitative data. To understand inequalities, there is an increasing role of qualitative studies. So a large researchers and organizations, they do micro level studies. But when you look at the entire NFHS itself, it's still quantitative heavy. There's no component of some aspect of qualitative information which can be captured, which can be used, which actually help us to understand these mechanism of these, how these inequities play. So that is something. And if we are talking about how do we ensure the representation of these vulnerable groups, so it also goes back to the design of the surveys, the sampling. Now, if you want to study about a certain group, you need to have adequate numbers for them to be represented, for them to be, for us to study and make meaning out of those numbers. But if we have just a representation of 4 to 5 people from that group, we really can't do much about the analysis. So it also involves a lot of design things which can be incorporated.
Thank you, Bevin. We'll open the floor now for a brief period of discussion and questions. I think we have a little bit of room to also hear experiences, so it won't be pure questions. But please try and keep your contributions to a minute maximum. And I'm sorry, but I will be timing that so that we can hear from as many people as possible. So we'll start here, right here, on the right-hand side. Sir, can we have the mic here? And then just go around. Please introduce yourself.
Good morning. I'm Dr. Maria Libreros. I'm a Colombian doctor, global health specialist. I was technical and operational leader for international NGOs in Colombia, working with IDPs, with migrants, refugees, survivals of gender-based violence, and so last mile. Even though Colombia is an OECD country, it does rely heavily on INGOs. And what is interesting is that the health cluster is led by the Ministry of Health. So my question for the panel, I know Professor Jiju already answered part of the question about CSOs and their role. I think NGOs have experience in multi-sector interventions that are very valuable in terms of primary health care. So I wanted to have a little bit your inputs because I don't really know the Indian context. I know that for NGOs in the past years it's been very complicated, but I wanted to have your perspective. Thank you.
I think we'll collect a few questions, but so yes, at the back there.
Maxine Whittaker from James Cook University. Just comments around community-led monitoring and community-led surveillance, because we've been talking more at an academic or government level, but how do we actually use CLM and CBS to support what we're talking about? Thank you.
I think we have two hands on the left-hand side at the back. Piche pehle. Those two hands and then...
Hello, good morning, panel. This is Mohammed Sohail from an organization called Saki Trust. So I have two questions from the panels. We know there is a lot of inequality in the health system. So what are the proposed solutions that you can give that how can collab with the public and private partnerships to reduce these inequalities? And what among, how do we create the more evidences? Because we tell that often there is a lot of evidences among the us. But how do we create the more evidence that should address the key issues that should make a more holistic approach to consider everyone from the marginalized background, mining affected communities to solve this all public health issues? Thank you.
Well, thank you. I enjoyed your presentations very much. I'm Klaus Wendt. I'm a professor of sociology of health and healthcare systems at Siegen University in Germany, and I work particularly on the international comparison of healthcare systems and also on health inequalities. I would like to refer to a concept by Korpi and Palme. These are two Swedish sociologists, and they focus on the paradox of targeting. And their main finding is that universal solutions are always better than targeted solutions, even when it comes to the reduction of social inequality and also of poverty. And the main reason is when you have universal programs, then you also include the middle class and the willingness to pay. And this is why I enjoyed the example yesterday from Thailand very much, that access to healthcare and annual medical checkup is given as a birthday present once a year. And this is a very good example that this is framed as a social right. And this really increase access to healthcare. You have given a lot of information how the last mile can be reached. But I think the local government should be key in this respect. And you have given a lot of good example how to do it. Thank you.
Thank you. One at the back, and then we'll come to you.
Thank you for a very interesting panel. My name is Anthony Ngugi. I'm a professor of epidemiology and population health at the Aga Khan University in Kenya. I like very much the comments and the discussions about disaggregation of inequalities at the lowest level. Some of my work actually centers around building capacity for very localized data generation by community health workers, data that is really contextually relevant to the needs and the priorities of very local health systems, because we are aware, and I think he was saying that when you have data that actually are from very broad levels like DHS, and many other national level surveys that could also even be powered to the district level, they actually have very, very limited utility at the local level. I've actually never seen, because I also work very closely with, for instance, sub-county and local district health data systems, I've never seen them use any of that data because, it's meaningless to them. It's actually it masks those very local area disparities. Yeah. So I think there's a case to be made of we cannot have health equity and equality without really granular local level data. Yeah. And I'm wondering whether this can be, in fact, in Kenya, the government has taken on our work and launched nationally what they call electronic community health information systems, whereby they're equipping community health workers with skills to collect that data at the very local household level as they do their health promotion and health education work at the household level. And these data are very, very useful. Our experience has been that even in the absence of any formal interventions, just by feeding back these data to the local communities, they aspired to mobilize community health action based on the indicators that are really doing poorly, and when they compare indicator performance between villages, they really feel challenged. They take ownership of what they need to do. So I'm wondering whether this is something that probably maybe has been thought of in India or can be tried. Thank you.
Thank you very much. We'll take a final question. Okay, two final questions, and then.
This is just to answer three questions related. One is that in the Kerala experience, if you can, because you have 1,000 plus decentralized units, is there any equity-based allocation of the funds that you are looking at? Is it a multi-dimensional or multi-indicator wise that addresses most of the other developed indicator? The second one is that you also said that is central funds are also allocated to the center, but does this equity also applicable to the central funds? Like is the, for example, what I'm interested particularly knowing that JSY scheme gives a like a flat rate. Is it varies from Kasaragod to Trivandrum? That's my interest to know. The third one is, sir, you said about autonomy in the decentralization. Where is the Lakshman Rekha? Because the tendency I have seen is that once we decentralize, then phone call comes, you do this, I have given you funds, you do this. So at the end of the day, the local units' voice and their empowerment that we have invested gets lost. What is that Lakshman Rekha, and how do you, that business of drawing that Lakshman Rekha, it will be helpful.
I'm Smita Sadasivan from Tamil Nadu, State Advisory Board member for persons with disabilities. With regard to equity and equality, the services are, inaccessible for persons with disabilities and other vulnerable communities. For example, if we take a medicine, many medicines don't have a QR code by which people with visual impairment can access the QR code and understand the details of the medicine, the expiry date or the ingredients and whatever. And similarly, the primary healthcare centers are not accessible for all 21 disabilities, persons with disabilities. So with these kind of inaccessibility and the data, National Family Health Survey question has dropped the disability question in the first place and in the 6th round. It was there in the 5th round. So these inequalities remain in the society. What are the steps? Even Azim Premji University's study showed that there are a lot of inaccessibility in the community primary healthcare centers. What are the measures taken by the government of India to address these inequalities, and what is the status at the global level? Thank you.
Thank you for this amazing conversation we are having. I am Komal. I am working with Piramal Foundation in Bihar. So my question is around decentralization. I would love to understand more on the beginning of journey in Kerala around decentralization, because still we are trying to do it but struggling with the capacities of local bodies on how to plan differently for their panchayats. And the reflection from the panel that we talked about the migration, the out-migration in urban cities. Is there anything we can do for the returning migration to their own space when they're coming back to their residences in their states? So is there any example or anything you can suggest?
Thank you. And I think we have a statement, but it has to be 20 seconds, the question.
Sure. The panelists have, I'm Nitin Kothari from Clinton Health Access Initiative. Panelists have rightly spoken about urban specific challenges and also need for efficient enumeration of data, especially with respect to population. I wanted to understand from panelists whether they see role of digital tools in ensuring efficient enumeration of population. I'm coming from the experience of one pilot we conducted in one Indian city, and we used digital tools to do enumeration of population, and we found that we were able to identify 50% more population than what was there in the paper-based record. And hence, would like to understand from the panelists, how do they see it?
We're quite short of time, so what I would recommend is we go in reverse order. Aruna, we start with you. Please address as many of whichever ones of the questions that you think are relevant, but we'll have to keep it to 2 minutes maximum.
Thank you. I realize that a lot of questions are coming to Professor Jiju, but I actually thought of an example to kind of tie together digitization. I think there's talking about medicine, but I'll take an example of tuberculosis. As we speak, country India, I mean, it is the oldest control program, and is a kind of a very good model of. And going forward, we also created tying up with the private sector. It's not really, I mean, sometimes we understand program a very horizontal, very vertical way. So it's also very interesting to understand, like, who are the people who are catering to horizontal or vertical? Who are these? Like the moment we say migrant, moment we say urban area, but so that the conversation about universal versus target. So I'm thinking of this example of multi-drug resistant tuberculosis. And my starting point of becoming a public health person or a health systems researcher started with tuberculosis, understanding, how people seek health. And tuberculosis was one of the, how do I say, that's the trajectory. So going forward, we're talking about 2022, we have a program called Nikshe. We actually count. We actually have a very it's very portable, like anybody sitting anywhere can update. So basically, I can actually read that how many people are seeking care in private sector, how many people are seeking care for tuberculosis in public sector, and apparently, it's designed in a very nice way. It's like, I will not be able to miss anybody. Yet, right now, we are also aware that so many people are having extremely drug resistant, total drug resistant, and of course multi-drug resistant. So then these are the paradox. Like, we try to create a beautiful solution, yet some it's like holding sand in your hand, and still how hard we hold, it still sips out of our, so it's like that. So I kind of think of a philosophy like, however much we try to fix solution, there would still be new problems would be created. So then why don't we think of creating, like, the whole thing, like, it's the right to health, it's citizens' business. We inform them enough, or we see that coming. That is the whole vision of public health, that are we able to see that coming? And we saw pandemic. We saw how, why systems design is very important. That's exactly, we're talking about this Nikshe or PPP model or tuberculosis control program. It's a beautiful model to see that, are we really trying to create a resilient system that can withstand stress, withstand uncertainty? So we need to create those pathways to, create new feedback that loop in. And then we do not have to create a new program. That's a bad design. So can we think of a resilient system? Giving this example of tuberculosis and AMR and multi-drug resistance. So our regulatory system, the pharmaceutical industry, oftentimes they are not tied together. Why then on earth or in India, some of us actually do self-care and can buy antibiotics without prescription? So things are not tied together. So that tying together needs we need loops, those closing those gaps. So that is how I would answer these multiple questions. Of course, it will not be very satisfactory, but love to have a conversation. Thank you.
Thank you, Aruna. Professor Jiju.
So in fact, so the question how Kerala has started the whole process is something which is very lengthy. I think I can cite your literature from where you'll be able to read the whole story. But that happened subsequent to the enactment of the 73rd and 74th Amendment Act, which has made the local governments mandatory, which also envisages that almost about 12 vital sectors could be transferred to the local governments. We in fact did it in letter and spirit. And then we have been successful also to a great extent. I would not say everything is perfect, but maybe to 70% we have been able to do that, and it creates ripples, it creates a lot of impact. So that is one thing. And regarding data, qualitative data is very important. I would cite an example. We have recently conducted a program to eradicate extreme poverty. Kerala had 0.7% extreme poverty, and we went for a micro-level database creation wherein we measured quantitative as well as qualitative aspects of multi-dimensional poverty, and we identified 64,004 households which require interventions in different dimensions. So there had been health, palliative care, etc., etc. And different departments have been harnessed, efforts of different departments have been harnessed, and they have been given mandate to address specific issues of each of these households. And maybe by November 1st, 2025, we would be able to declare ourselves as the first state to accomplish zero poverty, for that matter. 0.7% would be eradicated slowly. And also, we are looking forward to other instances of more poverty happening. That is not going to be a single time process, it is going to be continue. So data is very important, and qualitative data is very much important if you really want to address many of the grassroots level issues. And another question is regarding how do you, whether this equity based allocation is being done. Absolutely, it is based on equity. It is a formula based devolution as we do in the National Finance Commission. Basically, it's by the State Finance Commission. It can incorporate different indicators and income disparity, poverty, and some of the other socio-economic aspects, and I would say social determinants of health could be integrated into the devolution formula, which would certainly reflect more allocation to disadvantaged places. Contrary to what is happening at the national level, I would say that's a different observation. And regarding central funds, okay, there is a platform for integration of central funds. The funds would not be sufficient for everything to happen, so that would be compensated by funds from other sources. There is a mechanism of doing that. And regarding Lakshman Rekha is very important, and it has been protected by a legislative action. It has been enacted by the Kerala Legislative Assembly that there should not be any intervention by the state government or any other agency in the affairs of the local governments, except for various, say, few programs which the state government thinks are important. Say, for example, we have got a comprehensive housing program, LIFE, by making use of the PMAY and other some of the housing schemes. PMAY gives only 72,000 rupees, but we give 6 lakhs rupees, and rest of the money come from loan from HUDCO and from the plan. So that is how we make that compensation. And I think I have
Thank you,
answered
Professor
many of
Jiju.
those things, most of those things.
We'll come to Abha now.
I'm going to respond to just two questions as quickly as possible. The one was about the role of NGOs in the delivery of basic services, right? I think it's a very tricky question, because I think NGOs are often they're responsible for connecting people to services. So they might not be aware of their entitlements or getting them enrolled for schemes, taking them to the health center or to the school or to access child protective services or what have you. They play a very important role in that. But in my work, I've also noticed that NGOs are often a little resistant, because sometimes they say, this is the government's job. Why are we doing it? There's always going to be a role for CSOs, but increasingly it feels like they are taking on responsibilities that should be part of the public health system. So I think there's a little bit of a tricky situation there, which I think NGOs are constantly struggling with. The other question I wanted to speak to was the PPP question, which is, I think there are models that it has worked successfully. I mean, KHPT, who's organized this panel, is an excellent example of an organization that does PPP work in a very successful and thoughtful way. But there's also a lot of cases where, PPP models, they tend to focus on specific health programs or specific health outcomes. They're not working at a generalized level. There's not a lot of interest in reaching the most marginalized populations. So while they might be delivering services at a broad level, it doesn't necessarily get to the people who might need it the most. So I think there is a little bit of reluctance within the mainstream public health community to relying too much on PPP models.
Sorry, I've just very quickly to run through it. See, one thing when you're talking about community-based organizations, for those who are interested, I would encourage you to look into the work of Accord as well as Ekjut, where, I mean, there are many organizations where community is at the heart of their intervention. So when you're talking about health systems, we talk about structures, we talk about provisioning, availability, but where is the community? Is health a priority for the community? So these organizations have been working on, from the community aspect, giving priority to their needs and then working on health. And that is something that we need to look into. Just adding on a bit about PPP, just coming out of a conference where, when you talk about private, it's private profit minded. So can we think about models like public and non-profit minded private entities? So that is yeah, and then just about digital tools for data collection. See, we should not see largely see community health workers as people who are collecting data. Okay, in addition to the other work, is there mechanisms by which we can empower them for local action? Okay, so I just quickly end up with the example by Seva Rural. So the community health workers, they measure the height and weight of children, and immediately the app shows that whether a child is moving from ma'am to Sam, and the community health worker then call up people and also inform them, and they initiate mechanisms by which the child is get to access the care. So can we empower community health workers to actually not only collect data but also localize action?
Thank you very much. That was a wonderful, comprehensive response. I'm going to ask Professor Bhushan to close us, but before that, I just want to put up some key words that came out of the panel today. No summarization here. One is information and at a granular level, so disaggregated along multiple parameters, empowerment of the community and a voice for their, to articulate what they need, devolution, localization, and looking at the entire system in partnership with multiple actors. I think if these are the basic principles we can work towards, we will be on our way to building a more resilient system. Dr. Bhushan, floor is yours.
So, a very lively, participative and exciting discussion, both from the panel and also from the audience. I mean, many questions and very apt questions have been raised, very apt, comments have been given, and I am not going to enumerate all the questions like, universal solutions, than the targeted solution, role of local government, reducing disabilities, community violence. What I would like to convey to you, and then also would like to convey about the challenges. Most of the things which have been taught, which has been discussed in this room, there is a policy and program by Government of India. I am not going to enumerate, but everything is there. National health missions, has been grounded on the basis of the decentralized planning. Funding is to be given only with the consent of the people. Every hospital has the hospital committees where people representatives are there. Funds are going to every panchayat at the lowest level for making the village health plan, and to every local bodies for making the urban plan. But as I can see even the people sitting here, the information is not reaching. The gap of the information is there. And if those informations are there, at least people can be guided. So this is a big gap from the government side, that if the schemes are there, policies are there, people are not knowing. And then think about those literate people. Think about those who are there in the rural area. Think about those who are there in the rural area, far-flung areas, hilly areas, cut-off areas. How they will come to know about the schemes and programs. That's a big challenge. And then is there a solution that we make a program? Like we have the universal program. And the local people are given flexibility to put something so that that targeted population is benefited. But those things are not coming. The people's ability to plan is lacking at the state level, district level, and also at the lower level. So what I feel that health alone cannot do. Wherever you see the literacy is there, wherever you see the governance are good, and wherever you see economic empowerment is good, things are moving. How to address this is a big challenge. Besides the issues of the health, which government is trying, which all of you are trying to solve, I think we have to look into it. We have to still do the advocacy, and we have to give the solutions to the government to overcome this, and slowly, we will reach Kerala and Tamil Nadu and other states. I fully agree. I have seen Kerala. So many examples are there, but shortage of time, I will not say. Thank you. Thank you so much.
Thank you very much for your time and attention. We conclude today.
So thank you everyone, thank you all panelists for the wonderful discussion. So we would like to present a memento to our distinguished panelists for their contribution to this panel. To carry forward this gesture, we would like to invite Ms. Parvati Mohandas from Wipro Foundation to join us stage, please. Yeah. So we would like to honor Dr. Himanshu Bhushan. Thank you, sir, for your contribution. Our heartful thanks to Ms. Chandrika Bahadur for her thoughtful contribution as a panelist. We would like to present memento to Dr. Abha Subbarao. It's pleasure to present a memento to Aruna Bhattacharya. Ma'am, please. And last, we are pleased to honor Dr. Bevin Vinay Kumar. Okay. Yeah. And last but not least, Dr. Professor Jiju. Yeah. Thank you, everyone who have joined today. Yeah, thank you. Thank you, everyone. There is an announcement. We have another session. So requesting everyone to please vacate this room quickly. Please cooperate.
Still programs are there, ऐसा नहीं है, but enhanced nutrition system maybe not directly by that. Maybe there are so many programs and every time the software and other things. Basics are there, but information is नहीं है ना? And even for the disability and other things, many individual diseases are now covered. लेकिन लोग को पता नहीं. But lot more is needed. But lot more is needed. पर मैं ये नहीं कह रहा हूँ कि lot more is
इसका आप खुल के पीछे हो जाएगा ठीक है you can put
एक मार्कर डाला था इसमें
चेक ठीक है चेक चेक आ रही है
Good morning, everyone. We are just presenting the meeting on the topic of leveraging digital health platform to ensure equity and inclusion. Our speakers are Abhimanyu Saxena. He is the head and health system strengthening UNDP. Mr. Pavan Kumar, he is additional commissioner immunization of Ministry of Health and Family Welfare in Government of India. Mr. Mahesh Kumar Agarwal, he is team leader of immunization. And we have Dr. Rangnay Mateba, he is immunization specialist from UNICEF India.
Okay, very good morning, everyone, and I request extinguished cash at the back, please settle down. So very good morning once again, and as the previous speaker mentioned, we are here for a very important session on leveraging digital health for equity and inclusion. And may I request them to please put everything on mute? Yeah. Okay, so digital health for equity and inclusion. Let me put more emphasis on the reach and depth of this panel. First of all, it's a pleasure that Dr. Pavan Kumar, Additional Commissioner Immunization, is chairing this panel. Sir, welcome on board, and may I request all of you to please welcome him from the huge round of applause. Sir is heading the immunization vertical as well as maternal child health vertical at Ministry of Health and Family Welfare, and he has more than 30 years of experience. He has provided input for more than 30 public health interventions and more than 90 research papers he has contributed. There cannot be a better chairperson than Dr. Pawan Kumar for this panel. Moving forward, we have Dr. Ranganai from UNICEF. She is heading the immunization vertical and she's the immunization specialist. Let's welcome her from the huge round of applause. Dr. Ranganai is not just heading the immunization at UNICEF India, but also have a very rich experience in serving in this area in multiple countries, including Nigeria and other countries. And right now, UNICEF is a very strong partner of Ministry of Health and Family Welfare for many interventions, including vaccination, monitoring, social and behavior change. So it's a pleasure to have her, especially when we have to talk about the inclusivity of this program. And of course, we have Dr. M.K. Agarwal. He is the Director Immunization at WJCF. Can we have a huge round of applause for sir? Dr. M.K. Agarwal is right now heading the immunization division at the Clinton Foundation, but also he was part of Ministry of Health and Family Welfare Immunization Division for many strategic interventions, which we will discuss when we'll have opportunity to hear from him. But as I mentioned earlier, that we have a very rich panel and we are looking forward for much constructive and productive discussion. I request all participants to please put your phone on silent. So to start off and to talk about digitalization, yesterday we attended some sessions and you can see there are multiple sessions happening across digitalization. But why this session is important is that we are talking about the new innovations, the pilots and the scale at the same point of time. We discussed yesterday also in few sessions that there are 4 A's which are very important to understand any digital health solution and to scale that digital health solution. The first A is the accountability aspect, the leadership, the ownership of the government. For example, if we say that CoWIN is the single source of truth and we have launch of UWIN by Honorable Prime Minister, that set the context. Similarly, the second A is the affordability aspect, which means that India is a diverse country. We are doing vaccination in remote islands. We are doing vaccination in Himalayas. We are in conducting vaccination sessions at the places where there's no network connectivity or very limited network connectivity. So our digital health program, it's easy to conceptualize, but at the same time, it should work at the scale. It should work in the low resource setting. So that is also very important for us. The third A is the aspect of authenticity. That the data which is coming, how authentic it is and how it is getting validated at different levels. When we talk about digital health, we are relying on our frontline healthcare workers. So more than 220,000 ANMs, more than 800,000 ASHA workers, over 1 million female healthcare workers to operate these digital applications. So the authenticity aspect, the data validation, data security, and how we ensure that the data which is coming is meaningful and useful for us. And the fourth and the most important A in this aspect is the accessibility. That most of the process in the entire immunization supply chain and other health verticals are either digitalized or in the process of getting digitalized. However, do we have accessibility and do we have data integration mechanisms in place or these applications can talk to each other to receive the outcome and output which we are looking forward to. So with this thought, let us start the panel discussion. And I request Chairperson Dr. Pawan Kumar sir to set the context. Especially Dr. Pawan Kumar sir has conceptualized and designed a very robust zero dose implementation framework for the country, which talks about more than 8, 9 interventions, strategic interventions like UWIN implementation, monitoring and mentorship, like CSO engagements, data analytics and usage. Similarly, there are other implementation like BESD, community of practice demand. And so digitalization is an important aspect in most of these implications. So when you envisage and when you design this program, we all would like to understand that how digitalization can play a vital role in these intervention. So with this, I request Chairperson to please come on the dais and make a presentation so that it can set a context for us. Thank you, sir.
Thank you very much, Abhimanyu, and very warm welcome to all delegates and distinct guests which are off the dais and on the dais. And it's a proud privilege from the ministry side for all of us that in coming 1.5 hour, 90 minutes, we will be discussing about digitization, use of IT in public health interventions, and more specifically in immunization. So the task which has been given to us is to set the context, what has been done, and then deliberations about use of different IT platforms will happen in due course of time. As many faces they are known to us and a few are new from outside maybe from the program, but for the sake of everybody, let us see what the program is, that the quantum and scope of the program for the country. We are very huge country having a cohort of 29 million, 2.9 crores pregnant mothers for which we give vaccination. We have a cohort of 26 million newborns, 2.6 crore newborns, which we give 11 antigens for 12 vaccine preventable disease. We have a very huge network of cold chain, more than 30,000 cold chain points are there. We conduct almost 1.2 crore immunization sessions per year. See the scope, and we are polio free. For last 2011, we haven't have any case, and we are maintaining and sustaining that for last more than 10 years in the country. We have achieved maternal neonatal tetanus elimination since 2015, and we are maintaining and sustaining that. And recently, last year, we were having that field survey of see that what is the status of MNT in the country. And accordingly, the Government of India set a new target of having a measles and rubella elimination by 2026. And this is a Southeast Asia region also as a commitment to. So we have a plenty of work. Our plate is full to work. Lot of new initiatives for the country, and more specifically for the immunization program, which is the largest public health intervention, largest public health program, not in India, not in region, I will say in the whole of the world, because of size of the quantum which we cater for our country. And all antigens, all vaccines which are within the country, indigenous, and we are not dependent on outside agencies to get a vaccine from the foreign. So all are Indian made vaccines and which are being used for the country. Seeing this, the quantum of cohort, size of the cold chain equipments, number of immunization session happening, number of vaccinators we have in the country. So without digitization, without IT, it will be very difficult to handle the platform where this so much of quantum work is being done in the country. If we see the milestones of different immunization scale and scope, how the vaccines they have been introduced in the country, from 85 to 2000 only we were having 4 basic vaccines, but in last 10 years from 2011 to 2021, almost 6 new vaccines they have been introduced. Then AD syringes, VVM, so many new interventions they have been. This is just a milestone, how the things they have progressed in last 30 years, how we have progressed in inclusion of like fractional IPV in 2023, then Rota, then PCV, how the scaling of new vaccines they have happened in the country, then J in selected districts and selected states, this is how the things they have happened. As Abhimanyu was telling, the main bottleneck was having a zero dose children. Zero dose children, who are those children which are basically, for the operational point of view, a definition has been set as a operational definition. A child who has not received a DPT containing vaccine, mean penta vaccine, which is due at 6 weeks of age, but he or she is not able to receive that vaccine till 1 year of age. If any child in the country who is due at 6 weeks for DPT or a penta is not able to receive vaccine till 1 year of age, this means is a proxy indicator that she or he might have divide of other antigens also. So that is a kind of a operational definition, a kind of a proxy definition, a proxy indicator to capture the zero dose children. That is our aim and goal, because once we capture those zero dose children, it is automatically that he comes into the system, he will be followed, he will be tracked, and he will be given due doses as per her or his age group. So that is a challenge for the country. Seeing that challenge, lot of things they have been done in the recent past in 2 and 3 years, lot of manthan, lot of deliberations they have happened. And with this context, Government of India has brought a guidance document for a zero dose children, how to handle, which are those geographies, which are those vulnerable children which are there in the remote area, hard to reach area, on the roads, streets, where are those children? If they would have been part of our system or a micro planning, we would have covered them actually. That is not an easy task, because we have a micro planning, we have an inclusive, exclusive, whatever you want to call, we have a micro planning class, all things are there. But they were never part of those micro planning. If they would have been part of micro planning, they would have been covered into our routine immunization. So basically these are the geographies where the children, they remain, maybe underserved population in slums, or in those area where the tribal population is there, migratory population, some kind of a vaccine hesitancy, refusal, denial, vaccine avoidance behavior. Causes can be many to capture those, but how to handle them? It's not that one IT platform is created and they will come into the system. I think there can be a behavioral problem, there can be a supply chain problem, there can be a civil society intervention is required, maybe a micro planning is required. Many interventions they are required. With this background, Government of India has brought a guidance document how to handle those zero dose children, which Abhimanyu was just referring now. So these are 11 interventions which has been taken care by the country to handle those zero dose children. The most important is a UWIN, winning over a universal immunization program, which the platform which was in basically, so which was basically IT platform, because now we were using MCP card, maternal child protection card is there. If child is migrating from one place to another place, we are not able to handle, cater, capture or track those children. That was the intervention which was in the pilot in 2023, since 2023, and last year Honorable Prime Minister have launched the UWIN. Then is improved and inclusive micro planning. I think micro planning need to be updated maybe 3 monthly, 6 monthly, or yearly, depending time of the context in which state, district, block, or geography we are talking. Then mentoring and monitoring app. Our colleagues from different partner agency, from the government side, they are monitoring immunization in their checklist, performance, ODK tools they are using. So what I am doing is not known to the Y person or the Z person. So let us bring all those things in the mentoring and monitoring app, so that everybody is knowing who has monitored what. There is no duplication of work for that. Then civil society engagement, those hard to reach area, vaccine avoidance behavior. People, they are not coming forward. They don't know the importance of vaccine. They say, I'm okay. My mother hasn't received, my mother-in-law has not received. She is okay. So what is the importance of vaccine? The causes can be many, and how to capture and handle those. Then is the rapid immunization for skill enhancement. Now in the COVID time, we have seen that we were having no physical meetings during that time. We have observed that if we create a IT platform where our healthcare worker, vaccinator, they have a modular kind of a training which is available at their mobile set itself, or web-based or mobile-based. They can learn those new initiatives in immunization through those modules which are there, and that is an important intervention. Then institutionalizing the training. We all know every year lot many trainings under NHM or outside the NHM happening, but where is that database? Who is trained at what time, how many times, is the same person coming for the similar kind of a training, if even if they are being trained, what was the before training, what was their score after training. So these are the important. Then data analytics, community of practice actually for the demand, actually that learning from the CSOs what they have learned. Then community of COP will just analyze those data, and that will help us to bring those bottlenecks. Then behavior of social drivers, behavior of people, behavior of community, caregivers. I think we need to analyze why the children, they are not moving forward, or the caregiver is not moving forward for the vaccination, even they are having hesitancy. So these are few intervention which has been devised, has been captured into a zero dose document, and which are in different phases of implementation in the country. So in this, we have covered demand side, supply side, cross-cutting barriers. We have tried to handle all those barriers with the use of IT, digitalization, use of digital IT platform at all parameters they have been captured, and we have tried to handle all these that which we have just discussed. And then capacity building, the capacity building of medical officer or healthcare workers, I think all is required. Surveillance, then it is also should be a part of our platform to handle all those things. And then community of practice and the COSO, which will be having a deliberation in coming 40 minutes, and the UWIN data analytics, which are important intervention at ours. Besides this, there is another important intervention which is in the system, is electronic vaccine intelligence network. I have told we have a more than 30,000 cold chain points in the, we are almost having 10 lakh plus immunization session every month. So where are those, how the vaccine is going, what are the temperature parameters of those ILR, deep freezers in the field. So this is an important robust platform through which each machine, ILR, deep freezer is in the periphery at the cold chain points is being digitized, where you can see what is the temperature. Every hour we can see the temperature monitoring. It is app based, it is web based, and the cold chain logistics management, which vaccine, which batch number, which syringe, which needle, which ml, how many stock is lying from a GMSD till the last mile, that is a cold chain point, and how to manage and monitor all those. That is an important cloud-based intervention, that is a EWIN. Then CoWIN, a flagship program for the country. All of us know that we have gone through a difficult phase, and then the way the country has managed the COVID actually through the CoWIN app, that is remarkable and much appreciated at all levels. Session planning, session booking, public domain, doses, who has given doses, when she has been given, how many doses. So also on the mobile database, everything is being captured, and through that learning, we have brought another platform, that is a UWIN, which we'll be discussing. Then SMS, AFI, SafeVac, all these IT interventions, they have been captured and being used with this CoWIN as well as for the UWIN. So recently in last October 2024, Honorable Prime Minister has physically inaugurated UWIN for the country, which is a largest digital platform, not in the country, we will say almost not available across the globe, who will capture this much of cohort into a mobile-based app or a web-based app in the country, and which have many features, which have many features like how many children they have registered, who is due for next, then getting an SMS at the time of registration, you get an SMS, and you have a QR based certificate being generated through the UWIN. Then you have a facility manager module, you have a due children module, you have a vaccine avoidance behavior people community which can be tagged, then you have a EFI being integrated with the UWIN. So many things they have been integrated with UWIN, and which are in different phases. So that is also an important intervention. Then we were talking about digitization of a training management information system. What was the score before starting the training, after starting the training, what is the database, how many training, all they have been just brought in one platform of immunization training management information system, which, and it has a policy level benefits, has a programmatic level benefits, so that you identify each and every person where they are and how they are being, and which training they have been utilized for that. Then key features are training schedule, HR management, batch creation, load estimation, participation training, and all those things. So they are being taken care of. Then is a RICE, which we were discussing, in which if ANM is starting a module, there are 5 modules, which module is being covered by which health vaccinator in how much time, who are lagging behind. If they are lagging behind, what are the causes? The team should integrate and have a coordination, and then even if they have completed all those 5 modules, what is the score? How much gain in knowledge has happened? The training should not be like that in a physical come, meet, eat and greet and go. Okay, what was the advantage? What was the gain? What was the knowledge translation for that training? Same in a virtual mode as well in a physical mode. So in a virtual mode, the cause of the measurement of what is the gain of that knowledge, that is being taken care by the RICE. Then we have a U-Mentor app, which will be rolled out soon, which is in a testing phase, where all monitoring of the country will be taken care in a U-Mentoring app. Then we have a digital platform. This is a master slide where this is the largest public health program. How all integration of programmatic activities, how integration of all platforms will happen in the program, starting from EVIN, ITMIS, NCCMIS, National Cold Chain Management Information System, where logistics of a cold chain which is being captured into one platform. Then we have a UVIN, then we have a RICE. Then for seamless session and vaccination monitoring services, UMentor, SafeVac, VS, the VPD surveillance information management system. The vaccine preventable diseases, their monitoring actually, their outbreaks, how many cases of DPT, pertussis, tetanus, measles, rubella happening in which area, which are in a syndromic phase, maybe a fever or rash, which are confirmed case, which are epidemiological linked, which are not epidemiological linked, which are just syndromic only, how many are lab confirmed. So all platforms, they need to be integrated at one dashboard where we can have analysis. I, as a national program manager, I should not be visiting 11 platforms to look one thing, second thing, third thing. If we integrated all these platforms at one thing that we call it a data analytics, which is a future of IT in immunization, and we call it a largest public health intervention in the country. So integrating all these dashboard at one platform, where the database will remain there at the respective backend platforms only, but the interface, the public interface, where data analytics is required for daily monitoring, like I want to see, my seniors want to see, state want to see. So those variables, as per the requirement, they can be captured in a data analytics, which will help us to for the decision making on a daily basis, weekly, monthly, and moreover, if you apply AI over all at this data analytics, the artificial intelligence, because the huge data is migrating on a daily basis from one platform to another, and seeing the quantum transactions which are happening daily in the country. If data analytics is there and we apply thereafter GPS, GIS and AI on the system, we can predict what will happen in future. In 1 month, 6 months, forecasting of vaccines, also forecasting of outbreaks, also forecasting of cases also. I think this is the future of IT in immunization. I think I break here air only, and we'll listen to all our esteemed other panelists also, how we can leverage this IT platform for future strengthening of immunization program, because more vaccines will be added, more outbreaks will happen. If more public health emergency of international concern, they may come in future, because all are vaccine preventable if they happen to be. I think how we can use that. I stop here only, and we look forward to the deliberations, and thank you very much. Thank you.
Thank you so much, sir, once again, and such a brilliant session to understand the scope and the scale of the digital health in the India's immunization program. Now, sir has set the context that we are looking forward for digitalization of the processes, not just at the time of registration or at the time of checking vaccination status or at the time of monitoring, review, but the entire demand side as well as supply side, we are looking at how digitalization can empower these systems, and that will allow us to move to our next speaker, Dr. Ranganay. UNICEF is one of the strategic partner of Ministry of Health and Family Welfare, especially when it comes to monitoring SPCC and other areas. And as Pawan sir mentioned, that we are working on approach which is called IRMMA approach: identify, reach, monitor, measure, and then advocate. Uh, from your perspective, and especially the development of U-Mentor application, how digitalization can strengthen the entire monitoring process, not just in terms of the program review, but from a program manager perspective, if we are a medical officer or if we are somebody who's there for a session site from a partner agency, how this application will be instrumental to strengthen our monitoring system. So over to you.
Thank you, Dr. Ponce. Ladies and gentlemen, thank you for this opportunity to talk about the U-Mentor application and how it's going to be used in the immunization program. Dr. Pawan has already alluded to the digital health technologies that are in the immunization program or that have been used in the immunization program, like the CoWIN, the SafeVac, even, and now the UWIN platform. And these platforms have all demonstrated how technology assists program managers to take evidence-informed decisions based on real-time data, aiming at improving the system and system quality and efficiency. The U-Mentor has three components. It is the quarterly supportive supervision plans that are developed at block, district and state levels, and it has the monitoring during the supportive supervision, and with 9 approved checklists, and also the mentoring. When the monitors go out and they supervise, support either the immunization session or the cold chain point, scores are automatically developed, generated through the system, and those scores will now give the manager an idea which ANM needs mentoring, which vaccine cold chain handler needs mentoring. So that's how it's built. And this U-Mentor platform is being developed by UNICEF under the aegis of the Ministry of Health and Family Welfare, and it aims to expand the use of technology into program monitoring and mentoring of the health workers and improved immunization services. Dr. Pawan has talked about UWIN. UWIN registers all the children and pregnant women in the country. And when the monitors go out to the field, they also have the house-to-house checklist. They go out, identify those children that have been left out, that have dropped out, or that are completely not registered. When they're identified, then linked to the micro-planning, which is now digitized as well. So we identify those children and then ensure that they are reached by the immunization program. The supervision is done by all the government officers and all the partners. In the past, every agency would go out, do their monitoring, but those results, those findings from the monitoring might not reach the planning platform because each one was working for their own hierarchy. They would send their reports through their system. But with the U-Mentor app, this will be real-time evidence at block level, district level, state level, and even at national level. Everyone will be able to see what is happening in every corner of the country regarding the immunization program. And so it goes beyond just collecting the data. It also improves the decision-making process at every administrative level. And it also addresses the challenges of data migration, or, when you are having hard copy records, it's difficult to maybe channel them to triangulate those data. But with the U-Mentor app, it's going to be very easy. And So it has monitoring checklists, monitoring tools for every field visit plan, field observations, and analytics dashboard all on a single real-time platform. And it has been designed to assess the performance of the healthcare workers at vaccination sessions and also at the vaccine stores. As I mentioned earlier, every every immunization session will be assessed. The quarterly supervisory plan aligns all the supervision in that district to ensure that every session is monitored at one time or other. But throughout the year, every session must be monitored. And those scores that are generated will now give a rise to whether to this session site needs mentoring. At the planning stage, the monitors are available, but mentors will now be chosen from skilled monitors who are able to provide on-the-job training to the ANMs and the vaccine cold chain handlers, because it's not everyone who's skilled enough to provide that training that is needed. And through this course, they can also decide whether it's just on-the-job training or whether the ANM needs to embark on the RISE modules, on training using the RISE modules that are through the, I think it's JSI. So all that is as a result of the supportive supervision that is being done through the UMentor app. And it also improves collaboration among the government and partners. 3 of the checklists monitor the state task force for immunization, state, district, and city level. So that monitoring will also give rise to the quality of the discussions that are being done at those meetings. Are they taking or looking at the information that is being generated from the field? What are they doing about it? Have they, because through the house-to-house checklist, they don't just go to monitor immunization, because a child who's deprived of immunization may be also deprived of other things like nutrition, they may be disabled. So all that information is supposed to come out through the house-to-house checklist. They also identify influencers. So when they have identified a hesitant community, that is supposed to come out via the dashboard, and they identify who can now go discuss with the influencers. What do they do to ensure that these families that are hesitant, they have been converted to accepting vaccination? So that's what is all about the UMentor. It will help identify the vaccine hesitant families, identify those children that have been missed, and if the data is triangulated with the UN, we'll know who they are, where they are, their movements, their social demographic factors, whether any of these can now be tapped on to ensure that they are converted to acceptors of the immunization program. Thank you.
Thank you so much, Dr. Ranganayak. And congratulations for designing this application in such an appropriate manner. The takeaway from this is that breaking the silos, and I completely agree that if a program monitor is going for the monitoring visit and coming back with some inputs, it should not remain with that particular monitor. It should be shared on a real-time basis with all the relevant stakeholders who are there. And sorry for that. Can you take my phone? Extremely. So yeah, we were at the monitoring aspect. So this entire UMentor concept, where the supportive supervision is getting digitalized, and not just in silos, but utilizing this across all levels is very important. And taking that and moving more towards this entire monitoring and review mechanism, we would like to move to our esteemed speaker, Dr. M.K. Agrawal. Sir, again coming back to the IRMMA framework, and sir, William J. Clinton Foundation is a partner of Ministry of Health and Family Welfare, where from your perspective, how this digitalization aspect, which Pawan sir has talked about, and the review mechanism strengthening is very important. How this entire digitization and digitalization can help us in strengthening review mechanism for the program managers at the periphery level, at the block level, at the district level, state level, and at the national level also, because that is very important to capture the output indicators as well as outcome indicators. So we'd like to hear from you, sir, on this.
Thank you, Manu. I think that this is a very important panel discussion, and thanks for organizing this panel for this kind of discussion. Actually, as Pawan has talked about, Dr. Pawan has talked about, it's data forms a very important part of any intervention, basically, and data analytics and review strengthening ensures the governance and accountability function, wherein the program performance can be monitored and continuously monitored and reviewed and actions taken accordingly. And here I would also like to emphasize the Government of India's emphasis on digital health. I'm just quoting from a press release, very recent press release from Government of India, just given in January, how digital health is, importance is given to the digital health in countries' development context and especially in the health context. I just quote, India's healthcare landscape is undergoing a digital transformation driven by government initiatives, policy reforms and technological advancements. With a rapidly growing population and increasing demand for quality healthcare, digital health solutions are playing a crucial role in enhancing accessibility, affordability and efficiency. With growing investment in digital health and technological advancements, India's healthcare system is expected to evolve into a globally recognized model for digital transformation, setting benchmarks for other developing nations. This is just a quote from Government of India press release. And in this context, you should also see that when COVID pandemic was there at its peak and then COVID vaccination program was being rolled out, at that time also our Honorable Prime Minister announced that COVID is a public good, and he offered the COVID to other countries similarly placed where COVID vaccination was going to be launched. And you know that COVID was a very large, basically digital platform where the registration, scheduling and reporting happened for COVID vaccination. Now I come to the question which he's talked about, that in the context of zero dose implementation plan, how the data analytics and then review strengthening can play a role. Here I would like to quote some examples from our work in Uttar Pradesh and Bihar, where we are doing this kind of work in the field, in real situation, where we are supporting both the governments in Bihar and UP for strengthening review mechanisms around immunization as a part of broader efforts to reduce zero-dose children, as well as to tackle the issue of dropouts also. I think dropouts are also as important in the context of India's immunization as zero-dosers are, because they also form a very large part in the context of performance as far as immunization program goes in. And one of the most important shifts we have witnessed in these two states, that how digitization has helped transform the routine reviews into more structured, data-driven and action-oriented discussions. In UP, we have developed an automated Excel-based tool for RI data validation and coverage review, which is being now used across all 75 districts of the state. These tools make it easier to identify inconsistencies in HMIS data, track block-wise coverage trends, and flag districts blocks sub-center-wise discrepancies that may need urgent actions at every level or at a specific level. And you would be glad to know that at the state program manager level, all the 35,000 health facilities from where the data comes are just at the desktop of or laptop of state immunization officer, where he can see, which are color coded, where he can see which sub-center, which block is not performing. And he can pinpoint what is happening there. And he can take actions accordingly and immediately. But the real value is just not in identifying the gaps, and real value lies in uh, structured reviews and then taking actions in a time-bound manner. And it is this data which has been provided, this tool which has been provided, is enabling program managers to act on those action points. And here, that basically our digital minutes of meeting tool would play a critical role. This tool aims to help formalize action points, assign responsibilities, and ensure timely follow-up. That is decision tracker. I think digital minutes of meeting tool is being developed where action points are marked, and it has been marked whose responsibility will be there to act on those points, and what are the timelines where these actions are to be taken. This is decision tracker tool will further help to strengthen the review and to take the actions in time-bound fashion and fixing the accountability, and thus strengthening the governance mechanism and program performance also. And I would also like to talk about certain good things which has happened in Bihar also. In Bihar, integrated online portal is there as a review mechanism, which strengthens the district and block reviews across all the 38 districts. The digital platform captures monitoring findings and implementation challenges at both block and district level, enabling prompt interventions and resolution by appropriate authorities. And a key innovation of the system is automatic carryover feature, which populates unresolved issues from previous meetings on priority agenda items for subsequent discussions, so that if some action has not been taken on the previous minutes of meeting during the review, then this item will be carried over as a scheduled agenda item in the next meeting to be brought to the notice of chair of that the program manager, or who is chairing, whether district magistrate is chairing or CMO is chairing, and that feature enables that accountability feature and strengthening the program also. Another feature, which is also another digital tool which is also related to the review of immunization program, is calling monitoring initiative, which has also been sent to the Best Practices Summit of Government of India. And building on Digital Microplan Foundation, Bihar implemented a telecalling monitoring system where 14 program experts make daily calls to validate microplan implementation. Each expert makes approximately 10 calls per day, covering around 150 sessions per day and around more than 2,300 sessions monthly across all the 38 districts and 534 planning units in Bihar. And I think this generates quite a good information on monitoring and strengthens the review. And another example I would like to give for a data analytics tool, that is Looker Studio Dashboard for Priority Geographies in Bihar, where HMS data analytics across sub-center, block and district, including comparative monthly trends for different antigens, are available as dashboard, which can be monitored sitting at the desk by the program manager. And this data-driven approach allows for targeted allocation of limited monitoring and supervision resources to areas showing concerning pattern or unexpected variations. If you monitor, and then you can strengthen the supervision of that area, and it will strengthen the program further. Other digital initiatives undertaken in Bihar, though not directly related to review strengthening, but which support the zero dose agenda, are GIS-based urban mapping. We talked about IRMA, identifying and reaching the zero dose children. I think this tool, we have done a proof concept of this tool in Ward 13 of Bihar, where we have done the GIS-based mapping of one urban ward, urban city. Patna is urban area, and then Ward 13 of that urban area was mapped basically through GIS mapping tools, and where we found the missed households which were not covered in the health maps, and those were included for routine RM and CH services, where missed children were found for immunization. That is the power of this GIS mapping tool, which identifies the zero dose children and then reaching those children. Uh, that said, I think it's also important to acknowledge and that digitization comes with its own set of challenges also. I talked about all the downstream part of digital technology. Downstream part is easy to implement. You have to implement a tool. But that upstream part, which will ensure the equity in digital health and digital tool implementation, is the availability of the internet services, proper capacity building of the uh, persons who are going to use it, and logistics, proper logistics, tackling that maintenance issues of those logistics, hardware and software. That is upstream part that has to be taken care. Otherwise, there won't be any equity. You make any digital tool, it will be just a useless thing. But without these meeting these challenges, the equity cannot be met in digital tools and in implementation of any digital healthcare product. But these challenges should not deter us from pushing for innovation. In fact, they are part of the processes. And what works for us in Clinton Foundation is an iterative approach, building tools that align with the government formats, training district teams hands-on, simplifying dashboards, that is creating automatic graphs inbuilt in the Excel tool, which can be directly copied to PowerPoint presentations. That is very important. And creating buy-in by showing how these innovations actually make the work easier, not harder. At its core, digitization is not about fancy platforms. It's about helping people make better decisions and faster decisions. And when we think about IRMA framework, identify, reach, monitor, measure, and advocate, digital tools are enablers across each of these steps. Thank you. Here I stop. And
Thank you so much, sir, and congratulations for the excellent work which is happening in Uttar Pradesh and Bihar. And the take home for us is the downstream and upstream side, which is mentioned by sir and mentioned by the chairpersons also at the outset, that what all challenges which we need to keep in mind. With the permission of chairperson, I would like to ask a subsequent question to Agrawal sir. Sir, during your leadership also, different aspects were envisaged, like AFI digitalization or like NCCMIS. So how do you think, how important it is that these digital platforms are integrated, they can talk to each other, and what should be the value added? Because not just from the reviews mechanism strengthening, but also in terms of a faster information exchange processes.
I think Dr. Pawan has already talked about that integrating the platforms, various platforms, and there are so many digital tools. And as I talked about the dashboards in my during my previous discourse, I think integrated dashboard will go a long way in solving the problem of time availability with the program manager at any level, whether it is national level or state level, and he can visualize the challenges, gaps, performance, and where the actions are needed under a set of single dashboard. That is very important. You have rightly said that many digital interventions or many digital tools have been developed in last decade or so, starting with NCCMIS, National Cold Chain Management Information System, which maintains the cold chain inventory on a digital basis across all the states, including spare part inventories, etc., to maintain the cold chain in better health. And then the electronic vaccine intelligence network, which maybe you all know about that, how it manages the stocks, how it tracks the stocks, and how a cold chain handler can issue and indent the stock on a mobile app, and how the program manager can visualize all the stocks sitting at one level, and it also monitors the temperature remotely for all the cold chain equipments. You know about that. Then we had SafeVac, which is AFI surveillance app, where reporting and recording of basically all the PIR, preliminary information reports and case investigation formats are done, and which comes from block to the district, to the state level, and then to the national level, how the things are there. And this SafeWack was also embedded under CoWIN. CoWIN has also got a reporting mechanism wherein the AFIs were reported by the health workers on the app only, CoWIN app. And then now HMIS, which is there for service delivery, and UWIN system is also there now. And Dr. Pawan talked about the data from U Mentorship app, and then BSD surveys. And this data, I think, should be integrated. And here again, I would also like to quote what we have done. I think in 2 of the states where we were working, we have done some experiment with the triangulation of the data, and we found very good results. Basically, in UP, we have done the data triangulation efforts using HMIS, EWIN, UWIN, and concurrent monitoring data, which all the partners are doing concurrent monitoring, you may be knowing, and through an app. And all the 4 data are available on different dashboards, which program managers used to see. And what happened in UP was that there was review meetings of block medical officers, and where all block medical officers are called. And also, these meetings are regularly held in Uttar Pradesh, where virtual meetings, in virtual meetings, all the DOs are being addressed by Director General Family Welfare and then state immunization officers. And they wanted us to have a common dashboard, because we know that, I think we can talk it later, but data access problem are always there. But this data was provided to us by the state itself to do the triangulation, and we did the triangulation, and it had very surprising results also. How we see that HMS data, how it is discordant with concurrent monitoring data of that very block and the sub-center, even up to sub-center level, it can be seen how where the discordance was, and mainly at the block level and at the district level. And then how UWIN, we can improve the UWIN registration. HMS data is quite high, UWIN is quite a little low. Then the results were from EWIN also, where we can see vaccine consumption is there, high vaccine consumption is there, but low vaccine consumption is there. Low vaccine consumption is there, and then performance as per HMIS is quite high. We know that consumption is linked with the performance. That program manager could look at and then can seek the response why this is happening. And if HMS data is quite high consistently over the time period, over some time, and then concurrent monitoring data shows gaps, then that thing can be tackled, that you are over-reporting the data in HMIS. I think those tools are available to the data managers over there. We have developed tools and dashboards in UP which are available to state immunization officer. So we have not used this triangulation tool at the district and block level. We have not taken it down, because still this integration requires quite a lot. But I do concur with Dr. Pawan's views on this, that program managers should have basically a tool which gives you idea about everything about the program, so that a decision can be taken, timely decision can be taken to improve the immunization coverage or program coverage, and to strengthen the systems further. Thank you.
Thank you so much, sir. So we talked about equity, and sir has mentioned it very and articulated it in a very meticulous manner. And before I hand over to Dr. Pawan sir for the closing remark, I would request the inclusion part, if we can talk about it. And Dr. Ranganai, equity and inclusion, there is a hairline difference, where in equity we are ensuring that the logistics, the resources are available. But inclusion, we talk about how we can collaborate and we can ensure that each and every participant is there and each and every community member is there. With the introduction of U-Mentor, U-Win application, how do you think we can strengthen the community mobilization and strengthen the CSOs? Very quickly.
Thank you. You know, I'm very excited about the introduction of UWIN because it registers every child and reaches every pregnant woman and a child. And for UWIN, there is registration at the place of birth at the health facility, but it also gives the opportunity for the parents to self-register. And when they self-register, it means they're already aware of the need for vaccination. And when the UWIN was launched, there was also social mobilization on UWIN, and that created awareness in the community on immunization. And we need to ensure that those positive perceptions are continued and to improve the demand for immunization. A number of technologies have already been applied in India. In Maharashtra, there was the M-Mintra, which used to give or announce or give information about immunization to a pregnant woman twice a week until the child was 1 year old. And it resulted in improving the immunization coverage. It's the full immunization coverage. And in Haryana, there was also automated mobile phone informations to remind mothers to bring their child for vaccination, and that improved timely immunization. So we already have that awareness. We already know what digitalization can do. So with UWIN having the reach of all the children in the country, we can tag those families that are hesitant, and then triangulating with the information from the U-Mentor, ensure that those families are visited. We have CSOs working in the communities. They now work with the ASHA to make sure that they have gone to those families. They have enlisted the support of the influencers in that community to enable them to convert these families to vaccine acceptors. And with the U-Mentor, the managers can also identify those areas that have been left out. You know, supervisors who are most likely to go to areas that you can easily reach, that are not difficult. But with the U-Mentor, the supportive supervision plan ensures that even the rural areas are also covered. And it is in those areas that we frequently find the children that are being left out. And when that happens, the information is given to them and they're converted to immunization acceptors. So these two applications, the UWIN and the U-Mentor, they give visibility, they provide better access to and deeper insights to demand generation and operational aspects of the immunization program. When the monitor goes for supportive supervision, they're not only monitoring whether the child has been vaccinated, but they're also monitoring the quality of the session. How is the ANM talking to the mother who has brought the child for vaccination? Because one of the reasons that some mothers don't come back for immunization is the attitude of the health worker. So that would be identified, and then on-job training is given or is addressed in other areas. So because right now, the quantity of vaccination has improved in India. Maybe what is left to draw those children that are not coming for vaccination is the quality. We now need to concentrate on the quality, and having UWIN, U-Mentor, and other applications will make that possible. We have social media platforms that have been used. I can take the example of what happened during the COVID. WhatsApp messages, X, formerly Twitter, YouTube, they were all used to give information on the disease, the risk factors, the mitigation that the communities can do. The same thing can happen with the routine vaccines that were given, especially those that cause outbreaks, so that the community awareness raises and they know that they have to prevent vaccine-preventable diseases. I'm saying that I'm very excited about UWIN. In my country, we have what we call village health worker registers, where every child is recorded and they track using that register. It's a big volume. So you can imagine that poor woman having to carry that big register across the households. But with UN, it's easy, it's very light to carry, and every child is visible to the immunization program, and that is very exciting. And when the neighbors know that their neighbor is not vaccinating, they can take that opportunity to ensure that they also talk about vaccination. If all members of the communities are aware of immunization and can talk of the benefits of immunization, I think we won't have a lot of problems in future. Thank you.
Thank you so much, Dr. Rangana. This is very useful, and this has covered the overall scope of the session when we talk about equity and inclusiveness. With the approval of chairperson, we can open this floor for the question and answer. But before that, maybe I can ask some questions based on the immense learning we got. Just raise your hand. How many of you know that how to check nearby taxi or cab from your mobile application? Just raise your hand. Yeah, most of you know. And how to check nearby food store, vegetarian food, non-vegetarian from your mobile apps. Okay. And how many of you know how to check where is the nearby vaccination session happening using your mobile phone? Okay, not major difference, but what we heard using the UWIN application, just log in to uwin.mohw.gov.in. Anywhere in the country, you put the postal code, you put the blog details, the area details, and you will get to know where is the vaccination session is going on.
Talk about one intervention which we have done, I think in Madhya Pradesh. Our associate director is sitting over here from Madhya Pradesh, where in Ujjain we have done the geotagging of immunization session, and these are available at Google search, basically, in Ujjain city. And that has been done as in sort of a pilot basis and as per the requirement of the urban immunization over there.
No, thank you, sir. Thank you for that.
And that Google search can tell you about the session timings and where the session is going to be held in urban area.
And the contact details also, like whom to contact. And similarly, the way I think same kind of response we'll get, that we all know how to book a movie ticket using a Book My Show. The same way we can book an appointment for vaccination, as Dr. Pawan sir was talking about the world's largest electronic immunization registry, UWIN. So with that, we can open the floor and we can take some questions. Maybe front row, Dr. Suresh Talpat, if you would like to. Ashwini, can we have a mic?
Thank you, Abhimanyu and panel, for great discussions. And we have got improved knowledge about what is happening in country, and it may be useful for everyone. So we had shown several platforms where we are capturing data. So there is UWIN, there is EWIN, TMIS, HMIS, concurrent monitoring. And when we were doing triangulation of data in UP and Bihar, we could find that spellings in HMIS, EWIN, UWIN, and concurrent monitoring, it is different. So it took us more than 1 month to correct it manually. So is there any plan, because now supportive supervision application will be the live, and we are talking about integration and triangulation of data to make it easy. Is there any plan to clean that data at different source? This was my submission also and a question also. Thank you.
Thank you very much for important observation. I will say this is an observation, and we are well aware of this observation. Recently, last year, we have done a workshop, national workshop for all states, where we have done a data triangulation. If we say UP has a immunization coverage of 98% for first dose of measles, have 96% coverage of measles second dose, but they are having highest number of measles cases in the country. If they are conducting immunization coverage of FIC more than 100%, but VPTs they are happening in UP only. This means gap is there somewhere. And the point which you have raised is rightly said, because unless until you have a unified identifier, such kinds of problem will arise. To give a solution for that, we have a ABDM, Ayushman Bharat Digital Mission. We need to have a common identifier for the country, will be ABHA only, which will be linked with the HPR and HFR. HFR means Health Facility Registry, HPR is a Health Professional Registry. If all three parameters, they are linked together, the ABHA, HPR and HFR, you move data anywhere in the globe. You have one kind of a outcome only. But as of now, we talk about Bihar or any other state like in the Gujarat or any Tamil Nadu, they have their own platforms. They don't read with each other. Even they don't read from one district to another district. If my child from Ghaziabad goes to the Agra, then goes to the Kanpur, then to the UP, he or she is registered again and again. That can be one region. There is a reduplication and duplication of a data. That problem can be only solved then once you have a uniform identifier for that. And we have a solution for that because we want to have Abhas. Bal Abha, Child Abha, Mother Abha. And then HFR, HPR for all the health facilities. And that provision of creation of ABHA is itself in the face of a UVIN itself. So for the country in coming time, there will be unified identifier that will be ABHA only, so that this duplication of a data can be taken care of. Somebody was having question. Yes, ma'am. Yes.
Greetings all over the panelists and all over the delegates here. So let me briefly introduce that I am Dr. Vineet Kumar. I work for Government of Meghalaya as senior consultant, mostly in the domain of RM and CH, but I work in other domains as well. So my question in this discussion that pertains to like the application of AI to like how we can apply it to healthcare services. So here what I could listen was mostly it was limited to like vaccination and immunization services. But in Meghalaya we are seriously considering to the extent of like rolling out the pilot in using AI for detection of TB, using the cough patterns, and AI use of AI for anthropometry of the children. Like weight and length of the child to be decided by a video screenshot of the child, which is to be done by the ASHA or the Anganwadi. And also we are considering the use of AI for diabetic retinopathy. So these are the things which we soon plan to roll out after some deliberations. But here in this forum, I wish to ask that, is there any risk of us going ahead with such proposals and considerations, like in terms of errors or whatever other risk may be there? So that is one thing. One question is that, and another question is that what can be the other domains where we can think of using AI, particularly in northeastern states where there are hilly terrains, geographical challenges, cultural challenges, linguistic challenges, and many more challenges, right? So there are two questions, like is there any risk? And the second is, if there is no risk, then what can be the other areas where we can think of applying AI to the health solutions? So nice of you, thanks.
Thank you. May I respond to this? Or, yeah. So we have will be having a huge data in UVIN, and then the Government of India is coming with RCH 2.0. So in RCH 2, we'll be having a app-based and a web-based application where all data will be captured, and application of, once you have a database, AI application becomes very easy. We are at a first phase only. Now maturing with that data of UVIN, even UVIN will mature in 1.5 to 2 years. The child which was born last year, he will complete her or his FIC in this year, then 2 years and 5 years. One whole data is being tracked by name-based tracking is happening. Now duplication, reduplication, all things will be taken care of. Now there is if child moves from another state to another state, he needs to be registered again. So there is a reduplication of our data. We don't know the exact numbers also. So the zero dose or a continuum of a healthcare system, we need to have a IT-based common identifier so that child can be tracked in future. Not only for immunization, RCH will track and care of life course approach. newborn, becoming adolescent, then become mother, giving delivery, then immunization, then again those children. This is a life cycle approach, not only for children, for family planning services, for maternal services, for child services, for adolescent services, for nutrition services, so that life cycle approach can be applied. Now we are working in silos. We have developed a small application. We are working there only. What is the sustainability and replicability of that? Unless until we have a futuristic plan to develop those apps, and they may need to be integrated with the Government of India's app, then we will be having a solution at the national level. And whatever I urge to all, if whatever application we are developing, that needs to have ABDM compliance so that in future it can integrate with the bigger application of a Government of India, so that we can make use of all those integrated, separate, silo data, whether it's a northeastern state or any other state, because the huge platform need to be integrated with all kinds of apps, so that particularly the data can be taken care of. But your observation is very well taken. Thank you. Yes, please.
Hi, thank you so much. So my name is Arul Srinivasan, Chief Technology Officer from Kushi Baby. So we have been working on the similar platform with the Government of Rajasthan, an integrated dashboard like for various programs. So the key challenge that we are facing is mapping out the geotag health facility assets. Now, like different systems in the states itself having different level of geography hierarchies. So GIS become very challenging. So how did you solve it?
We have given solution to Government of Rajasthan. We had a meeting with Additional Secretary and the Mission Director. We have requested them to come on a UWIN actually, because they are using their own platform. So they have just started in a few states, a few districts. Now they have to come on board for all. And inclusion of HFR, Health Facility Registry. Once the HFR will come into the system, naturally GIS and GPS tracking will become easy. We have a futuristic plan also to have a GPS location of health facilities within the UWIN itself. Just like we are buying vegetables, or we have an Amazon or a Flipkart, you know the location where my product has reached. You want to call a food, you click, you put your PIN code number, you will see where is the location. Similar, that feature can be incorporated in the largest registry of the country in the UWIN itself. So that problem can be solved once all facility will come into HFR. Thank you.
Hi, good afternoon. So my questions, particularly, there was a slide that you showed in your presentation, which talked about, I think, the challenges with the detailed health systems that the government has implemented, namely that there are 10 or multiple different systems with different user password logins. Project managers are unable to try the data, harmonize it together. So that said and done, the government already has a couple unifying initiative. For example, there is Meri Pehchan, which is the national single sign-on system. We already have data.gov.in, which is a central repository for data from all ministries and states. So from your perspective, I just want to understand that what are the challenges that the central or state governments are facing in, integrating all these solutions? Where are they not able to talk to each other and integrate these solutions together for a unified solution when we already have some solutions available?
Yes, already Government of India have a solutions. We have identified the problems. We know the solutions also. We are in the process of just plugging those problems. Like just I have given an example of immunization itself, where we are having so many platforms. My healthcare worker to log into all these platforms differently. If I give them a unified logger, so in a dashboard you just enter in with one login and one password. Once you have entered into the system, you click in different platforms and you will reach to wherever you want to reach. And this is an example of immunization. But further, going further, if we come in the ABDM compliance, that can be taken for all our RCH platforms also. The Government of India is already working to integrate all platforms at one go only. Like if a child is born in a hospital, because their healthcare worker need to punch our data into RCH portal also, in UWIN also, we'll give a unified identifier and a logger and a password. If she enters, she clicks on the icon of UWIN, he will enter data in the UWIN. From that API, data will be pushed into the RCH portal. Once she just click the logo of her RCH, she will further data punching of a weight of her child, whether she or he has cried or not, when she got other things into the labor room. See, that data will be captured. So I think that part identified, solution is there, and the government is working in that process. Yes,
Thank you.
please.
Any last question? Maybe we can do. Okay, maybe
we can take from back, then,
and then front.
we'll come to you.
I'm Krisha. I'm an undergrad student at Symbiosis International. My question is that we're talking about equity and inclusivity, but there is a structural gap where, you know, teledensity in India is still very low, where BharatNet is still not reached 50% of the panchayat villages that have been promised that they would get BharatNet. So these are all the people who will inherently be excluded from using UN because they won't be able to access it. So what considerations has the government made to better improve this infrastructure?
Thank you very much for your question, and very intelligent question also. So we have a field experience of having no internet connectivity in hard to reach area, difficult areas, even in a well-to-do cities like Delhi also will not get a internet connectivity. Like in Bharat Mandap also, maybe in some corner you will not get a internet connectivity. So we in a UWIN we have made a provision of offline module also. So even if you don't have an internet connectivity, if you punch the data of a child in an offline mode, once he or she gets an internet connectivity, data will be synced into the UN database. It's the same like you are working on your WhatsApp, even your WhatsApp is not working. You have just sent a message, written a message, but it is not delivered. Once you get a connectivity, automatically the message is being delivered. So that feature, offline module, is already being incorporated in the UN, and it has been tested like in northeastern state, like Arunachal, Mizoram, where we have in Tripura, Nagaland, we have a difficulty of internet connectivity. Not in those northeastern state, we have in Odisha also, we have in Tamil Nadu also, where hard to reach tribal areas also, within the plain settings also. So that feature is already taken care of. Thank you very much for your question.
Good morning and thank you. So I just have a submission and a question. Having worked in RMN-CHA and core in the routine immunization strategy and boosting the demand generation, what is the plan ahead for digitalizing the micro plans? And also, as sir mentioned that GIS mapping of the sessions were done, this has been an intervention already implemented in few Gavi cities in Maharashtra, wherein the GIS mapping was done and it was printed and added in the micro plan itself in the digital format. So what are the thoughts of the GOI health department and the plan ahead on the micro planning aspect?
So you are aware of that, that the Gavi districts, the 143 districts in 11 states, and these are urban settings in the state of Maharashtra, the Thane, Pune, and greater area also. So that digitalization of a micro planning with an Excel sheet has started, that how many areas are there, who is a vaccinator, which are the hesitant family, who is a mobilizer there with the mobile numbers. This kind of feature has already been started, not only in the Maharashtra, it has started in the UP also, it has started in the Madhya Pradesh also, all those 11 states, wherever the districts were applicable, this has already been started. But we are in a process of maturing into that, because our UWIN is maturing with the progression of time. More database will come in a UWIN than tagging and GIS mapping. That will happen with a futuristic goal is there, and with the progression of time, it will be taken care of. Yes.
I think in Bihar also that digital microplan is available, and Bihar was one of the first state where digital microplan was implemented.
Yes,
thank you for giving the chance. So it was a wonderful panel. I work as a scientist at the Indian Institute of Science Center for Public Health, and we are initiating a program on digital health. What we see that in IISc Bangalore, a lot of startups are there in Bangalore in general who are working on digital health and AI space. But what we see is that there is a huge gap in what is the need in the public health, and the technologies that are being developed, sometimes they are useful, but the applicability is not sort of integrated in the program design. So ultimately those inventions go nowhere. The startups, after a few years, they just have to wrap up. So as an implementer, as a people who taking decisions in which kind of programs, which kind of applications innovations and technologies can be integrated, how do you see that this gap can be bridged so that more useful innovations can happen?
Yes, thank you very much for your question. And this has happening for last 1 decade. Startups, they come with small interventions, in particular block, district, and once that funding stops, they die. So my request to everybody is that in futuristic, seeing the future, because now we have a Ayushman digital mission, which have a common identifier, common variables through which the data can be integrated with all platforms. So even if you do as a small startup in particular district or state, you should be ABDM compliance so that scalability is easy, expansion is easy if the infrastructure, the structure of that database and that of an application is integrated with the Ayushman digital mission, other platform which are existing so that it can taken care of. If we'll not go by the compliance of that, this kind of a problem will arise. So our all application which we are envisaging for future, let it be a UWIN or having a RCH portal or Enmol or whatever, they all are ABDM compliance because in future we need to integrate all those applications so that databases, they talk with each other, they are searchable throughout the country. Like UWIN has a tagline, anywhere access basically, anytime access, anywhere and anytime access in 24/7 into 365 and anywhere. If child of a Tamil Nadu goes to the Bihar and Bihar child goes to the Madhya Pradesh, the child should be able, you should be able to search. But how will you search unless until we have a unifier coders for that, identifiers for that, and if the data pushing is required at the back end, the HFR should be matching with each other. All facility registry, they should be matching because if the child is being immunized, where to put in a database, that HFR, where it has happened actually vaccination. So the infrastructure, the architect of that application should be in a talkative mode with other applications. That was lacking in the past time. I think that problem is now have been identified, being solved. I think in the future we see a better version of all those applications which are applicable.
Yeah, sorry. There is a DHIS. Have you heard about under ABDM? There is a digital health incentive scheme for private institutions, private hospitals, clinics, where they are encouraged to register, as Dr. Pawan is saying, health facility registration, health professional registration, and integrating the data with ABDM systems. And for that, financial incentives are being given by Ayushman Bharat digital mission also. So that's why I think this is being encouraged by Government of India, digital health mission. I think this should be, I think people should be aware about that. That is the main thing. And last question from my side. I think it's for you and when you both. I just wanted to know, do you have any plan to just link CRS, Civil Registration System, with UWIN to strengthen the denominator platform under UWIN?
I think I'm a right person to handle this question. Many things are there at the back end which are being worked, which cannot be disclosed at this platform. But what you are thinking, sir, the government is working into that direction also. So if there are no more questions, so I can summarize what we have discussed and what we envisage for future actually, because this was a very interesting session about digitalization of tools basically we have in the largest public health program. The most important point which have emerged is about triangulation of our data. Example I have given of Bihar and other UP states and other states like Madhya Pradesh, Rajasthan, then we have Assam, the bigger states where I see most of the outbreaks like measles and rubella is there in 15 states, where the 90% of cases of measles rubella, they happen in 19 states, 15 states. And out of these 90% cases, they happen 3 or 4 states. I was looking at their immunization coverage. I was wondering that it is more than 95%, 96%. But the cases, they are also huge in those. So that kind of a data triangulation I was doing manually actually. So we are having 11 applications which are working in silos. Maybe they have been inversas being built in different time zones. So I asked my team to work with the data analytics. As a national program manager, I need one dashboard only where I can see what is the coverage, how many children they are left out, how many are dropped out, how many are zero dose, how many they have left in between. That kind of problem is solved because by name you have registered, anywhere access, anytime access, where are they are moving, you know them. If my ANM says, Saab, my bacha is not here, but I said, you check your UVIN, he must have been immunized somewhere else also. Then is a compliance of a UVIN actually. You have made a database, you have made an application, but people they are not using. Then second, my urge to all states, whenever I do a review meeting, please start using the application. Unless until you will not punch a data, then UVIN will also not mature. This problem will also be not solved for those things. Third is, whenever you do kind of a innovation in any state or a district, please do keeping in mind that that application should be scalable and should be integrated with our existing government of India's application. Otherwise, those applications will die as a natural death. Because those applications need, basically they need to be have ABDM compliance. Because once I'm having working in that area, if we are not able to scale and link with the existing system, then that will be a natural death for those applications. So we have to think in a bigger way with a bigger heart so that we are ABDM compliance and in future we can integrate all those applications. Fourth point is we have seen 11 intervention as Dr. Ranganai has told about the civil society engagement in the field. So I want that they should be working hard work with the hard work in the field so that whatever learning is coming from the CSO engagements and like WHO is doing the behavioral social driver, whatever the behavior kind of aspect is coming into the feature. All these data will be going into the COPD actually, community of practice, so that the output of one my partner agency is an input of another my partner agency, and out of second partner agency is an input of a third partner agency, so that there is an integration input output process, and so that ultimately we have a monitoring and governance mechanism at the national level, which we call the Immunization Action Group and pre-IAG. So that data will flow into IAG where the monitoring, mentoring can happen properly for all states, where all stakeholders, including state government and all partner agencies are there. I think that part can be taken care of. And alert system in UVIN actually. 3 days before, if I am due for children, then due dose. If the ASHA is having a smartphone, she can see how many children are due for coming 1 month, 15 days or 1 year. So that will help us to, this is a IT digitalization basically, which we were talking about, digitization of micro planning. In your mobile is your power. As you have a UPI system, everything is in a mobile phone only. Same with the whole of immunization, let it be an inventory, let it be a event, let it be a logistic, let it be a location, let it be a due those children, let it be a digitalization. So everything is in a mobile phone only. So if you start using those applications in letter and spirit, I think the problem of a zero dose and a dropout that can be solved out. And as Dr. M.K. sir has told about that EVIN is linked with the UVIN, SafeAct. We have talked about SafeAct also. Even the SafeAct is integrated with UVIN. In the future, people will start reporting minor AFI into UVIN itself. So we'll be having a huge database. Even the new indicators for AFI are coming for the global level. Unless now we were having a global benchmarking, global vaccine action plan where we were having minimum 10 events per 100,000 live births. Now it will be as per the million population only in the futuristic. So we need to have a database of minor, severe and serious AFI also. And all they need to be captured into the severe and serious and everything being integrated from SafeAct to the UVIN. So this is the power of a digitalization. And we empower our ASHA worker, vaccinators, medical officers, the cold chain handlers, the district immunization officers, state immunization officers. I asked my team to build an alert system also for the mission director and the secretary health also. That So many children, they are due in last 1 month, they are due for vaccination, but they have not received vaccination. If that alert goes to the mission director and the secretary health also, say they will come to know, oh, in my that particular district, so many children that are left out. So I think that is another facility which I urge my team members to incorporate as early as possible, which I am just pressing hard for that. Those so many other things are there in my mind, and the government of India is working for that. I think it was a wonderful discussion, sir. Dr. M.K. Agarwal Saab has given insightful learnings which is happening at two bigger states, the UP and Bihar. Because once UP moves, Bihar moves, country moves. If we control measles, rubella, measles in Bihar and UP, the overall numbers also decreases. So they are working in a very big dynamic districts, and Ranganai has told about U Mentor app, I think, and the CSO engagements, very important intervention, the civil society engagement and the U Mentor. So we'll work harder for that. I think we'll be able to handle all those things. And big thanks to Abhimanyu for mentoring, anchoring all those things, and arranging such a beautiful platform to discuss only IT and only IT in the immunization program. Thank you very much. I think we should wind up here only. Second session is waiting outside. Thank you very much, everybody.
Can we have a good photograph for the panel?
Yes.
Thank you, everyone. We'll get started in a minute. Yeah. Can you please?
मैंने आप पूछा था कि ये पीडीएफ है।
Thank you for your patience. The way the sessions are organized, we've got to wait for the previous session to move out and then redo the room. And you'll see this happen right after we finish. So we'll get started very, very soon. All right. Everyone can hear me? Okay, perfect. So as we're trying to get this done, I'll get started. Hi, everyone. Welcome to this much anticipated critical and timely funders roundtable, The Art of the Possible on Urban Health. We thank you all for taking the time to be here and apologize for this delay. KHPT has been planning and conceptualizing moving forward conversations in this space for quite a while now. As a public health organization working very closely with communities and the government for over 21 years, we are now able to lean on some of our experiences learned in this space, and we'd like to bring it all to you. And today, then, with committed partners, including NIMS University, who's provided us with this very important platform, and Bridgespan, our knowledge partner in this effort, and with unwavering support from our old friends at APN and DASRA, we're able to gather here with all of you. Urban health remains a daunting and vast public health area of focus, made up of complex issues demanding connections and collaborations at a multi-sectoral level. And we'll see how the intersection of various thinkers and various areas are required to even approach the complexities that urban health brings our way. There remain funding considerations in this area, perceptions of perceived unsolvability or complexity, lack of technical capabilities to demonstrate actions, and a lack of a coordinated response. But today, as a group, we've come together to explore the perspectives and insights from both private and public actors. We'll talk a little bit about your efforts to improve health outcomes among the urban vulnerable. We'll converse on how to navigate the complex nature of urban health challenges which demand collective solutions beyond any single organization's or sector's reach or capacity. And today's conversations will hopefully help us chart the discourse around a framework for decisive philanthropic action and a roadmap for moving forward. What we want to create a space for people to come together to start talking about this and moving forward, daunting as it is. I'm very happy to introduce our moderator for this session, the very wonderful Mr. Anand Bhagwati, partner at Bridgespan, to ground us further for today's conversations and introduce our speakers. Anant has been deeply committed to empowering Indian NGOs and the domestic philanthropy sector to achieve their full potential over his long career. And he continues to maintain his passion for applying corporate world skills to support philanthropists and NGOs with strategy formulation, implementation, and scaling impact. Thank you, Anant.
Great. Welcome. Welcome in this hopefully fairly engaged discussion. I'd love for this to be as conversational as possible, and for that reason, I'm also thankful to Mallika for keeping us on time. As we start off, just a couple of points on why this frame exists, right? Urban vulnerable in the context of health. A survey which was completed in December of this year with about 1,091 people belonging to urban vulnerable communities. And please think of over-indexing on informal workers, informal livelihoods, informal housing. In December, talked of extreme heat as a topic where 88% of people said we are not just feeling it, we are suffering from it, and it is getting unbearable. Now, the reasons are many. Some people because they are in external domains on a daily wage. Some people because the housings they are in, forget about air conditioning, have a tin sheet. But the reality is in December, we heard 88%. Imagine what is happening outside right now. Does this fall in the remit of the Ministry of Health? No. Because this is about livelihoods, this is about housing. Does it fall in the remit of the Ministry of Housing and Urban Affairs? Well, they're doing their stuff, but health may not fall in the remit. So whose remit does this critical topic actually fall in? So that's the reason we are here. Today, our assertion is, it is a little bit like an orphan child. It's a very, very critical topic which doesn't fall into a particular remit. So I'm thrilled to have, obviously, brilliant speakers, change makers with me. who have done things to solve for this, to start connecting the dots. But a lot more remains. And today is about hope. Today is also about thinking of practical solutions. As you do this, Sangamitra spoke about philanthropy. A question can be asked, why philanthropy? Government is there, civil society is there, why philanthropy? What we almost always find, and this is true for topics globally, the first mover always happens from someone who is putting in the seed capital. And who will put the seed capital on a topic which is not going to get you economic returns, which will be critical, but is not going to be fast? It is going to be philanthropy. So in some ways, that's why, what is the role of philanthropy in this? And please think of this as a topic which is already on us, but the solutions are not up to the same level. I also wanted to just, briefly, introduce the amazing speakers. There are a lot of people in the room, and as we do this, we hope to hear almost everyone. We have Dr. Himanshu Bhushan ji, who's basically, in some ways, been part of the public health system, being part of the change innovations, and deeply respected in thinking of what can be different. We obviously recognize that the government is going to be the prime mover in much of this. We have Dr. Sanjeev Kumar ji. In some ways, I'm from Mumbai. He, in his previous avatar, was the additional municipal commissioner. I think we owe a deep debt of gratitude to some of the health-related actions that the BMC has been able to take, and the systems of triage which exist. What are the learnings and opportunities from there in the context of the urban health? We have Dr. Ruben Swamikan, a deep expert on infectious disease control. We would love to hear about what is the art of possible from the vantage point of not just the disease itself, but also someone who's connected the dots in the past from the corporate world. We have Praveen, who really leads Wipro Cares, deeply focusing on the community aspect. None of this is going to happen if the community is not just consulted, but is in charge. It's interesting to hear that the urban health system is maybe more broken than the rural health system because we don't have the community infrastructure in place there. We will be also joined by Dr. Nidhi Pundhir, heading the global CSR at HCL Tech. It's an honor also because in some ways, deeply thinking about the role of the vulnerable communities is going to be critical. One simple data point, those who can afford air conditioning versus those who cannot will be the new, unfortunately, the new caste system in India. And imagine if that becomes true, and imagine that there are situations where a large percentage cannot afford it because of their work or their, the housing, what will happen? So, I'd love to hear more from Dr. Nidhi. And of course, Dr. Aarti Maria, who is really a practicing healthcare practitioner, but also thinking of at scale, how can care institutions actually deal with the issue. You see that there is really, in some ways, the Samaj Sarkar Bazaar triumvirate sitting in the room. This is because these issues cannot be solved by one alone. And as we go deeper into it, I'd first request Sangamitra to share a little bit of what is the frame for the discussion today, but also please, as an audience, please come in very actively on some of the Q&A which will be asked, simply because this is something where solutions don't exist, but solutions are needed urgently. Thank you.
Thank you so much, Anant. Really appreciate that context. If we can have the slides up, please, on the screen, that would be great. So Anant is very right, and I think all of us know what urban health can be imagined as and how deep and how important and how formidable it actually is. I heard yesterday at a panel that Dr. Srinath Reddy says how every minister in the cabinet is a health minister. So health does require an intersectoral focus. It's not just the health department. Everyone has to come together. And when you think about urban health and you think about the kind of complexities and the social determinants underscored by the effects of climate change. There are no climate change deniers. You have to think about climate change. You have to make your cities and your towns resilient. You have to look at adaptation, and you have to look at mitigation. That's what you need to do for climate change. And climate change affects the kind of urbanization, the rapid urbanization that's happening, the kind of migration that's happening, the kind of displacement. And within the urban system and the urban setting, there's multiple vulnerabilities then related to the kind of shifts you see. You see age shifts, you see demographic shifts, you see gender inequalities, you see the kind of migration that happens because of employment, because of marriage. And India then displays and has displayed this phenomenon of the 2, 3, 4, 5, where there's your annual growth rate, there's the urbanization growth, there's there's the megacities, and there's the rise in informal settlements where people are transient, they don't belong, they don't have agency, they don't see value, they don't demand. And I think KHPT's focus over time has always been people-centric, and that's the only way to think about urban systems resilience and urban health as well. We work from the person backwards, and then we look at all of the sectors that need to be involved in enhancing urban health. The inequities faced by the urban vulnerable are very, very stark. There's many, many documents out there with all the data that show you the kind of inequities that are faced by the urban poor, the marginalized communities, your migrant workers, people living in informal settlements, mothers and children living in informal settlements. And within that, you've got inequities that are compared to your rural counterparts and people who are wealthy in the urban focus. So you've got kind of a double whammy. There's a double burden of NCDs and your communicable diseases. The pandemic, I want to stay here for just a minute. Everyone's talked about this at different panels where you cannot forget lessons from the pandemic. We did a good job, but there was a lot of gaps highlighted that we need to learn from and we need to implement. Cities are different. You've got, as I mentioned, you've got your mega cities, you've got your middle tier cities, you've got your small tier cities based on population and the kind of people that reside in cities. And now you've got peri-urban areas and the kind of encroachment and overlap between rural and urban. So the planning that needs to happen needs to be very contextualized and very local with people participation. There are continued needs in the urban setting. There's things at the governance and policy level that need to be done. There's things that we need to do to bring the community together. And there's a focus that needs to happen, a shift in focus, perhaps from the curative to the preventive setting. And there's a lot of action that we need to bring in using technology, using digital platforms and AI that we need to look at to bring in data-driven programs and public-private partnerships and digital solutions and innovation to scale. I'll leave this up, Anant, as the discussion moves forward. With all of the needs and all of the complexities, we have put together some food for thought for everyone to just take a look at. And as you're having these conversations today, as funding organizations that are extremely committed, passionate, and want to think about this area, to see where we can focus our energies and our funding and our learnings into. KHPT again wants to bring together a committed group of stakeholders to create a space for having these conversations. And we'd welcome all of you to have these continued conversations with us. Today is not the last day that we're going to do this. So beyond the Mandapam, there's going to be a very concentrated effort to continue to bring this group together. So we'll leave this up. And as Anant leads the conversation forward, please keep coming back to this and see where we can do good things and where we can make a change. And I'll stop here and pass it on to Anant so we can have our speakers speak. Thank you.
Thank you, Sangamita. And as just a quick poll to the audience. So as you look at the slide on the screen, you see six things. I'm just going to keep, this is also maybe for those who have had lunch, a wake-up thing. Raise your hands if what you do today connects with innovation around environment and health. Raise your hand. Raise it high so that we can easily see. And I'm just someone if can just keep taking notes. So this is about 10 people. Okay. Raise your hand if you're doing something around community empowerment models. Wow, this is maybe 40. No worries. 40. Yeah. Okay. Raise your hand if you are doing something actively on partnerships around health, promotion, especially partnerships with different stakeholder groups between Samaj, Sarkar, Bazaar. Impressive. This is almost equal to the community number. This is impressive. How many of you are focused on equity-focused initiatives, specifically for the most marginalized, especially around what we talked of informality? Okay, great. So this is about maybe 15. And how many of you are involved in strategic catalytic funding, basically either unlocking or finding mechanisms to unlock newer pools of philanthropic capital? Great. So about 7. So the good news is within this group, we already have all the practitioners. The interesting news is you need all of these to happen together to essentially tackle some of the topics that you'll hear today. So, as you think about the discussion, as you listen to some of the esteemed panelists and discussion leaders, do please think of one topic. We'll come to that question at the end. One topic that you want to connect all the dots, which is relevant to you. So with that, if I could request Dr. Himanshu Bhushanji to just give your initial thoughts, please, and get us started. Thank you.
So, good afternoon, and again, thanks to KHPT and the organizers for giving me this opportunity. So, in fact, when I see the faces, I know personally that many people here in this room are, who have worked dedicatedly for various areas in the urban health, including we have the presence of Dr. Asima Bhatnagar, who is the Deputy Secretary here in the urban health in the Ministry of Health and Family Welfare. So, since I also had the opportunity of working in urban health for a very, very long time, so I will try to convey my perspective. And Sanjeev ji is here, who has both the experience of implementation as the Mission Director, National Health Mission in Maharashtra, and also, as Additional Commissioner, Brihat Mumbai Corporation. So I think his experiences also will be very, very helpful to understand the situation. So to start with, when I ask, I will be very frank enough. Now I am retired, and earlier also I will be very, very frank in my talk, and today also I will try to be more frank. First thing which comes always in my mind, although we were the people who designed the National Health Mission and everything, but whether a decision to divide urban and local was a right decision or a wrong decision. This is the first thing which comes in my mind. I am not saying that we can go back now and we can combine. It's very difficult if we cannot combine. Because what happens that, health should be one. The health plan should be one. And there should be a differential approach. It is not only the urban. Even within the urban, most focus is only to the slums. But when it comes to vulnerable, what is the definition of vulnerable? COVID has very clearly said that everybody is vulnerable. Those who are there in the multi-story building or even the 6 bedrooms with a big plot, they are also vulnerable. Should we include them as vulnerable or not? It's a big question. We have already submitted the draft, and Asima will be able to tell what is the status of that draft, where many modifications have been suggested. So, how to tackle all these things beyond slum, how to tackle even those who are there under the roof of the bridge, and so many other areas, migrants, you people know it better than what I know. So how to tackle all these things, it's a big challenge. And when we go in the implementation arm, then what we see, that program still have the stepmotherly attitude towards the urban. The same immunization officer will be more focused to the rural, everybody is covered, but when it comes to Sanjeev ji will be able to tell it better, that go and do the same thing for BMC or the Bangalore Municipal Corporation or Chennai, then probably that lack of ownership is there. How to improve that? So this again is another challenge. A structure, the institutional mechanism, both in the health department and more in the urban local bodies, that institutional structure, how to improve that. You know, while I was holding a meeting of the various stakeholders, including development partner, various states and other people, then I interacted with them when I was in NHSRC, and people were not knowing, if we talk of the health plan, how to plan for a public health surveillance, how to reduce the out-of-pocket expenses of the urban people, what are the surgical needs of the people, what are the critical needs of the people. So there are so many areas, and the most important part, whatever you do in health, you can cover only 30 to 40%. Because these people live in a very, very thickly populated state. And who are these people? Police will say, no, you cannot settle here. People will not like them to settle. Bad smell is coming. So they are ultimately cornered off. And they go to where Kude ka dher, this place, that place. And the job they get is all very, low type of jobs. And ultimately what happens? Addicts, alcohol, drug, domestic violence. How to tackle all these things? And then you have the problems of, dirty water flowing, Ganda Nala, and all those settlement problems, light, electricity. So these are the things. So in my opinion, sir, what is important is that health policies are there. This I can say. Policies are there. But the challenge is that implementation of this policy, and particularly in this context, none of the philanthropic action can help in the implementation. It's a huge one. It's a huge one. So you cannot help much in implementation. You should be a catalytic force. You try to generate evidence. You try the local, generate the research, local needs, and do advocacy so that which can be replicated by the states. So that is what I would like to say. Thank you.
Thank you, sir. Very insightful. And you said 3 or 4 things which I just want to underline and then pass it on to our next speaker. So you asked about who's the vulnerable. I think that question is so critical. And that definition might also be changing because with heat stress, with flooding, what may not have been considered vulnerable, in 10 years' time, that might become vulnerable. And again, especially, coastal regions are especially more so. You said, secondly, urban seems to have fallen a little bit, in the stepmotherly treatment category. Like, what does that mean? How does one get beyond it? Recognizing the realities. You definitely talked about sanitation, water. Many of these are not in the ambit of the health ministry. How does that get solved? And then, of course, lastly, the role for philanthropy. I think in terms of evidence building, in terms of pilots, in terms of local needs understanding, very critical. And one of the things I'd love to hear a little bit from Dr. Sanjeev Kumar as well, sir, as you speak more, is today philanthropy feels a little overwhelmed when it comes to urban health. Because in rural, there is an infrastructure and there is a delivery mechanism, that they can get behind. In livelihoods, there is the SRLM, they get behind it. So philanthropy feels if the problem is too intense and too broken, should we actually even touch that topic? Or is it something that we should wait for some time? So there is sometimes the risk of inaction. So with that, if I could bring in Dr. Sanjeev Kumar, sir, please.
Thank you for invitation, having me here and giving me the opportunity to speak. I am Dr. Sanjeev. I am basically a medical graduate, but after that I joined the civil service. And now I am not in health, I am in energy sector in Maharashtra. So, but I worked in health for some time. For 1 year or so, I was National Health Mission Director there in Maharashtra, and then in Bombay Municipal Corporation, I handled health for for slightly more than 1 year. I think it's thank you, Anant. Thank you, Himanshu. We have been, I think, interacting with him for the last many years. He came to Bombay to help us, and I have been told you only suggested my name for. I think it's an important topic, but one of my learnings in the last few years that the things which we take very casually, they have history of hundreds and thousands of years. For example, some of you are having these bindis. So this started from Indus Valley civilization. It's as old. So there is something fundamentally wrong why urban health has been neglected. There are some cultural factors that the whole system, everybody right from the very beginning was focused on rural. You know the Board committee fundamentally talked about an institutional arrangement at the village level, and urban was not discussed. Then in post-independence era, you go to Bombay, there has western suburb, eastern suburb, and the city. The city was, if you go to western suburb, for example, and talk to an, I was sitting with a politician. He said, "I'm going to Bombay." I said, "You are already in Bombay." So they think city is Bombay. So historically, that was part of the city. And you have JJ Medical College, you have KEM, you have St. George, and you have Nair. For a population of where about 25-30 lakh people are there. In western suburb now, which is roughly about 70-80 lakh, there's no medical college, there's only one Cooper Medical College. And the same is in the eastern suburb, which is roughly about 30. There's no medical college in the eastern suburb. You go to Nagpur, all your medical colleges, 2 medical colleges are 100 years old. Nashik did not have medical college. It just started now, because now of late we have decided that we should create more medical colleges. So this is what happened. That urbanization suddenly happened, and we were caught unaware. There is another problem in this, that it is not uniform. See, if my home, let's say Jammu Kashmir or some of the northern states, I will not be focusing on urban, but it is a fundamental problem, or problem of a higher proportion in states like Maharashtra, Gujarat, Tamil Nadu. And when it is, unequal, the focus is also unequal. So fundamentally it remains that we have not been able to respond to the urban challenges. There are other challenges as well. For example, you go to a rural area, your sarpanch, rich landlord, will also go to the same health wellness center or the same PSC, because there's no private institution available. Whereas in urban, there is a clear-cut dichotomy between middle class, the rich people, and people living in slums. There is a geographical isolation, there is a cultural isolation, there is a social isolation as well. There is even from people from different states in those slums. So I think when we come discuss about health, you mentioned about Srinath Reddy, that every minister is a health minister. You're absolutely right. You talk about anything right from climate change to IT to anything, that I think covers health. But then where do we start? That is the issue. So I think one important issue which has been mentioned, he started with the beginning, dichotomy between urban and rural that you created at the Government of India level. But even now, if you see, when I was National Health Mission, the urban component, urban funding in the National Health Mission is 10% at that time. Even now, I think it must be about 10-20%. So for a state like Maharashtra, which is almost 50% or more than that now urban, if you have only 10% funding, and implementation challenges are very high in urban areas because of space and other constraints. So I will say, let me ignore 10%, let me focus on 90%, because finally they will rank me and say, what are your spending? So I will focus, which is 90% rural health mission. So the first challenge, I think, that we cannot have a uniform approach when it comes to the urban health throughout the country in all states. In states like Gujarat, Maharashtra, Tamil Nadu, and where the urbanization is more, we need to spare more funds for the urban part of the National Health Mission than just the rural part. The important issue which has been, again, can I take slightly more time? Huh. So, important issue which has been mentioned, we keep talking about the vulnerable, poor, people living in slums, people having no water sanitation. But what is the learning in COVID? During COVID, there was no private sector. Everything was done by the government. Everything was done for all the people. To what extent did we succeed, or where we failed, or where we did not, we can have a separate debate on that. But because of your interventions during COVID for the whole community, you would agree that reputation of health department went up. Am I right? Now, when it comes to the complex surgeries, big operations, big medical colleges, I'm not talking about that. Let us focus on the primary promotive health care. Should we focus only on the slums, or also for the middle class, if not for the whole society? And when the people are paying taxes, is it not the responsibility of people to provide at least some primary health care to all the people in the community? And the reason is, again, very important, but this is, for example, you did not have medical colleges or big hospitals, or you had some. You go to Nagpur today, I was there during COVID, as divisional commissioner, we handled COVID. I came to know that about 250, 300 private hospitals there. So private hospitals in cities for catering to the needs of the rich and the middle class, they have filled in the gap. Now, when it comes to the primary healthcare, promotive healthcare at the community level, private sector has not been able to respond, cannot respond also at such a large scale, which is not very costly, which doesn't involve a lot of money, and people don't have that much money. That responsibility will be fundamentally taken care by the government. Of course, the private sector, philanthropy and other can support slightly, but that, I think, is the fundamental responsibility of the government. What happens when you focus only for the poor or extremely poor? I am not saying that we should not focus more on the poor, but when I focus only on the poor, then that issue gets completely neglected by the media. That issue gets completely neglected by the elected representatives. That doesn't become part of the public discussion, debate, discourse, and public narrative. So when we focus something for the whole community, then something which is being done for the middle class, for the better off, then as a result of that, it becomes an issue of discussion, and the poor people living in slums are also lifted up. So I think that is one component where, and then it's not very costly. I'll come to know, we'll discuss some of the interventions we try to do in Bombay Municipal Corporation. So I think these are some of the debates. Should we have the same funding throughout the country, in all these states, same pattern, or some more in states like Maharashtra or Gujarat, Tamil Nadu, where urbanization is more, or where the urbanization, let's say 30%, 40%, should we have a disproportionate funding? That is one. Should we intervene for all when it comes to private, primary or promotive healthcare? Good primary healthcare, for example, reduces your hospitalization by 30%. Am I wrong? Am I right? Why primary healthcare is not focused? I have thought about that issue also. All of us are responsible, including the doctors. The medical college training is all about big surgeries, big hospitals, great, and as an administrator also, it is not related with creating big infrastructure projects. It's related with creating small interventions at the community level. So all of us don't focus that much on the primary promotive healthcare. So what we try to do in Mumbai, that I went to some of our primary healthcare centers on the 8th floor. One doctor sitting, and just having, but he does have a stethoscope, but rarely you would find him checking the blood pressure of the patients coming. That is generally not checked. Only in case there is a complaint, there is an issue, then it is done. So how many patients go there? Maybe 10, 20, 25, 30 in a day. He is happy, he goes. But then when you go to slums and you find these informal service providers, those who are not doctors, those who are providing some kind of a quackery, and they are taking care of thousands of people, making thousands of rupees, and we are not intervening. Why? And why it is that? Because we have no institutional arrangement there. How to create community, how to participate people, is that we first begin by providing the services. And once you begin by providing the services, our experience is that people start asking for more. People start providing space. In a city like Mumbai, where space is a huge constraint, we found that people asking that you set up this health and wellness HBT clinics or Apla Dawakhana we started more than 200. Then we took another decision, no fee, 10 rupees I think they had earlier fee. I think it's when it comes to health services, I am of the opinion it should be completely free. If you provide me free services, I am not going to go to a hospital just to sit there and waste my time, because I have the opportunity cost of around 400 or 500 rupees as my labor cost going there. So that's what we did. Then the timing part. So we had kept timing, and we said that in case we find that patients are more than 70, 80 or 100, then we will relax the timing. We started from 8 in the morning to 10 in the evening in 2 shifts, where the workers who can go in the morning, come in the evening, or those who can come in the evening, they can be done. Just a minute. Then we recruited 7,000 ASHA workers there to provide, because one part of the health and wellness centers or community centers is the curative care. But the real challenge is about the hypertension, diabetes, mental health, and those challenges. We recruited about 7,000 ASHA workers. We gave them 7,000 BP apparatuses, started training for them that you go from be proactive, not reactive. Don't sit just in your health and wellness center and wait for patient to come. You just keep on moving from family to family, screen people for hypertension. We know there are about 32 crores people with hypertension now in India. About 25%, 30% is the community burden, and only 10% is the control rate, community control rate, which in his places like Canada, I think is more than 60%. Or in Thailand, it is 30%, more than 30%. So these are these. I think what we need to do is that we make the beginning of providing services at the community level. And my request is that let us think less about the doctors, think more about the nursing staff, the paramedical staff. They are the people who can provide these services, diagnosing people for hypertension, diagnosing people for diabetes, diagnosing people for other ailments, and then providing curative services. So I think these are some of the interventions we made. This is a big topic. There are a lot of issues involved in that but lot can be done. My experience, little experience, a lot can be done, because lot needs to be done. It is almost particularly you go to, at least Bombay has a history of the medical colleges, the health services. You go to small towns, nothing, and then there is a big gap between rural and urban, disconnect at the state level, national level, district level. That is something I think we need to, the institutional arrangement we need to correct. We need to correct the financial funding. And these are some of the many challenges, but this is an interesting area. I think we can make difference. It is not as difficult as we think. So, but we will have discussion over the next 1 hour. Thank you.
Thank you. Thank you, sir. Um, Great. So lots of cause for hope. We now want to focus a little bit about what is the role for philanthropy, and especially three topics. One is we heard a lot from, Dr. Sanjeev about the preventative and the early primary actions. It'll not be the large, sexy infrastructure. Ultimately, philanthropy can get caught up in the large buildings, etc. But this will all be small and beautiful. The second thing you spoke a lot about is diagnosis and early detection. And the third thing, of course, is there a possibility of making this where a lot of evidence can be there? Can I call on Dr. Rubin given the fact that we have three amazing people, I'd request Dr. Rubin, then Praveen, and then Dr. Nidhi Pundhir to speak about two things. One is what has been exciting, what is giving energy in what you have done in this space, and what is the challenge in doing more, especially when it comes to urban health. So if I can request Dr. Rubin to start.
Thank you. What we'll also do is, because we're running short of time as well, and as our speakers continue to talk, if everyone can just scan this QR code, because I think ideas that are generated in and as our folks are talking, please start typing up some of your thoughts. We've got very concise questions that you can respond to. So please scan this and go ahead, Dr. Rubin.
Thank you, and firstly, thanks to KHPT for having this session and inviting me here. I'll just get straight to the point and look at some of the things that are out there. One of the things that we really need to look at, and I think Dr. Sanjeev laid it out well in terms of what the challenges are. Right? And I think everyone in the room sitting here looking at urban understands these challenges, knows these challenges. Right? The challenge really is what the solutions are, right? And how can we get that going? And I think from an infectious disease perspective, if you really look at it, is how are we trying to say stop or prevent something like that from happening? Couple of things to look at. I think one is the innovation space, and I'll stay away from rural for a second. All of the innovations happening with the big bucks in the big institutions in the urban space, right? And all of them are being tried somewhere. What we'd really like to see is how do you take these innovations, and I'd urge philanthropers and funders to say, okay, it's already happening in a certain place. And I just came out of a room where they're looking at how they're able to stop the leaching of antimicrobials from a hospital setup into the sewage system and beyond, right? And so if you can do that, then all of a sudden that whole AMR is contained within the facility itself, right? And it's not going further. Right? Government of Delhi is now trying to engage in cleaning up the Yamuna, and one of the things they found is that 21 portals of entry of really bad sewage, which is totally contaminating what's happening in the Yamuna. So if you can contain it at source, and there are now innovations that are available, what we really need is how do you take the innovations to scale, right? And how do you ensure that it can be done? So rather than trying to reinvent the wheel, try to say, okay, let's get something new, right? Let's throw out another grand challenge and see what's there. Is it possible to coalesce existing ideas and then say, okay, which of this will work for me as a funder? Which of this will work for a particular city, right? And how can we take it forward? Secondly, I'll use COVID as an example because that's very stark in everyone's memory, right? Mumbai is a great example of what happened in the war rooms, right? War rooms were able to connect where the ambulance should go, which hospital has a bed, right? Also, which cemeteries or which crematoriums are available, right, to move patients out of the hospital. It was brilliant, right? But to take it a step further, Chennai also developed war rooms, but today Chennai is using those war rooms to cater to support people who are having road traffic accidents, so that the war room is not dismantled altogether, but can be bought back in case we have another COVID or a COVID-like situation. So I think how do you then develop these kind of scenarios for various cities to be able to actually engage in the process and ensure that it continues to be there. So I think looking at it from a perspective of innovation, one, two, using existing infrastructure to better it,
or to repurpose it for whatever we need now is a far more faster and probably cheaper way of using what can be done. One last example, in terms of during COVID, again, and beyond, if you look at the Ayushman Arogya Mandirs that have been set up, right? There was always talk that we need to get to the last mile. We need to be able to help those people access services, right? And so how it was then set up. 150,000 facilities that today are being manned by community health officers, trained people, right, who have the capacity to do that. We're talking about teleradiology that can be used, all right? So again, technology, how do you use that? You're able to ensure that people at the last mile can access drugs. And for those, who it might it be a surprise that other than paracetamol, the next drug available is an antihypertensive at all such peripheral institutions, right? So you're actually able to reach that last mile to be able to provide services at that particular session. So I think what is key is how do you coalesce all of this? While we look at the problems and they're so stark and they're so large and it seems undoable, but I think now Dr. Sanjeev laid out many solutions that are possible. So I think these small drops really tend to make up the big ocean. Thanks.
Thank you. That's exciting. I mean, you spoke about not reinventing the wheel, but backing promising innovations. Can I call on two speakers before we go to a last speaker to wind up? I think Praveen, if I could, and then Nidhi, do you have a mic? Yeah. And really two practical ideas you feel which can be done by funders, philanthropists in this space, especially when it connects also with the government. Over to you.
Ideas comes based on how we approach and how we try to handle it. Even though we say that at large our focus is on maternal and child health, I think I'm audible. Oh, okay. So I'll use this. Okay. Yeah, thank you. See, we know that there are a lot of determinants, and even when we focus on maternal and child health, we know that now mental health is an issue. So we have entered into a mental health issue. And again, mental health due to climate change issues, how we can handle that. And when we achieve a certain milestones, how we can further improve and what are the obstacles for it. For example, it might be related to wash related, as you had mentioned. So we enter into those areas also. We take a small pocket and we look at how we can actually get deeper into it and see to it that we can actually look at improving their health. So from that perspective, it might be even implementing rainwater harvesting and providing water to the school toilets, because those are the things which actually will have an impact. We also looked at what we can do in climate health. And let me tell you, it's something which we are struggling, because even our partners are also not able to come up with right ideas. Some of the NGOs which are coming, they purely come from a climate change angle, not from a health angle. And even when we want to implement something for the community, especially in the urban slums, it's not it's very difficult. It's too far to imagine. Maybe we can actually, the solutions which comes is, why can't you have a cooler roof for the community space or for a school? But we do not have a solution to implement it at large for the larger community. So these challenges do exist, but at the same time, as a funder, I know that we need to also have patience. We need to actually look at investing in some of the innovative ideas itself. We need to encourage in actually having sessions which leads to brainstorming and which leads at creating the solutions. I think as funders, we should not look at waiting to see that someone will come out with a solution and then fund. Maybe we have to look at actually funding for creating those solutions itself.
Yeah, thank you, Praveen. That's a breath of fresh air. And in some ways, you also spoke about such an important topic because ultimately the community side of the innovation is missing sometimes. Dr. Nidhi, if I could request you to bring us to like what would be one or two practical solutions which funders could actually get started with. Can I speak from there? Yeah, go ahead. No, no, I understand.
No, thank you. First of all, I think it's amazing that we are discussing this topic separately, urban health, because as erstwhile speakers said, that we kind of lose if we discuss health as one topic. One part where I would really want to draw attention of many donors sitting here is that the shape and size of India is changing. When we say urban, we are just not talking about maybe from the previous censuses just 20%, or it's going to be increasingly 40% plus urban or peri-urban. That's the scale we are talking about, maybe 50%. And now when we travel to rural areas, they're no longer same rural as we used to be thinking, or urban, same urban as we kind of think about them. So there are these pockets. So from HCL Foundation, we took a very, very systematic approach towards it. We completely divided a rural and urban portfolio. And when we did our needs assessment, we were quite clear as to what exactly and how we want to go about urban. See, one, we really need to understand the shape and size of the problem in urban. It's very different. We are talking about migrant population. We are talking about ultra-urban poor. We are also talking about common people like ourselves who live in a very dispersed kind of a setup where at times for you to find one medical doctor can be equally a problem as much as for the rural person out there. So I think this whole thing about access, accountability is very, very different when it comes to an urban setup, and that I think for CSRs, for any donors who are trying to fund, is critical. The other strategy, which is very, very different from working in a fixed rural community where you have the population static, you can find the person when you go there. In migrant is you will not find them all the time when you go there, because most of them are domestic helps, rickshaw pullers, working in industry and so on and so forth, and they are not living with the larger. So that household approach which we take as public health practitioners fails completely in the urban health. Another thing is it has to be a very, very fast moving strategy. If we have found our beneficiary, be it nutrition program, be it immunization program, be it anemia program, to be with the person, to be with the program participant, to fast track. And I think that has given us some very good results, I would say. I just want to quote the data out here, and you were talking about strategies that have worked. What has really worked is to be with them. Once we've identified them, use technology, use some kind of they have phones. I think one thing that works is you can actually get them on some kind of a phone, because that's how their rosy roti works, in the urban area. So when we started and we just picked up, one clear issue of recruiting eligible couples into our family planning program, because population is an issue in a lot of pockets where we work, and we continued to work with them, and that's when we've had like almost 66.7%, and we are working in 9 cities in more than 170 slum pockets, adopt modern methods of family planning. Now, what is that does? That actually stops them from getting into the poverty cycle, which would have happened otherwise. Spacing methods. Similarly, anemia, once we've identified, we need to start treating them immediately. So 99% of our people who we are working on anemia, be it adolescent girls, be it so school-based approach, community-based approach, household-based, but don't lose track of, as if they are your own family members, work with them so closely. So I think what has helped, how this has happened, I mean, that's again 99% of them have come out of acute anemia, is system strengthening approach. We've never worked without tri-party partnerships. Government is on board, for sure. Urban, we just cannot work parallelly, because if you start supplying modern methods of contraception, you are actually trying to do the job that government should be doing. So source them from there. But outreach is where usually government has an issue, putting right kind of health camps at the right kind of place. The other part where I think your challenges question is this population, which I did say moves very fast. You lose them quite quickly. The other problem is that the PHC's outreach and all, if we are thinking that with the same rural method we'll be able to, it completely needs a very, very different kind of approach and accountability. So I think in modern India, and India which is fast becoming rural to urban, technology we cannot undermine. I think today morning we were talking about, I wish we could have like a geotagging of all our participants, that even if they migrate from Bihar to Noida and from Noida back to and then West Bengal and all, let's not lose touch with that. So just I'll end on the last data. During COVID times, when and I'm so happy to see a lot of our partners are here in the room without whom we cannot just function. All our partners had MIS to the extent that we were actually in touch with 80+% of our program beneficiaries. So if the mother was pregnant when she was in, let's say, slums of Chennai, and if they did travel back, if they had to, we will still be able to ensure that there was an institutional birth. So 90% plus institutional births or 95% have been ensured. So I'll just sum up saying that urban is a very challenging space. If as donors we commit to it, design thinking can be in-house, but the way we disperse, the way we have our partners, much higher level of commitment would be needed in order for us to not lose the investment that is being made. Of course, rural is equally challenging, but the design has to be very different of the program is what I want to say. Thank you so much.
Thank you. I think I'd like to speak from the experience I have had in Girl Effect and in other organizations where mostly I've worked on urban health challenges. Whether it was TB, whether it was family planning, whether it was WASH. I'm fortunate that my 20 plus years of experience is actually urban health and not rural health in a way. So I think the two things that I want to say really, and I'd like my, I think after me you can take it. Yeah. So I think I'd just like to say two things. One, right now I'm working with adolescent girls and young women. I think the challenges that we've seen for adolescent girls and women in the urban space are as many as we see in rural spaces. Plus, I think interestingly, when you started the dialogue, you said something about public health challenges. I think they are, they're uniform across population. I mean, now if you look at immunization, it's uniform. It's everybody should be, vaccinated. If you talk about dengue, everybody is suffering from dengue. If you talk about TB, anybody can have TB. WASH is a challenge because, anybody can face a problem. Like you go to a market and there is not a single, you can't visit a loo which is clean. So anybody, I think all of us are equally, I think that's one thing that we've learned. Second thing, from our own work of community engagement with, young people really has taught us is that I think the phone and the internet and AI are game changers. If we're not talking about those and utilizing that in today's world, then we are going to be left behind. We have seen that a digital health initiative has the potential of reaching 23 million plus adolescent girls and women across, let's say, a northern India belt of around 11 states. We have seen that when we introduce a chatbot, which is AI enabled and allows girls to converse with, a bot seeking advice on things that they don't want to talk about to other people, to maybe an usher, to maybe their mother, to maybe their friend, they can get information that is useful. I've been part of a gaming initiative, which actually uses games to tell young boys and girls about behavior change, about contraception, about consent. So I'm just saying that there are innovations out there, and I'd like to repeat what Ruben said. There are lots of innovations out there. I think from a funder landscape, what we are really looking for is, one, more funding for these innovations to scale. I think that would be really good. We don't have to reinvent the wheel. Two, I think definitely with 50% population shifting to urban and climate change being such a huge problem, I feel the funding has to move to urban health. It cannot stay stuck in, rural health. So that's my closing this thing, that the funding has to move to urban health,
That's okay. I think the time is up.
access to gene therapy in the Global South. I'm Ben Johnson. I'm chief editor of a new journal from the Nature portfolio, which is called Nature Health. So our submission system and website went live just 2 weeks ago. So you're amongst the first in the world to hear about this new journal. And this will sit alongside Nature and Nature Medicine. And our goal is to publish the most impactful research in public, global and population health. And really the vision behind Nature Health is that good health requires more than medicine. It requires research in economics, in the social sciences, in environmental sciences, investments in education, in tackling poverty, and in all the social determinants of health. And so our goal is to publish research from across the biomedical, social, and environmental sciences. And I'm delighted to host this panel on gene therapy because in many ways gene therapy, gene and cell therapy is an exemplar of the non-biomedical barriers in health. And what I mean by that is that science has essentially solved many of the problems of how to develop a cure for a genetic disease or a genetic-based treatment for cancer. And the panel have done a lot to advance this field. But the barriers still exist. And those barriers are more, they're logistical, or they're financial, or they're political, or they're cultural, or they're social. And if you just take sickle cell disease, for example, of the 7 million people in the world with sickle cell disease, a large portion of whom are in India, only a tiny fraction would be able to receive the current gene therapy treatments, which have a $1 million price tag. So the challenge of how to develop these gene therapies, gene and cell therapies, has been solved. But what's not yet been solved, although potential solutions exist that our panel will discuss, is how to pay for them and how to deliver them at a low enough cost that people can afford. So this is the panel for today's discussion. I'm going to introduce our world-leading panel who really have been advancing the field of gene and cell therapies. We'll then have a talk from Dr. Borodropoulic, one of our panelists, and then we'll move on to the panel discussion, and there will be time for questions. So please do think of your questions as you're going along, and then there'll be an opportunity to ask those to a panel. So I'm going to introduce each of our speakers, starting with Dr. Borodropoulic, who has been a gene therapy pioneer since the 1980s, has worked in academia and industry, and now at a non-profit, including founding Lentigen, which made the first, the lentiviral vector for Chimera, which was the first FDA-approved gene therapy. So he's had a very distinguished career in gene therapy, originally starting as a virologist, and he's now co-founder and executive director of Caring Cross, a non-profit that seeks to support the affordability and accessibility of gene therapy products. If I have a round of applause for our first panelist. And joining on the panel is Dr. Indu Mariappan, who is a leading researcher in retinal and corneal diseases at the LV Prasad Eye Clinic, and is exploring how patient-specific induced pluripotent stem cells and genome editing can develop treatments for eye diseases, and is very focused on engagement and involvement of communities in that pioneering research. So a round of applause for Dr. Indu. We also have Dr. Debo Chakraborty, who is a principal scientist at the CSIR Institute of Genomics and Integrative Biology here in New Delhi. He's an expert in gene editing using CRISPR and leads a trial for sickle cell anemia in the tribal populations in India, working with the Ministry of Tribal Affairs here in India, and aiming to make a low-cost cure for this and other illnesses. So a round of applause for Dr. Debo. And then our final panelist, Dr. Atharva Karolkar, who is a co-founder of ImmunoAct and a co-inventor of the first Indian CAR T cell therapy for cancer. This is the first CAR T cell therapy to treat leukemia and lymphoma developed in India using Indian intellectual property. And this occasion was marked last year by the Honourable President of India, who dedicated this CAR T cell therapy to the nation. So a round of applause for our final panelist. And we'll now have a talk from Dr. Borojopolic.
Thank you, Ben, the organisers, for the opportunity to share our vision and to really set the sort of stage of some of the things that we really need to think about when we're thinking about these cell and gene therapies. If I could have the, okay, I can do it from here. Fantastic. Yeah, so Caring Cross is a non-profit, and our focus is enabling affordable and accessible cellular gene therapies. This first slide just shows you the potential and the clinical approval and regulatory approval, at least in the United States, of many of these CAR T-cell therapies that are on the left and stem cell gene therapies on the right. Many on the left are treating and curing diseases like leukemia, lymphoma, multiple myeloma, and on the right, genetic diseases like sickle cell, beta thalassemia, and other genetic diseases. These therapies are personalized. What that means is you're taking cells out from a patient and then putting them back in, right? These are the therapies that work very, very well. On the left there, you can see cells from a patient that can be either a T cell or a stem cell. Then you add a vector, that's that thing with a packaged with a DNA inside of it that adds the gene to the cells, genetically modifies the cells, and then those modified cells are then infused back into the patient. So for CAR T, you can see on the right there that you have a T cell and you add the CAR molecules, and those CAR molecules give those T cells the ability to find, hunt, and kill cancer cells and then kill them on the right. But their price is extraordinarily high and really not sustainable and restricts access. On the left there, you'll see Kymriah. Just the product itself costs $475,000 for the therapy, right? This doesn't include any of the patient care at all. And on the right, if you go to the far right, Lyfgenia, which is a treatment for sickle cell disease, $3.1 million just for the product. Very few places, even in high-income countries, it's really not sustainable. And it's not feasible in low middle income countries, and it really restricts access, particularly for underserved populations, no matter where you are in the world. And the next data set will prove that if you look in the US, only 25% of patients eligible for CAR T get it. 75% don't. And in low middle income countries, it's less than 1%. And yet these therapies are curative. They don't have to cost so much. How can we make them more affordable and accessible? So the way that we think about this to improve access, we think of them in 4 columns here. Technology improvement. A lot of the technologies that are being used now for the commercial products is technology that was invented like 20 years ago. We can improve. We can improve the cost of vector, for instance, to lower the price. Vector is the critical reagent. It's the most costly part of the process. If we lower the cost of that, we're lowering the cost of the entire product. In the second column is you see short and simple manufacturing. Sometimes we over-invent and make things too complicated. And when you make things very complicated, they cost so much. So what we've done is gone back and tried to see how we can simplify each unit operation and how to really reduce the cost, because that supports scalability of these personalized medicines. On the third column, we focus and support local manufacturing, democratizing this technology so it's made either locally, regionally, or even within the hospitals, because that's more efficient. When you make a drug, you get scalability in a large plant. The bigger the plant, you can make the drug and send it out, and all you're doing is injecting it. But when you're taking cells from a patient, reprogramming them, putting them back in, the economics are very, very different, right? And it's better to make them locally, like bone marrow transplantation in that sort of a model. So that's why we focus really on point of care or regional distribution of these products. And then finally on the right is technology transfer. The only way we're going to get lower prices if we technology transfer to lower middle income countries so they can use their local skilled labor to manufacture the products, because a big part of the cost is the labor. right? So if you make the vector with local labor, you're going to decrease the vector cost. If you make the cells with local labor, you're going to decrease the cell manufacturing cost. That's how we're going to really reduce the cost and make this affordable and sustainable. This is just some publications that we've done in the past. On the left there, you can see that what we've shown that when you make it locally, in that case it was in Cleveland, Ohio and Moscow, Russia, you can actually make a highly similar product in multiple places. There's no problem in doing that. And on the bottom there, in the middle, right in the middle, you can see a patient with follicular lymphoma before and after CAR therapy. Look at those tumors are in the white, and this is and it's completely regressed in the patient after 90 days. This is the kind of curative therapy that these therapies afford for these patients. And on the right here, my colleagues in Spain have already created this decentralized model. In Spain, there are 10 different sites manufacturing these products locally, safely and reimbursable by the Spanish National Health System. So this is all possible. You can make these products locally, reproducibly, and safely for patients. Now, when you manufacture these products, you need a clean room, right? A GMP facility. Now, on the left there, you can use either a facility from a hospital, but if a hospital doesn't have such a facility, you can have these mobile clean room units. We're collaborating with a company in which you can put these units in a hospital, on a parking lot. All you need is power, the internet, and you can produce CAR T-cell products right there and then. You don't need to create large infrastructure necessarily. And one of these units are very, very small. I'm not going to go. It's only 700 square feet in size, yet such a unit can produce on a single shift 250 products a year. Now, for any medical center, there are no more than 250 leukemias and lymphomas in one hospital. That's more than enough to take care for a single product. But the scalability is even more. This is just a single shift. But because of the methods that we've made are very economical, actually, you can use a single facility to make up to 2,000 products a year on multiple shifts. So the scalability is enormous, even with a small facility. So remember, the more products you produce in a set facility, your unit cost goes down because your facility and labor costs are relatively fixed. And so this is the ecosystem of things that we need to think about. We need to think about, on the left, the manufacturing innovation. On the right, the clinical candidates themselves. And on the bottom, the supporting systems, the clinical development and moving into commercialization of these products. Making the products in a very simple way is very important. We can use either apheresis or blood. Being able to have blood as a primary product is important because many places around the world don't have a lot of apheresis machines. So we wanted to create a process that's very simple that you could use for apheresis product or for blood. I'm not going to go into it, but it's a very simple process where the total material cost of this process is $20,000 per dose. Right? That is a big difference than $400,000 for the total cost. So if you layer on top here in India, labor and facility costs, you can be in that $30,000 range to produce these products, right? And remember, these are single living medicines. You don't add these medicines once a year. These cells last for the life of the patient, right? So it can be very durable therapy. So for vector manufacturing, we couldn't rely on a third party to make vector. So we had a company, a public benefit corporation that makes the vector. And we're located just outside of Washington, D.C. We have a very efficient process. This just shows you how efficient this process is. On the left, you'll see the harvest in the 10 to the 8. Many other companies would be happy that that's a final titer. Right? We get it in the harvest. So it means we don't have to concentrate as much. We get higher yields and we get high 10 to the 9s. This is the best process in the business, I can tell you that right now. And it's based on our team that has been doing this for 20 to 30 years. I'm going to skip over a couple of slides and just go straight to a strategic collaboration in Brazil. This is live evidence on how we tech transfer. So we're collaborating with an organization called Fiocruz, which is the large biologics manufacturing organization that's supported by the Ministry of Health in Brazil, that we are giving to them the vector manufacturing, the cell manufacturing, the plasma, everything so they can manufacture things locally so they can produce it there for an all-inclusive cost of about $35,000 a dose and make it available to the Brazilian public for little or no cost at all because they have a national health system. And I was there about a year ago and the minister had some very nice things to say about our project. For them to be able to import these technologies and make it locally is critically key for them. And we are on track in terms of our delivery times. We also have a strategic collaboration in Turkey with the Koç Healthcare Group. The Koç Group as a group contributes to 8% of the entire Turkish GDP. So it's a very large group, can move things very, very quickly. And their health system, we have an exclusive partnership with their hospital network to produce locally the CAR therapy. We have a similar now with a group in the UAE, Burjeel Holdings. And here in India, we have multiple partnerships, including my colleagues here at ImmunoAct, but we have a much more of a decentralized a way of distributing the technology here in India, because India is a very large country, right? There's no need to go into one organization. And so we have a pipeline of candidates. I'm not going to go into details. We have a triple CAR, a sickle cell beta thalassemia for multiple myeloma, a very interesting results with an anti-HIV CAR. And why am I so excited about this therapy? It's very different than drug therapy. Drug therapy is like panning for gold. You get lucky or you could fail, even in a mature clinical trial. But this is engineering. We already got a baseline that works. And we're just going to get better and better. It's like we're at the time of the Wright brothers, and it's just going to get making better and better therapies and curative therapies for the people that need them. And we have the whole of nature as a genetic toolbox in order to use to make these therapies better. I just want to acknowledge our many collaborators and just to say this is what is very important, that we think of the patient, that independent of life circumstances, everybody should get access to these kind of therapies. Thank you very much for your time.
Thank you, Baro. That was great. So maybe if we continue thinking about CAR T cell therapy, so this is a revolutionary treatment for cancer, particularly lymphoma and leukemia. And now in India, there is a indigenous CAR T made by the scientists at ImmunoAct. So maybe I can start with you, Dr. Athava, to tell us a little bit more about the CAR T that you developed and thinking about the focus of this talk, which is how to make them affordable. How affordable is it? How widely available is it? And what more should be done or could be done to reduce the cost further?
So I would like to first thank you for calling us here and to have such a cozy panel. I think it makes a lot of difference when so many people contribute to this story. And I would like to start by saying that affordability is a very subjective term, right? So all the 5 people sitting here in the panel may think of affordability in a very different way. Something which is affordable to me may not be affordable to some of you, and vice versa, right? So our idea when we started with this work was that can we bring it at a cost which is the same cost of the standard of care, which was stem cell transplant in India. So the stem cell transplant costs somewhere around $10,000 to $20,000 based on what type of stem cell transplants you do and in which centers you do in India, or even above that. So that was the price point which we are looking at. So typically we had to bring down the cost from $400,000 to $10,000, and we were successfully able to bring it down to $30,000. So still there's a lot of gap which we still yet to bridge. But at least with the effort which we have done, we have been able to bring it down by 90% of what the cost was there in the United States. At the same time, the entire cost reduction happened because of the indigenization of the technology. There was a local manufacturing effort which was taken into place. So like Dr. Boro highlighted, the vector is a key bottleneck when it comes to cost, right? The IP is a key bottleneck when it comes to cost. So in our case, what we did is that we developed the entire project ground up. So right from designing of the car, made IP over it, made the vector development process, the plasmid development process, the CAR T development process. And while we were doing it in India, we also had a limit as to how much resource or funding we have for this process development. So the process which came out of this entire effort of almost 10 years was the process which was cost effective, because that was the because the funding was limited in the country like an LMIC like India. The process which came out of this country was also a cost-effective process. And we give an example in a lot of talks, like India is famous for such type of innovations. You have seen like the Mars rover, right? So like he was highlighting about the Boeing. So if you see the Mars rover was done in India successfully at 1/10 of the cost what took it to make the Gravity movie in Hollywood, right? So India is known for such examples, and not just in technology like space, but in medicine also. When the bone marrow transplant was done in the United States in 1990s, it was again of a similar cost, like $100,000. But today you see bone marrow transplants in India are $25,000 in cost. So India definitely has that advantage, or I would say all the LMICs have that advantage of bringing in cost down for the for the cell and gene therapies. That is one approach. And what it helps is that it helped us in creating an entire ecosystem. So right from the innovation, so because of the innovation, we had to develop the entire science and technology, the technology know-how behind this. So it created a foundation for the new cell and gene therapies in the country now. It helped the clinicians get a hands on the therapy. So they have now got a training of the nurses, the healthcare professionals, so ecosystem at the hospital. The government agencies, regulatory agencies, the funding agencies have also now understood the need of such therapies in the country. And I think there's a lot of support coming from there. So I think as a whole, this entire ecosystem which got built around this CAR T cell therapy, the first CAR T cell therapy in India, I think has created a foundation where India can become a mainstream country in cell and gene therapy around the world.
Wonderful, thank you. And obviously, if we're thinking of gene and cell therapies, there's a whole variety of different types of different conditions. Maybe we can turn to you, Dr. Indu, to tell us about your area of expertise of eye disease and how gene and cell therapies could be a treatment, and how do you get to an affordable product for these conditions?
Yeah, so affordability, as both of them, the previous speakers have said, local manufacturing is the key, and you need indigenous technologies, and more such players have to come into the field, and that's what would make it work and make it affordable. But coming to the first question as to why the need and what is the need and demand, so I'll just give you an example. I work at an eye hospital, and if I have to give an example of an eye disease prevalence in the country, say retinal condition, just one tissue condition, 1 in 4,000, which easily translates to about 200,000 people in the country. And putting together a variety of inherited conditions affecting different tissue types, you have 200 million people in the country, which is 1/3 of the global burden, sitting in here in India, waiting for such therapies to come. And if you have to make it affordable, we really have to develop our own technologies. And LVP has started its investment in stem cell therapy for corneal surface reconstruction using autologous limbal stem cell derived transplants. This was a technology developed initially, been reported by people in the Japan and Italy to begin with, and there are commercial products which cost some 100 times. There is a commercial product available. But when we developed it with our own indigenous methods, adapted the technology, and had our own GMP facility, now the product can be delivered to the patients. Similar product, which is just a skin graft, similar to a skin graft, it is a corneal surface graft. You can provide it at anywhere between 50,000 to 1 lakh at a nominal price. Even if you add a lot of other costs, now with GMP requirement coming in, it may not exceed 5 lakhs. So that is what, that made it accessible. Now we have treated over 800 patients so far at the center over the years, in 10 years' time, which is the biggest number anywhere in the country, because it was accessible to the patients at an affordable price. Right? So the patients are there, so you just have to figure out a way how we can deliver it in a better way.
And can I ask a follow-up? Because I know the clinics you work for have a very have this pyramid structure we were talking about earlier, where you have very grassroots engagement. How important is it to engage with communities when you're developing a very high-tech treatment like gene therapy?
So when you're looking at a high-tech, intensive treatment modalities, you also need to know who are the recipients, who are the end beneficiaries here, right? So in our country, for any gene therapy, forget about eye conditions, even any genetic conditions, the awareness is the biggest problem. People don't even know that the problem that they're dealing with is because of an inherited condition, even if they say my parents, elders, and everybody were affected, but still they don't realize that it is an inherited condition. That's where learning and public work is important. You really have to work with the community, educate them, and see. And rather than thinking about how to deal with the condition after the disease is manifested, which we are talking about in terms of cell and gene therapy. So that is where the grassroots level working is very important. And also to understand the prevalence, what is the prevalence for a condition and how many people are going to benefit out of this therapy, that is going to interest the pharma partners who would eventually partner with us when we are developing a therapy for large scale manufacturing, because they would look for how many patients will benefit out of that product that they're going to bring out. So that's also is equally important. So that's where your grassroots working at people at the village level and tribal communities are all very important, and working with the patient groups. Again, patient groups are not very strong in the country. They're very small number of patient groups. We really have to engage. If you are thinking about translating these therapies, we really have to engage closely with the patient communities. So, and even when the therapy is ready and available and you're ready to develop and you have to start a phase 1 trial to recruit these patients, somebody have to communicate with these patients, right? To convince them these are well-tested therapies that they are going to benefit, for which you need a good counselors and patient group communities that you need to really work with them to take it to the doorstep.
Great, thank you. And we've covered cancer and we've covered eye diseases, so we can move on to sickle cell disease. Dr. Debo Chakraborty, perhaps you can tell us about how important it is that we get a gene therapy for sickle cell disease available to the people in India.
Yeah. Thanks, Ben. Yeah, like you rightly said in the beginning, that India is home to the second largest number of sickle cell patients, a very high number of beta thal patients across the world. Oftentimes we get to hear that the Indian sickle is a bit mild, which is not really true, because that's a misconception, knowing that the fetal hemoglobin levels are typically very high in Indian sickle patients. So the diversity of and the complexity of the disease in India is very different from the African American population, which means that traditional ways such as fetal hemoglobin upregulation and things might or might not work. So there is a need to not only understand the dynamics of the disease, but also what is the genomic, the determinants for this disease. That makes it a bit complicated also. What also makes it very complicated is that the standard mechanism of care for sickle cell patients in India, which is hydroxyurea, is also not something which is often achievable by all these patients. They come from the poorest of poor places in the country, which are tribal belts across almost the entire middle India, starting from the northeast all the way up to Gujarat, with more prevalence in Maharashtra, Madhya Pradesh, Chhattisgarh, Orissa, and so on. So they are rampant everywhere. And they are, like I said, they're really the poorest of the poor. They live sometimes in the hills, in the jungles, and places like that. And when we ask doctors there that what is the oldest patient who comes to you, they say it's around 35, 40. So that's how long they live, and oftentimes they die in their teens and so on. So it was important. Fortunately for sickle, this was something that was a priority item for the government of India. So at a very early time point in 2015-16, when our Prime Minister visited Japan, and he was told about the iPSC-based therapies and coming on. So he had launched something called CSIR Sickle Cell Mission. So CSIR is Council for Scientific and Industrial Research, which we are a part of. And a large focus of that mission in the initial years was to see if you can develop such kind of gene therapies, which was not even existing in the West as well. In fact, the FDA approval came only in 2023. So this, I'm talking about 2016. So they gave us money to work on developing technologies, which we started working on them. And, it was only after we were able to have, confidence with the technologies we developed, we secured a US patent on it. Then kind of the floodgates opened up a little bit, and we had more FTO, we had more industries who could participate. But more importantly, the government came and said that we are going to sponsor you for the first sickle cell clinical trial. That was a bit unheard of at that point of time, because federal government doesn't fund clinical trials. It doesn't happen in any country, I think, almost. But it was a kind of a, how to say, far-sighted decision, and we jumped into the bandwagon without realizing what what it entails and all that, as an academic institute and so on. So we're a part of that, and yeah, a lot of things have to be set up for that process. One important thing, covering all the points that has been said, is sensitization. So we have to realize that India, being a very complicated country in terms of diversity and accessibility, what works very well in the West cannot be simply put and asked to be fit over here. It doesn't work. So our therapies need to be built from the bottom up. We have to first go to the patient and ask what they need, and then accordingly we have to build therapy. So ex vivo gene therapy is not sustainable, for example, in LMICs at all. So one of the things that we have actively started, with a lot of help, lot of support from collaborators across the world, is to develop in vivo gene therapy vectors and in vivo gene therapy solutions, which is still a while to go even in the West. But probably, if I had to put it in a more perspective, that how to reduce the costs, that would be the way to reduce the cost. With ex vivo, we might be ending up at 1/20th of the price of what the FDA approved drug is, which is around maybe less than $100,000 compared to $2.5 million, which is currently there. But if it has to be brought under the scheme, such as an Ayushman Bharat Yojana scheme, which the government runs, where free of cost treatment is given to patients, which is what they want to do in such a case, we have to bring that to even half of that. So we are talking here about maybe $20,000 to $30,000. That is only possible when you have scalable vectors. You do not have the patient brought to the therapy, but the therapy brought to the patient. So that's the way that I would look at it.
Great, thank you. And we'll open up to the floor in a moment, so please do get your questions ready. I just want to stick with thinking about government or regulatory support, because obviously you had direct funding and involvement. I wonder if we can return to you, Dr. Bora, about how important or is it necessary to get that government or regulatory support, and how can governments and regulators support more wider access to gene and cell therapy?
Yeah, Hello? Before I do that, I just want to make a comment on your comment regarding the sustainability of ex vivo gene therapy. I do believe that these processes are becoming simple and shorter. The costs are coming down, right? And so I do believe actually we'll be able to get at a price point of a sickle cell for ex vivo 1/100th of the price, right? One thing driving that is that the traditional sickle cell therapies like Lyfgenia had a very low titer of vector. We have very high titers of vector. That's going to immensely reduce the cost. So, and in vivo, I'm a virologist by training. Putting vectors or viruses into the body has its own limitations, right? For example, if you're trying to put something in directly and injectable, you have no opportunity to condition. Yet we know many of these therapies, you require conditioning in order to get engraftment and to get a sufficient population of cells that can genetically modify. So I see in vivo as maybe the future, but very high risk. High risk for failure, complete failure. While ex vivo is here and now. We know it works, right? So I would rather focus our attention on how do we make that shorter, simpler, and lower cost, because we know it already works. And I'm sorry, Ben, what was your question?
It was what support can governments and regulators give?
I think the governments can play an immense role here. So in our collaboration with Fiocruz in Brazil, it's totally funded by the Brazilian Ministry of Health, right? They are not only going to be supporting the tech transfer, in which there is monies for us to put everything in a nice package for our Fiocruz collaborators to learn from, to be able to then have all the SOPs ready and everything, but also they're funding the clinical trial. They'll fund the pivotal clinical trial for approval, because they see a tremendous benefit at the other end. Because instead of paying $400,000 or $500,000 a product, they're going to be paying $35,000. And that's very important for them, because right now, constitutionally, the Brazilian government is under a lot of pressure, because constitutionally, patients have a right to get these therapies. Now, if they have a right, and the government is forced to pay $400,000, you can see the incentive that they have in order to bring the technology in-house and then to be able to provide it to their patients at a tenth of that cost. So your governments can play a very important role here to support the ecosystem. I mean, I think the clinical centers and the organizations have to do the work themselves, but in terms of providing that government support to help pave that way, I think government support is instrumental to accelerate adoption of these therapies in local countries and environments.
Great. And staying on the same topic, I wonder, Dr. Indu, if you can talk about any potential regulatory challenges that you've encountered, or how governments, maybe local or national, can be supportive.
So, with respect to the cell and gene therapy, when we ventured into the field, that was totally new for our regulators because we were the few forerunners who were starting the process and filing applications. And it is more of a learning experience, both back and forth, because they were also not very familiar with the regulations that are required. And but the government is very much for, and they understood the need for such a technology to be developed in the country. And now we have multiple programs to support, say, CGT funding as well. And the regulators now are more keen to have open dialogue with the developers to bring out the regulatory points that need to be changed from the pharma. Old pharma regulatory guidelines need not be the same and exactly mimicked for the cell and gene therapy. So those changes are slowly happening. It's definitely much better. It was not very difficult because it was a good learning experience for us. We didn't face much of a hiccup, though there weren't no clear road path ahead of us when we started. But now I think it is much better, and I'm sure for people who are going to develop further, it's going to be a better process, and it's going to be faster than before. And the clear understanding of the requirements is now very much there. And the support, I think the funding must increase in the future. That's where many of us struggle with the funding. But if that improves, I think a lot more takers, a lot more players and startups will pitch in this CGT area.
Great, and again, we'll continue with this theme, Dr. Thava, because you have had an approval. So you've had the first Indian CAR T cell therapy being approved. Can you talk us through any of the, I suppose, the challenges or lessons learned during that approval process?
So I would say very upfrontly that the approval would not have been possible by the regulatory support in the country, right? So they were very, very open to learn what new things we are doing, and they waited patiently for our answers and listened to us, like why this therapy would fit into a particular paradigm of regulation, why it would not fit into a particular paradigm of regulation. So I think there was a lot of learning and hand-holding at both the ends. So being a sponsor, we were responsible that we upfront tell them about the adversities that this therapy may have. But at the same time, as a regulator, they were also open to learn new things. So I think that was a key takeaway for us. And now that has helped, I think, a lot of people in the country. So because I was there, so I've been this in for last 10 years, and 5 years I was at the academia side, and 5 years now I have been at the industry side. So I think the support has been equivocal at both the sides. So it's not just a pharmaceutical company who is getting a good support of the regulations, but also an academic center. So the first 10 patients which we treated were treated at IIT Bombay, which is an academic institute, and that is where we built a GMP facility. So when we built the facility, we had the inspections, and they came up front and told us that these are the lacunae and you need to fit into those guidelines. And we did that, and they were ready and happy to give us approval. So they were not saying that because you are in an academic setup, right, we would not allow you to conduct a clinical trial from an academic institute, but rather they were very open to approve the GMP facilities in the academic institute and give us a risk-based approval that, okay, we can give you an approval for 10 patients and let us take this project forward, like he's saying, as a mission mode project, right? Let us reach to the first patient and see what more we can do from there, right? I think, and since we have treated the first patient, we haven't looked back. And I'll tell you, the first product, it took 10 years to starting from innovation to getting into the market or the market approval. Now the second product which we developed for the multiple myeloma, the BCMA targeted, it just took 3 years to get into clinical trial, right? So I think the entire 10 years of effort was really worth it to cut down the entire, so it typically trained everybody in the entire pathway who were all involved in this, and that I think helped. And typically also, because the phase 1 trial was funded by the government grants and the research grants, in our case, there was a lot of active involvement by the government of India to see the funded research by them, how it could reach the patients faster. So I think that is one thing which we were looking at. And here I would like to just take an opportunity and say that there were multiple groups which got involved into getting this product into market. So first being the academia. So we started the entire product development at academia. The IP was filed at academia. And I think that is also a way to bring down cost, because today we are talking about scaling access and how we can make it more affordable. So if you do R&D at academia, you typically have a chance to fail, because unlike an investor-driven setup in a pharma company, you have a very limited scope of how much R&D you can do. So you want to hit only those targets which would probably get into market. But as an academician, you can try and error more, and you can develop a product at a low cost. So I think that is something which helped us. What academia right now is helping in the country, I can tell you, and I can say with the experience of the CSR Institute and LV Prasad, is that we are also helping in skill development. Right? India only had biologics so far, say in last few years, the cell and gene therapies have come. So the skills required for a cell and gene therapy, whether it is intellectual skill set or technical skill set or GMP skill set, those were not in our students at that point of time. The government supported academic institutes are actually creating this talent in the country by supporting the research in India. And that helps, now being an industry person, that helps me a lot, because I can hire talent which is really at par of what is the case for other industries apart from cell and gene therapy. That's one thing. So that's a way of bringing down cost. Like he said, labor, local labor, and now locally trained labor, I think that will add a lot of value proposition. And then you come to the hospitals. So what we did differently is that so far we have treated patients in around 57 hospitals in the country, and most of them being the regional cancer centers. So the government India has a scheme of National Cancer Program, under which they have designated few hospitals in the country, around I think 25 of those, which are called as regional cancer centers. And the purpose is that these centers are supported by the government of India to produce comprehensive cancer care. So these are the hospitals which will have interdisciplinary teams. So these are the hospitals to go to for such type of complex medicines, because they can have an entire interdisciplinary program where the entire learning can happen. And now these centers are typically acting as satellite centers for training of other institutes, private and public both, around these centers. So that is how we have been able to scale so fast. So the learning was that because we had a collaborator like Tata Memorial Center, which is the largest cancer center in the country. Right from the day when we had an idea of making CAR-T, when CAR-T did not even exist, like we did not even have a construct, we told them that if at all we have a construct, whether you would be able to do a clinical trial. So we had them partner right from them. So I think they also started looking at capacity building, infrastructure building, training. So in the start, because we had a clinical collaboration with NIH, the USA, right? So we had a training program for the doctors and the caregivers that how they can help in CAR-T cell training and treatment. So I think that was required even before the product came into clinical trials. Then there were patient advocacy groups which came into picture. So like she said, awareness was very critical. So today when we have so many patients, like today we have treated 300 plus patients commercially, and a lot of credit goes to the patient advocacy groups, because even at $30,000 price point, a very few patients are able to pay. And these patient advocacy groups are typically raising funds for these patients who are eligible for CAR-T, but just the only bottleneck is money. Like clinically everything is fine, the patient physically is fit, but just because of money, these patients are not able to get CAR-T. These are the groups which make sure that these patients typically get CAR-T as of today. So I think they play a very critical role, and they would also play a very critical role in policy making and moving the governments, for supporting such research, because now that they are showing an interest in raising money for such advanced therapies, so there is also a change in the policies, and like Dr. Devbajyoti pointed out about the Ayushman Bharat scheme. So there are such schemes which are coming out which can support such advanced therapies, and that is going to only happen when the voice of patient care groups and the patient advocacy groups is heard. So I think everybody in this entire, like I said in the start, ecosystem plays a very vital role. And then the entire thing is, I think in the background there's an industry who does all the manufacturing and who focuses on bringing down cost of the innovation so that it can be still given to a lot of patients. And there is also a regulatory system. So I think the industry and the regulators, I think they are in the background of this entire story, and the patient doctors and the innovators and the patient advocacy group are at the forefront of this entire accessibility model.
Great, thank you. And maybe we can explore a bit more those collaborations between different sectors, but I want to see if there's any questions from the audience at this stage. Yes, we have one in the... Do we have a roving mic? All right, thank you. And please introduce yourself and say who the question's for.
Yes, I have two questions. Firstly, I thank you all. Myself, Riddhi Sharma. I have done PhD in radiation and cancer biology. I'm presently working at JP Brothers as editorial quality manager. So what I do is I see the manuscripts from all the clinicians and I check them for editorial quality, and so this is my work. So sometimes I see a great work, a great case report, but the clinicians are so busy and they don't know that what great work that they have done. So I fill that bridge. So I try to do that. So I have two questions. Firstly, I shall ask at Sarva. Since I have worked at ILBS in immunology, I have worked I have been recipient of the DBT RA grant. So our group have seen that the CAR T cell is very well augmented with the gut microbiota. So my question is, are we doing some R&D based on the gut microbiota? Because what works in the West doesn't apply. There are many examples, doesn't apply, like Jyoti has pointed out. We just can't bring it there, and there are so many therapies going on that doesn't work in India. Because the microbiota is upregulated, like we are having patient cases here. So are we doing some R&D based on the probiotics? And second question, can I ask later or?
Maybe ask both now, yeah.
Okay, my question to ma'am, are we having some therapy based for the acute angle closure glaucoma? Because it is very abrupt in nature and.
So acute angle closure, so you have surgical modalities out there. So it can be easily managed with surgical methods. TRAB is what they do, and it can be easily managed. So when you think about cell and gene therapy, these are conditions where you have currently no other modalities available, and you clearly have a situation where the cells are either degenerating where you want to replace, or there is a genetic involvement where if the cells are fine, just that they are not functioning as expected, then you deliver the gene or correct the gene, then you can. So CGT clearly deals with a subset of those diseases, not everything. So this condition is not applicable. It's not required. You have modalities.
Okay, thank you.
And I would like to start by saying you must be very happy that this year India has very good 2 publications which have come out in the cell and gene therapy space. So one came from CMC Vellore in NEJM about the beta thalassemia condition treated by gene therapy, and second came from our hemophilia, sorry, and second came from our group in Lancet Hematology. So I think 2 good editorials which have come out this year from India. I would say definitely that. And coming to your question about gut microbiome, yes, there is a lot of interest. And there is now a lot of interest in finding out what are the factors, including gut microbiome, where CAR-Ts don't work. Right? So now that we have treated more than 300 patients, we have handful or even more of those patients who relapse in short term, who relapse in long term. What was different in those patients and why did these therapies relapse, right? Because these patients have got CAR-T typically as a terminal treatment, and after that they were eventually even going to get palliation or they're just going to die, unfortunately, right? So we are definitely interested in improving the outcome for these patients of why it doesn't work for these patients. So I think gut microbiome is just one of those, and there is a lot of interest into that. And I would like if Dr. Bora would want to highlight, because he is doing a lot of work in what, if CD19 CAR doesn't work, then what works next best, right?
Yeah. So, as you know, we're developing a tri-CAR. So about 50% of the patients with a single CAR relapse because you lose the 19. The tumors are tricky, right? They can lose their antigen. It becomes very difficult for a tumor to mutate and lose 3 different antigens simultaneously. So by having a tri-CAR, you actually reduce the chance of relapse. And we've shown that previously, that even if you have 2, you significantly reduce relapse. But 3, I think, is something that covers the majority of the populations.
Great, thank you for that question. Any other question? Get another question here, please.
Hello, it was very interesting panel. I am Mahua from Indian Institute of Science. I work as a scientist there, and my area of work has been rare diseases for past 8-10 years. And it's very interesting to see so many upcoming therapies coming up. My question is to Boro and all others as well. For diseases which have lower N number of patients in total, what advantages do you see for going into such experimental therapies? One definitely is that there is no other therapy existing, perhaps. But from regulatory point of view also, because most of the time we are told that these diseases, don't have much hope. But what are the advantages is something I want to hear from all of you.
Yeah, well, I think the local model in running clinical trials directly in a local setting has a lot of advantages. And something that we're exploring in the US is that for rare diseases, where many companies don't want to go to pivotal trials and go to that expense and have that commercial product because there are so few patients, have a clinical trial and just keep it open. Why? I mean, if the product is working, you can actually go to payers and you say, listen, you're going to save all this money for treatment because these patients are very expensive to maintain. But if you have a one-time therapy, you can convince payers to say, listen, provide us funding, even under a clinical trial, right, because the outcome would be better. Generally, you need to show 3 or 4 patients that it is working. But then you can convince payers. And so I asked these questions actually to Peter Marks a few months ago, and before he obviously left. And he says there's nothing in the statutes, in the US at least, to stop a clinical trial. You can keep a clinical trial indefinitely open. So if that's the case, for such a small number of patients, why do we need to go all the way to commercialization? Have the technology available in key hospitals, patients can come and get treated. Because that's the goal, isn't it?
And to add to that, another advantage of having a rare disease or a small n number is that you can ask for an accelerated approval pathway. So you can get to the market even faster. So unlike a disease which has to go through a phase 2, 3, 4, so more than 1,500 patients have to get treated, the turnaround time from research to market authorization would be like 5 years to 10 years. But in case of CAR-Ts or other rare diseases, including I think sickle cell and eye diseases, we can say that the turnaround time would be very small. So if you have a rare disease, you have to have a very small number of population in your clinical trial, and those can be done faster, and that can make the product accessible to the patients faster in that way, even in a commercial setup.
Can I add a follow-up question, maybe for Dr. Devajyoti to answer? Like in USA, we have a full-fledged orphan drug law, right? Orphan drug act from 1986, and then which has been again and again edited. We don't have such here, but new drug and clinical trial law has certain amendments. But from your experience, can you tell us what do you think should be there, which is not there and should be there?
So I can tell you from really my own experience with a patient like this. So I mean, there was a couple who came to us about a couple 2022, 23, whose daughter was suffering from a rarest of rare disorder with only 2 or 3 known cases in the world, which was a disorder which causes the accumulation of proteins in the neurons, and it's a point mutation which causes it. So they had been funding, they were well-to-do people, they were funding the New York University Langone Center, Oren Devinsky's group, for almost 3-4 years to develop a therapy, knowing that there is a CRISPR therapy on the horizon one day. And if it could be done, because their kid was already, was unable to see, to talk, to have any senses, and it was a slow death. No patient survives beyond their teens in such a disease. And they had started working on that, the American group, and then they told them that, even if we manage to do it, FDA will not approve it, because the standard procedure is still going into small animals, large animals, and the process of making AAVs at that scale to inject would not be feasible for your daughter, at least. So then they came to us and said that, can you do this in India and possibly help us? So we took that up as a challenge, now I would not do that anymore. But at that point of time, looking at the condition and what the patients wanted, we did that. We made our own CRISPR vectors, base editing vectors, because it was possible to correct the point mutation. We made iPSCs from the patient. We differentiated into neurons. We saw phenotypically the accumulation went down. We did whole genome sequencing, off-targeting, all these things were done. Then we needed people to make AAVs in GMP quality. So we worked with Orko at Bangalore. He made dual AAV vectors in GMP conditions. Injected them in different routes into the mouse, into the intracerebral, intrathecal, intracerebroventricular, did all immunophenotyping. Everything was done, almost 300 mouse experiments or so, all within 2 years. And then, because time was running out, so but we got tremendous help from NYU, from a group in Italy who seem to have the only antibodies in the planet against this disease, because nobody studies this. It's exactly the same problem. Nobody studies rare diseases, particularly when they are ultra rare. So they shipped all those antibodies to us. We went to our regulators and we told them that, look, this is the condition. There is a single patient, and we have to develop a therapy. And surprisingly, they said that, go ahead. We have in our statutes something called a sunshine trial, which is an N of 1 trial. If there is a patient who is dying, who needs a therapy, we are not here to stop you. You give us the minimum necessary data. We will not ask you to do this in primates. You do it in mouse. And you have your mouse POC data that is good enough. You find your list of doctors who wants to do it. So we assemble surgeons and all who said that we'll take up this kind of an ambitious treatment. Then we met Uditi, this girl, around August in 2023. And at that point of time, she could not even see, but her parents were saying, these are the scientists who are trying to develop a therapy for you one day, perhaps. So we were late by 6 months. So we started the production, but within, I think in October 2023, she passed away because of the complications of the disease and so on. And there's a very nice story on this, which Nature has done. You can go and check this. We covered this whole story. But something that it did was very interesting, because when we talked to the regulators, and they were aware of this now, that so many rare disease patients are there, and such life-saving therapies are possible in the next year or the year after or whatever it is, a lot of things started mobilizing. The first thing that mobilized was that we had a lot of people, patient groups from all sources coming to say that, okay, my kid also has a rare disease, and we never thought there was a treatment. And some of them are very famous people. So the ex-Chief Justice of India, D.Y. Chandrachud, he called us and said that, my 2 daughters are all also having a disease of the same kind. So what is needed in our country? So we visited his house and he said, look, what is needed is legislation, number 1, 2, imports on the rare disease drugs that come from outside. If you can get these 2 things in your capacity to change, and you would be knowing this, that these things were passed last year. So once he got involved into it, he made things that were moved and all. So in the end, somebody benefits. If little efforts are done, somebody in the long chain will benefit. And the number of rare disease people in India. It's not rare at all. So I think to answer your question, in the Indian CGT laws, there is provision for that. And in fact, Rahul and me and several others are now designing the cell and gene therapy guidelines for India for the next 5 years. So we have introduced all these clauses there, that if somebody needs a therapy, that person should get it. It doesn't need to go through that long, arduous route of complex things.
Great, thank you. We have a question near the back.
Yeah, thank you very much for the session. My name is Professor Charles Sibinjira. I come from Makerere University. But most important is that I chair the board of Joint Clinical Research Center, and we are embarking on gene therapy, and I'm very happy to listen to Dr. Boro talking about this. I have two questions, and one is on I realize a lot of gene therapy has been used to treat patients. And I'm wondering whether there could be new gene editing tools beyond CRISPR, since you have been doing this for quite some time. But also in this meeting, there has been a lot about artificial intelligence and how it is simplifying clinical care, cancer care, and also digitization. So how will the advances in AI and machine learning optimize gene therapy? Thank you very much.
Maybe I'll respond, but maybe there should be from the CRISPR side of things. We don't work on CRISPR at all. We just work on lentiviral vector and viral vector-based gene deliveries. So our mechanism is really not to edit. It's mainly to deliver the gene, the repairing gene, or a gene that can affect a function. And as you see, there have been products that have been approved. So we're trying to focus our strategy on things that we know already work extremely well and have a very easy bar, actually, there's no validation of off-target effects for lentiviral vectors per se. So that's kind of our focus. But yeah, machine learning and AI, I think, will play a very important role. Will play an important role in future for QC, right, for the management of the release of products. I think in the future, maybe not now, but maybe 5, 10 years, you're going to start to see machine learning being able to automatically release products based on parameters, and then human intervention will be less in terms of looking at things that are more, deviations. I think machine learning will play an important role in terms of identifying new targets with clinical correlations, but also in the design of vectors and the design of these therapies. So I think there are many opportunities. We're just beginning, I think, to scratch the understanding of how machine learning and AI can be applied in biology, and I think that there are many opportunities. So maybe something on how you see CRISPR evolving.
Yeah, I think along the same lines. So we need better and better proteins, smaller proteins, delivery systems, all of these. The scale at which engineering used to work before, protein engineering and vector engineering, has been reduced in time scales. You have through AI, this has already been done. There's a Nobel Prize that has been, been received for, such kind of developments. But it is getting more and more into the domain where it will very soon merge with healthcare. So at least in the gene editing field, I think we are seeing more and more papers on very innovative and intelligent design of CRISPR proteins and modalities of delivering them. Yeah.
Great. Any other questions from the floor? Yes, here at the front.
I'm Jay Raman. I run a technology transfer company, and one of those early birds which burnt its fingers in gene therapy. Just thought, I'm not sure if it's a question, but some sharing along the lines which would probably trigger further discussions. Infrastructure, one technology transfer, then two infrastructure in India, and things like this. Between 2007 and 2012, we were very vibrant in transferring technologies into India. One of the initiatives, CCMB, has actually created an integrated facility for this purpose. Later, it is now an incubation center. Unfortunately, it's a facility developed for this purpose, like a clinic with NIMS and other things. And we in fact, worked with LVP on retinal degeneration, one of the technology transfers. And started trials and stopped it because at that time it was only a stem cell guideline existing. And it was not part of the TCGI and things like that. So it was very early that after 300 odd patients, it was stopped. Actually, it went till so much money was burnt in this process. And then one of the vector transfer technologies also kind of, so for India, I think India probably had some 10 plus years of story in gene therapy and then stopped, and then because of lack of regulation, and then there was a gap. And now I see a lot of progress in this area. So all that I wanted to say is that the scope is always high, but somewhere we need to kind of trigger back the, for instance, a lot of biologic companies actually bought some technology, vector technology, but they never took it to the clinic. It got stopped. So one of the things is like, I think it's time that why not we look at some kind of harmonization programs like US, India, regulatory harmonization programs is a need of the day. So people can come together, particularly clinicians, because it has to come from the clinicians thing. That's one part, and which I think. Second is genetic variation analysis, and then AI models being built. So one of the companies that we are incubating is around these lines, and we don't have India data. So India genome data is becoming extremely important. So maybe I think some of the fundamentals that are missing is something can be re-looked at or looked at. This is my opinion.
Okay, so we've got regulatory harmonization and need for more Indian genetic data. Do you want to start, Bora, with one of those?
I'll take the harmonization piece. Obviously, as an organization that's globally collaborating around the world, Latin America, Asia, Europe, harmonization is very important. So we're in touch with our regulatory colleagues both in Europe and in the US, and that's why we really went for a process that's very simple, right? Because that makes harmonization very simplified and easy. And obviously you've got regulatory nuances in each locale. You have to adapt. Like in Brazil, it's a little bit different than in US. But you'll find that there's more and more interactions between different colleagues at the regulatory level. They try to harmonize more and more and more. So you get standards occurring, So standards would help a lot in terms of harmonization, so that when you have a vector titer, that there is a standard out there to say, what is the copy number? What is the true copy number? And actually, we contributed a little bit to that field. We created a cell line with different copies of lentiviral vectors in it. So it could be used as a standard in the globe. And NIST, the National Institutes of Standards and Technology in the US, has now taken that cell line and is going to be making that cell line available globally, so that when groups are validating their copy number assay for vector, they have that standard available. So that's all part of the harmonization process.
With respect to the cell therapy, so in International Society for Stem Cell Research has put up standards for how to prepare stem cells for basic research. Now, in the past 1 year, they've invested time working with people across the globe, put together guidelines for stem cell use in the clinic. So these guidelines will now become a benchmark to which each country can work and then bring about changes that are in compliance with the local regulatory guidelines. So that will take place probably once this international standards has been released. So that's subsequently probably our regulators can work together and see how well we can match our own guidelines to the set standards. So that is expected to come in the next 1 or 2 years.
And I think very quickly, the last thing you mentioned was the Indian genome variation. And for that, I think you can consider the recent release of the 10,000 Indian genome from the DBT. So that's a very, very useful resource, even for CRISPR researchers like us, because now we have not to look at the Caucasian database to look at off-targets, because off-targets change by genomes, right? So all these things are very, very important things that are happening in parallel. So I think that's a very good resource, and DBT has made some mechanism to make it accessible for all. So one can look at these.
In what way genomic testing can actually bring more data, like empowering genomic testing?
I think as academic centers, like at IGIB, we do genomic testing for underprivileged things, and this data is anyway available. But companies which are doing a huge amount of genome testing these days, so you can also talk to them, like some of the big ones, MedGenome and others, who are making this available to collaborators and so on. So you can look at these as a possible.
The problem is this data is not available in one place. Right, because when COVID hit, so the real-time data was being captured by ICMR for reporting and for all any variant evolution and all of that. We had that information. It's very unfortunate that these testings are happening in pockets and in private, and so there is no one place reporting that ICMR can collect and make policies. And with respect to even prevalence data, we really don't have a prevalence data because we all know based on how individual researchers have published. So it's based on regional information, not as a national level prevalence data we don't have, but it should be feasible. If we could do it possible during COVID and all this data could be compiled in one way, I'm sure this is possible even for inherited diseases as well.
Great, thank you. And we're just going to take one final question from the front.
So I'm Visu. I work at a science park in the Genome Valley, Hyderabad, and we are planning to establish a CGT facility. As a science park, we want to establish common facilities for scientists. Debojit can establish a JMP facility, Atharva can do, but if a young scientist or if somebody want to do, we wanted to have a common facility. When we are interacting with various scientists and early stage companies, there are three things, fully automated, semi-automated, and manual. With the cost and the vector cost. So I request your suggestion, when a common facility is being set up, so what are the key things besides the analytical facilities?
And a quick answer, please. Short answer.
The short answer would be try to make something which is modular, because I think for somebody automated, because you're looking at it as a research park perspective, so somebody may want to use an automated, somebody may want to use a semi-automated, somebody may want to use a manual way of doing things. So I think have a facility which is modular in a way which can fit everybody's requirement. It's not possible to have a facility which fits all, but try to have something which can fit everybody's. That would be a great use of such infrastructure. Otherwise, it would be very limited use of that infrastructure.
That's great. Well, thank you again to our panel, and thank you all for your questions and attention.
Other activities. So we are really very seized of the matter. So this is about Jharkhand. When I talk about Jharkhand, that is the condition at Jharkhand, although we are very happy because it is more and more accessible nowadays, and we can reach out to the districts and the blocks, and we can do a better review there. And you already talked about active case detection and indoor residual spray, and I think lately in the program what we've been doing is we've been focusing a lot on indoor residual spray and the quality, because early on, maybe 2 to 3 years back, when I had visited, I realized that after 6 weeks of spray, there was sandfly which was sitting on the wall, and then we have been emphasizing that the spray should be of good quality. So that is really very critical to us, and we are having the teams in the field which go pre-IRS and then post-IRS. Pre-IRS to ensure that the quality spray is happening, and post-IRS maybe 6 weeks after the IRS has been done, so that they can just see whether the IRS has been effective or not, because it is a very important tool for us. And once we are using an insecticide, it becomes we are bound to give a good quality. Otherwise, we will have resistance, and that will be a problem. And then, of course, I have been emphasizing very, very clearly that all the areas which are co-endemic for malaria, the whole wall should be covered. I hope that every state is doing that. And Shower being the NPO, he has to ensure. And if none of the any of the states or districts is not doing that, you can kindly inform me. So this is one of the very key strategy currently that we have. Thankfully, we have a very good drug, and Ambisome has been a game changer, and we have been able, because it's like a one-day treatment, so that is definitely there. Number of fever days and number of days after fever, treatment initiation days have really reduced in the recent times, and we are very hopeful that we will be able to keep it down. PKDL still remains a challenge, and I think I was told also that sometimes it so happens that during the active case search we are not able to identify. So capacity building becomes a very important thing, and especially for PKDL cases, because VL cases have been going down. Initially, we saw a rise in the PKDL cases, but now currently we are seeing that there is a plateauing and decline in many other areas. So these are a few things which are also quite evident over there. And of course, miltefosine 84 days treatment still remains a huge challenge. Although I haven't really received reports where people have been refusing. So they are taking that medicine. We did have a lot of side effects, some 4-5 years back, but now we have not heard of any serious eye complications or any serious side effects coming out of miltefosine. But of course, it is still a disease which has a lot of unknowns hidden within its folds. And Dr. Mitali and all the panelists know this, that it is not that simple a disease. And how do we ensure that the gains that we've had so far, we sustain it and we bring it down? So the thing is that we have to take it down below 0.5. That is what is our target, because as I said, it's a very fragile thing to have like less than 1 per 10,000. So it can anytime exceed, and the hard-earned gains will be lost, because WHO will put its foot down and say, go again, back, 3 years back. So despite the number of cases going down, if we don't fit in the definition, it becomes very tricky. So I would also request WHO to kindly, consider this, that it is a population game. It is not the game of number of cases. So then you have to be very cautious that other factors related to transmission needs to be checked. Because I think there was a study wherein we had a lot of sandflies, but we never found anything positive in them. The pools of sandfly, nothing is coming positive. So that is very strange, and that is, something which is a little concerning. And of course, so in the coming times, aggressive and vigorous monitoring, that is the key to us. And DCs have been actively involved, and we are actually reviewing with the district officers and going down to the district commissioner who's taking care of his district, block medical officers, PRIs, which you already told, I don't think I need to repeat. But definitely we are very keen to, remove this problem from the country from its root. We don't want it to continue. And so the long-term goals that you talked about, I joined my medical school in 87. I don't know, that time also these were the long-term goals, and right now also I think 30 years down the lane. So long-term goals need to be tackled, and I think housing has played a very important role in the recent past. And today I'll just tell you one very interesting thing, Bhupinder, that in malaria, Lunglai and Nongtalai were presenting that they have those houses with bamboos. And so they were saying ki whatever indoor spray, outdoor spray, there is nothing like, that. So I was thinking of housing, why PM Awas Yojana is not reaching that. We can take it over there as well. So housing has played a very, very important role. Housing plays a very important role for many infectious diseases. It's not only VL. It is important for TB, it's important for leprosy, it is important for so many, because as we know, ventilation, overcrowding, these are the things, and the cohabitation with cattle. So our communities are made like that. And for IRS, we have now even requested the DCs that if there is some kind of, I would not say a force or a coercive action, but yes, some kind of seriousness from the administration side, that the cattle shed, the kitchen, which is left out during IRS, should be covered. So those are the few things which come offhand to my mind, and I think we have a lot of experts. We can hear their views and ideas. Thank you, Shawar, for that.
Thank you so much, man, for setting the context. I move on to Dr. Bhupen. So what do you think from your experience of last 10 years working in shifting from immunization to neglected tropical disease? What do you think during the past 10 years has been the key factors which reduce the number of cases from more than 9,000 in 2014 to less than 500 in 2024?
Thank you so much, and Madam has made my work easy. She has already narrated so many things. I just classify into a couple of sections. The first and the foremost thing I would like to start with is political commitment. It was a game changer actually. At the international level, at the regional level, sub-regional level, state, national, state, district, and all the levels. So that was one thing. Second, bringing indicator and urgency for elimination. Even that was helpful because everybody had indicator, okay, it's 1 per 10,000, but still we had indicator and we had a timeline, okay, 15, then 17, then 19, we had a timeline. So this is one, I would say, because it was supported by financial, other things, etc. Second is program implementation. Drastic improvement in the program implementation. Whether it is active case search, whether it is passive case search, whether it is IRS, use of diagnostics on time, giving treatment, etc. The third I would say is research and development. The moment point of care diagnostics came in, game changer. The moment whole lamp liposomal lymphocyte B came in, one dose, one shot, all done. These were major changes which brought the things into account. Third, the whole entomological support by Liverpool School at that time for some 8 sites, and they brought evidence where transmission is happening, how the transmission is going down. So R&D. Then next I would say intersectoral collaboration. The point madam mentioned about housing, it's a PM housing scheme, a different department, but they allowed that yes, if Kala-azar patient is there, we will prioritize that patient. Engagement of Panchayati Raj institutions, engagement of schools, engagement of other type of institutions, that was there. Then after community participation, the regular review and feedback mechanism, what madam had established, it was like established early. WHO came in, program came in, there were independent missions which were organized, everybody went to the field, reviewed and came back, and all was for a positive common direction that we have to reduce this this problem to a lowest level and eliminate. And everything was evidence based. The whole establishment of calmness and tracking each and every case and then finding, okay, now West Bengal is done. UP, done. Bihar, done. Jharkhand, oh, we have this problem, but overall done. So I think these were all things which were very promising. And then relationship between India, Nepal and Bangladesh, that partnership led by CRO, I think that was also very good. Although it's a neglected disease, by the way, beyond these areas, it's still neglected.
Thank you so much. So this brings me to the next question, which I would like to Dr. Rotre to throw light on. Despite all these success, we still are struggling in Jharkhand and few blocks. What do you think hasn't worked in Jharkhand, and what do you think we have to change our strategy to cover this last mile, especially blocks like Littipara and Amrapara in Jharkhand? And how do we, achieve that success there and sustain it further?
Well, as we just heard, the achievement has been significant, but as Madam points out, this is a very fragile sort of achievement, which is very... Okay, audible? Okay. So it's a fragile goal. So we are living with everything. We are living with the host, the environment, the vector, and and the causative agent still there. And the basic strategy of case detection, active case detection, has to be there. We have to. These diseases are known to be clustered in very high endemic, high risk geographic. They have a reputation of being happening there. They're outbreak prone. We have to prioritize those areas and intensify further and continue sustaining the active case detection, the integrated vector management, and early diagnosis, prompt treatment, and follow up, and the PKDL as reservoir. The same strategy that has worked elsewhere all around the world, in our country, in other places also, will work here. We just have to focus on the quality of delivery.
Yeah, thank you so much, Dr. Rotre. From my visit, what I feel, apart from doing all these efforts, we'll also have to work intensely on behavior change communication. In spite of having this Pradhan Mantri Awas Yojana Gramin, we can see that there are Pakka houses, but the people are not using it. There are sanitary toilets, but the people are not using it. So I think at the community level, we have to work on those aspects. Also, other socio-cultural aspects like they sleep near the animals, they don't use insecticide treated nets, although malaria as well is very intense in that part of the world. So if we have that behavior change communication, that would address Kala-azar and malaria and other diseases as well. And of course, we'll have to build partnership with local stakeholders like rural health practitioners, where like these communities, they live on the mountains or on plateaus or hills, and they come once in a week to this hart or bazaar, what you call, and in that bazaar, they think that they will get everything. They will repair their cycle, they will get their child treated, they will buy their potatoes and everything. So that weekly hard bazaar and the rural health practitioner who caters to them, I think we are trying to work on that end with, under the guidance of the national program. I think those additional steps would be required. Yeah, when things are not working, we have to think how we can work differently to achieve that point. With that, Dr. Aya, I would like to know if India is so near to elimination. Of course, it would be validated in a couple of years. What do you think? How important it is the regional cooperation, especially with the neighboring countries, ensuring that there is no cross-border resurgence, and what role WHO can play in it?
Thank you. So, no, regional cooperation is, of course, important for every disease elimination. But the focus of the regional cooperation, the importance will shift with the program advance. So when the burden is high, their main focus is to standardize or align the regional elimination activities among the neighboring countries. But when the burden is become very low in the near elimination or even post-elimination stage, then the focus become more for the early detection of the cases among the migrant laborers or people who are passing across the border on a daily basis, and timely cross-referral or notification to the other country, the other side of the border, so that the other side can also do the immediate action, the preventive actions, case of investigation. It can be the joint activity if the cases are near the border, but mainly for early detection and the response on the other side. So this is the main focus of the regional cooperation. And from the WHO, so we have, I would say, the three important the functions to play or support. So one thing, WHO have a convening power. So we facilitate, of course, cross-border, cross-country collaboration, cross-referral, cross-notification, and also the policy alignment. So for example, in 2023, so WHO convened a regional workshop for cross-border elimination of Kala-azar, malaria, and LF between India and Nepal border. So we brought not only the national program manager, but also state, province, and district focal points on both sides of the India-Nepal border. And so that we can facilitate, of course, the technical discussion, but also the networking, so that this side know who is the counterpart on the other side, so that we can facilitate even the formal but also informal notification or information sharing or even the regular discussion. So that was one thing we have done. Also, we have convened regularly the regional technical advisory group for Kala-azar elimination. So this is also another platform where we bring together experts and program managers from different countries in the region together. So we discuss the common challenges and cross-learn among the countries, but also between the countries and the experts, so that country can align and optimize their elimination strategy. So this is what we do. We also have started through the regional office and country office in India and Nepal to help cross-notification of the cross-border cases of Kala-azar. Not so many yet, but then at least we are also trying to complement for this cross-notification, because often our channel could be faster than formal notification between the countries. And then, of course, we'll continue to provide the technical support and also the coordination role, so to the regionally aligned strategy and also the guideline and capacity building. So this is not about Kala-azar, but actually this February, we also organized a cross-border capacity building workshop of the malaria and LF elimination between Indonesia and Timor-Leste. So this was, again, the purpose was for two countries, the district across the two countries across the one border, to jointly build the capacity of the elimination activities, but also again the networking. So we can also do the similar thing for the Kala-azar as well. I mean, we can continue to do that. And also, we also coordinate the procurement and or donation of the Kala-azar treatment. And this become more and more important when near elimination or post-elimination, because when the number of cases is so low, then country might not be able to have enough cases, because every medicine for procurement, you have a minimum threshold, a minimum batch size. So this is where we, WHO, will play a role in coordinating the needs of the procurement or donation of the medicine, but maybe potentially diagnostic as well in the future, in the long term. Then finally, of course, the WHO continue to monitor the progress of country, but across the region at the global level. So we will continue to do that, and also we will facilitate this validation mechanism, right? So for the Kala-azar elimination. So that's the main three role WHO will continue to play.
Thank you so much, Aya. Dr. Kavita, you work with Drugs for Neglected Disease Initiative. So what role do you think that the newer tools like shorter regimen or single-dose oral drugs will play in ensuring a long-term success, particularly in low-resource settings or hard-to-reach areas? What do you think? And is DNDi working on some new tools?
Sure, thank you. Good evening, and thank you for this opportunity. Maybe just to really come to the answer to the question you've asked is I'll look at it with three lenses: a lens of history, a lens of the present ongoing, and future. And some of them, of course, was alluded to by Aya and Dr. Tanu also. Historically, we've seen this parasite is a very smart bug, right? Antimonials, it has troubled. We have seen as high as 60-65% resistance. Miltefosine, we saw that resistance. And of course, then this huge trial done by DNDi and partners, where we got this evidence that despite a better results, efficacy results with a combination, we still chose a single drug. We still chose a drug which was a single dose. So the very fact that you've asked this question comes with experience that yes, single dose compliance, nothing beats to that. So therefore, I believe this continuous ambition that let's keep it single dose. The second thing at present, what I was saying is looking at it is the geopolitical environment presently. Would we still have access to these drugs? Will countries which are developing still have access to the liposomal amphotericin B? Even if WHO's best intent, would there be funds, financials available? That's a question mark. And the third is, in future, as you said, the numbers are going down. When the numbers are going down, can we maintain so many treatment centers? We don't, what will happen to the shelf life of the drugs? When will the patient come? So I believe all this together is what has prompted you to also ask me this question, can we have something different? Yeah. And I don't know if a single drug, because considering the disease, which is really a visceral disease, getting into so many organ systems, maybe not a single, but the present clinical trial which we are doing is about an oral drug. We've finished a phase 2 trial. We finished recruitment of the phase 2 trials. The follow-up of the patients is still ongoing. I will wait. I will not jump the gun before the results are officially announced. We are testing 7 days treatment and a 10 days treatment. But at least what we are looking at is a scenario not where a patient is compromised, he is working around the hospital system, but can it be screen and cure, right? Can the ASHA workers, like they're doing the rapid CAR test for malaria, can they do it similarly for leash so that it is more much closer to the patient? The possibility of combining 2 drugs, we have now done it. We've done it in Africa. Yes, Africa is where we always had 2 drugs. But in India, if we combine 2 drugs, can we have a shorter therapy? Is of course needs to be studied. And I'll lastly close with the challenge that with the numbers coming down, Dr. Tanu, we don't know how to do a phase 3 clinical trial. We've done a phase 2. What is it that could be helpful for the community together to look at the phase 2 data when it's available, that we can, whenever at least, we can pivot or we can change gears from a liposomal amphotericin, which is complex to give, which people have to constantly be trained on what dose to give, how to give, to oral. So there are challenges of these numbers going down and how to do a trial in such a circumstance.
So with that brings me to the question, like numbers are of course going down, and that is a good news here. that numbers are going down. But can we think of multi-country trial in such scenario? We can collaborate. We can have one site in Nepal, one site in Bangladesh, one site in India, of course. Is that not feasible? Because I was a part of multi-country clinical trial on DRTB, TB practical, which eventually led to new treatment regimen for MDR, XDR, TB. So why
Yeah,
can't
sure. No, we are, I mean, that's not something we've thrown out of the conversation. But, you know, when you speak to experts, some of them say the way the parasite behaves in different, even within Nepal and India. And Dr. Suman is here. I'll let him also have a word. Please, Dr. Suman, whenever you get time. How the differentiation in the parasite behavior does not sometimes allow you to do a single trial. You can have, yes, sub-stratifications and arms. All that is possible.
Yeah.
It's not out of conversation, of course. That's what was the last meeting we had a couple of months back.
Thank you so much. I now move on to Professor Mitali. Ma'am, around 10 to 15% of VL cases develop PKDL, and it remains a challenge, especially in the last mile. They act as reservoirs of transmission. They often present as subtle and as subtle macular lesions that are clinically difficult to diagnose. What advances are being made to improve early detection and case confirmation, and how close are we to having a reliable field-based diagnostic tool for PKDL or post-Kala-azar dermal leishmaniasis, please?
Thank you very much, and a very good evening to all of you. I think before I answer the question, I'll put you into a time capsule and take you back to 1922, when Sir UN Brahmachari made this very, very pertinent observation that a few cases of Kala-azar that he saw, at that time Kala-azar occurred in thousands, and there were just a few cases which actually developed skin lesions, and he called it post-Kala-azar dermal leishmanoid. So if we think about it, 100 years ago, we identified the fact that PKDL occurs, and still till now, it actually remains an enigma. It's really like a mystery. It's a million-dollar question. Which patient of Kala-azar will develop PKDL? We don't know this. And we don't even know why it occurs. It could be because of the host genetics that makes a case of Kala-azar more susceptible to developing PKDL. It could be related to the drug that was used, perhaps with antimony. There was incomplete removal of the parasite, and that led to some amount of residual parasites remaining, which subsequently resided in skin macrophages and showed up. Or it could even be the fact that the parasite has changed, as Dr. Kavita just mentioned, that there are differences. The parasite itself can change because it's a bug which has lived much longer than any of us and will continue to survive. So we have a very, very smart enemy that we are working against. And the bigger challenge that has now occurred is that with active surveillance, which was really a game changer, it became a game changer as far as the demographics of PKDL was concerned. We identified that there was no gender bias, males and females developed it, and more importantly, that earlier in the textbooks, the textbooks when I studied medicine, it said that presented with nodular lesions, with nodules and papules, and there were very few that were actually hypopigmented, which are the macular lesions. And we actually ignored them right in the beginning because there were only 10% and 90% of them were actually the polymorphic. But once the active case surveillance came up, we realized that here are these individuals who are roaming around. They are like a mobile disease reservoir. They are roaming around in society. They have these huge lesions. They are completely unaware that they are actually transmitters of the disease, and they are actually, harboring the disease. And the bigger problem actually is because they're just hypopigmented, these are marginalized individuals. For them to just have a hypopigmented patch is really not something that, they would even go to a doctor. It was the ASHA workers who actually made the difference. They motivated them. They asked them that they should come to a medical camp where they were identified. Once they were identified, the clinician, the dermatologist, the microbiologist, the tropical disease expert, they had a dilemma. Is this a case of leprosy? Is this a case of pityriasis? Is this a case of PKDL? Because often they could not give a past history of Kala-azar. So these were the challenges that were faced, and at that time, the only test that we had was the point of care, the RK39 diagnostic test that we had, the strip test, but that could be positive simply because they had a history of Kala-azar. So it was not in any way telling you that they have PKDL. So that's where research, which has actually played a major role in the success story, research contributed towards development and ultimately has brought us to the point where we are standing, is we came up with, others also have done it, is trying to look for the parasite DNA. Now that's like looking for a needle in a haystack, especially for maculas which have very few. If you do a slit skin smear or you do a skin biopsy, you will not find an LD body. So we said, okay, let's go back and try to see whether we can actually identify the parasite DNA. We were very fortunate that we actually were able to set up this test. It was actually taken up. We actually looked at the efficacy of miltefosine versus liposomal amphotericin B for PKDL. But you don't rest on your laurels, you continue. That's the fun of research. You keep on searching over and over again. And that's where we felt that the problem that was still there is just diagnosing is not enough. What we felt was that we need to decrease the turnaround time, because the patient will come, they will come to a medical camp, they will be seen, then they will be told, okay, come back for the diagnosis, then they will come back for the diagnosis, then they will get the treatment. So the turnaround time was a lot, and they were still, they would continue to be transmitters. So then we said, okay, let's try to have field applicable tests. So a field applicable test would be something would be applicable in the primary health center. It would be set up over there. The patient would come, be seen by the clinician. The clinician suspects that, yes, this is a case of PKDL. The skin biopsy is given. We set up something like a portable laboratory suitcase. This was funded by the Gates Foundation. We're very fortunate that we were funded. And we were able to show that you can actually help to pinpoint those cases that were PKDL. They were given the treatment and they were asked to come back. Every month they were asked to come back with their things. But even those have challenges because we still have poor adherence to miltefosine. So again, the field applicable test comes in handy because we can actually take another skin biopsy and see whether there are parasites present or not. So we have come forward. And I think the bigger challenge is, and I used to ask the WHO experts, I said, why don't you also have a point, we've set a target of less than 1 per 10,000 of Kala-azar cases. Why don't we also have a target for PKDL? And then they would say, let's go step by step. Let's achieve this goal, then we'll go to the next goal. But I think we need to do it hand in hand. Because if we don't do it hand in hand, we will not. And I think because we've done it hand in hand, we are in this strong position that we are in today.
Thank you so much, ma'am. Moving from the disease to the vector that cause it, transmit it. Dr. Rotre, given your involvement intensely in implementing integrated vector management strategies across different states, what do you think how we can tailor these approaches to maintain VL elimination in future, considering the cases are coming down and the people's technical know-how would decrease with time, and seeing other co-endemic diseases in the same region, how we can move forward into the post-elimination era and sustain it, and how we can innovate our IVM strategies.
Thank you. So, as I mentioned earlier, elimination requires sustenance, and all that we have been doing to eliminate has to be continued. And one of those key pillars there is vector control. So, integrated vector management has to continue as long as you are living with the vectors and everything else in the epidemiological triad. So, integrated vector management is something very well said than done, because the reality is the programs are so siloed in their own approach, and sometimes you need a co-endemic area to have other vector-borne diseases prevalent in the same area to have the same strategies or the same integrated vector management done. But having said that, I think we should focus on endoresidual spray, which is key, and we should be ideally, as WHO recommends, going for sensitivity tests and rotating every 3 years, so to see the efficacy of insecticides also. And like for example, if you have malaria and VL in the same space, So endoresidual spray has to be common. Only thing is we have to give an instruction of go beyond 6 feet, as we have been limiting in Kala-azar areas to not go beyond 6 feet. So it's the roof and entire area that can be done, because we use the same things, alpha cypermethrin and whatever we do. So integrated vector management makes sense if you have other co-endemicity prevalent in those areas. Otherwise, we'll have to focus on those high-risk villages, those high-risk population, those high-risk areas which actually where we have those vectors. LLIN is another, we can call it a vector management in a way that if you have insecticide impregnated nets given, it stops sandflies also to some extent along with malaria. That can be considered as going together in an integrated way. Source reduction is what is critical to stop vector transmission. So we do have source reductions activities happening for dengue, for malaria, in terms of so we can train the same people. If they are in those co-endemic areas, they should look for areas where sandflies also breed, like cattle areas or dung collections or bamboo shoots, or especially in those areas, banana trees, rotting leaves. So these areas can be removed, can be taken care of to get rid of the vector. So that is again another integrated vector management. I would say for dengue, there's a natural way of fogging and spraying. We need to do research, of course, to see whether that's working. Space spray will work for especially those targeted areas where sandflies are breeding in those stables or cattle sheds. There are innovations like rightly pointed out by Madam, that pakka ghar and wall crevices has to be done. It works for VL also, it works for other mosquito breeders also. Netting the windows, having insecticide impregnated netting is something which is coming up in those particular areas. Curtains which are insecticide doped and insecticide impregnated can be used as a integrated vector management tool. Painting is something which has come up. Wall paint having the insecticides, it works for all mosquitoes and including sandflies also. That can be taken care as a integrated vector management. Sugar beets and sticky papers also will obviously work for any vector, anything that works, but this needs further research and further, we can be trial, as you mentioned, some hardcore belts which we can try all these things collectively to get rid of transmission. So this is something which...
Thank you so much, sir. That was quite comprehensive, but I would like to hear more from you from UP's Dastak program. Could you please throw some light on UP Uttar Pradesh Dastak program that we have?
Yeah.
It seems to be very effective.
Yes, so Dastak is going house to house, doing active case search, looking for multiple infectious diseases with simple case definitions and some simple tools. So wherever we have endemic villages, the health workers or the health link workers who goes for Dastaks are trained and equipped and sensitized to collect that information also and identify suspected cases. But what happens with Dastak in terms of integrated vector management is they also do something called Sanchari Rog Niyantrana Abhiyan. That's also 3 times a year, just before the high transmission season, into the high transmission season, after that also, targeting exactly 14 departments come together there. It's not only health, it's agriculture, veterinary department, and urban development, rural development. They all collectively do these things. Breeder checkers in houses where mosquitoes are breeding. They cut the bushes to control vectors. It includes multiple vectors. They clean the drains so that there is no water accumulation and breeding and all those things. It's of course not for Kala-azar, but it can work for Kala-azar as well. So, and also like pond cleaning and so many other things, and you know, providing better housing and better sanitation, better drinking, and overall living conditions are also being taken care of when it comes to such kind of marginalized or communities which are actually affected. So this can all go hand in hand, and you know, so Dastak is an example of how we do active case search and integrate other diseases along with Kala-azar also, and PKDL of course, to you know, identify and put them on treatment and do all sorts of vector management along with the team, along with the program.
Thank you so much, sir. As the numbers are going down, donor support is also thinning. So my next question to Dr. Bhupen Tripathi. So how do we sustain the donor interest as we know that we are still to cover the last point, and the donor support has already started thinning. So I'm just billing the cat, asking you this question directly. Uh, uh, how to maintain the donors' interest that Kala-azar is still an important problem, and we really need more support and more intense effort in the last mile. How to do that, sir?
Perfect. So, well, we have not committed to finish our funding for this cause, that is for sure. But having said that, can we disintegrate the funding? Where is the funding coming from foundation? And what the government is doing? Let's go one by one. Human resource. Who is doing the active case search? Who is doing the IRS? Who is reviewing the program? All government people. ASHA is doing, CHO will be doing, MO is doing, government people. IRS supply, drug supply, diagnostic supply. Who is doing that? NUBDCP. Okay, who is doing the review at the national level? NUBDCP. All government. So I think this is a wonderful program to showcase whatever started with partner support is actually led by the government. Now patient is identified. Okay, malnutrited patient needs some money for nutrition as well. Who is giving money for that? NUBDCP. Whether it is VL patient or PKDL patient, there is an incentive attached to that from the government system. Follow up, government is doing that. Then in terms of housing, who is providing Pakka houses? Government of India is providing house. So I would say this is a wonderful program where actually all the things done by the government are visible. And then finally, when the cases are going down, the knowledge will come down. What will happen? Partners will definitely come down. That is the reality, because partners will have to focus on something else. Okay, malaria is there, let's work on malaria. But who will contain and have the knowledge and resources? Medical colleges are coming up. Center of excellence are being established. DNDI, Dr. Kavita has established Center of Excellence in Saran. That knowledge has to be brought in. We need to develop museums where all these things are there. The life history of Kala-azar is there, and any new medical person, whether it's a student or a PG or a new medical officer, they should be brought there to go through one by one. Like smallpox went away, none of us are actually doing anything on smallpox today. But somebody did that, and there are books available. So my thought is, money will be the last thing required for Kala-azar in India, I can tell you. The things required will be ownership to sustain the resources which have been brought in and continue to document the things what we have done. So documentation has started. Madam has brought in medical colleges. I think more than 42 medical colleges have been brought in as of now?
Yeah.
Huh? 22 medical colleges.
23.
Now, out of them, if we can identify geographically and we tell them that we want a section in their department where all the history and all the things clinical, they are available. So that is something which we have to bring in. In terms of competency-based capacity building, IGOT platform is Government of India's platform. So whether it is an ASHA or a CHO or a medical officer, that module on Kala-azar should be part and parcel of that. So I would say Kala-azar does not require lot of funding from outside. What we are requiring from outside is somehow, technical experts, like people like WHO colleagues, people like, PCI colleagues, GHS colleagues, and they are here for a task. They know that if the task is done, we have to diversify and take on new challenge. So I think don't worry on the funding on Kala-azar. Kala-azar is something where we have the solutions. We have the systems in place, and Kala-azar will be the first program on NTDs where government will say, Gates Foundation, thank you so much, let's go to somewhere else. And that is the knowledge and the experience which every country should follow. That government should come up, well, you taught us how to run, we are running now, you may please take a seat. So I think, we are in a very nice place for Kala-azar in India on the funding part. Having said that, these diseases are vector-borne diseases. We are doing elimination as a public health problem. We are not eliminating. That means transmission is not zero. We have to expand our places where else is the problem happening. Nepal has wonderful data. East Nepal, over a period of time, cases have gone to West Nepal. Similarly, in India, whether Uttarakhand is reporting cases, whether Himachal is reporting cases, I think we will require some funding for partner and program to go and explore. For that, funding will be always available. Some sero study is required, whether it's elimination, real elimination, or it's elimination we are not finding, but the serology is saying, no, there is a problem going on. So children identified a specific age group, WHO can recommend, we can do serology over a period of time. The third can be the diagnostics, are they working or not? Are the drugs actually working or not? Is there a resistance? ICMR is the body, we can provide some support to establish that system run by ICMR over a period of time. So I think we have wonderful opportunities in Kala-azar where foreign funding should stop actually. And government is ready for that. And if foreign funding is available, let us utilize for vector control, integrate vector control, or malaria, or any other disease which we have to think about. So I am very secure about Kala-azar. Funding is not a problem because government has already taken up everything. I'll stop.
Thank you so much, Dr. Tripathi. Kala-azar has a notorious habit of coming back every 10 to 15 years. So, Dr. Aya, how well we are prepared if there is a resurgence, say, in Bangladesh or even in some part of Bihar? Like there was a Sheikhpura outbreak back in 2019, more than 100 cases were there. What role do you think WHO could play in mobilizing resources, not just human resource, but is there any role which was discussed in regional TAG meeting where we can have a regional repository for key drugs like ambisome or RK39 diagnostics, where if there is a sudden resurgence or rebound in Southeast Asia, WHO can coordinate a concerted and joint response to that outbreak or a rebound of Kala-azar?
Thank you. So I think the Bhupendra has already mentioned, the cases are moving to the formerly non-endemic areas. We also have seen this in Nepal, and we are debating. I mean, everybody's talking about maybe the impact of climate change. Right, so the vectors are going up with the higher temperature, with more different rainfall pattern. And of course, it's not only maybe the climate change, but also Dr. Tanujay mentioned, now transportation is better, so people are moving around more than ever, right? So, and of course, surveillance is also strengthened because so much elimination effort in all these three countries. So we are seeing more cases in the formerly non-endemic areas. So there could be the immediate priority and long-term or mid-term priority, but I think the immediate priority is really to ensure a resilient surveillance system, very strong surveillance system, which means make sure you have a capability for diagnosis and treatment, even in the area formerly non-endemic, and up to the close to the village, up to the PhD level, and then also continue to train the health worker. Again, I think everybody already mentioned, include in the in-service curriculum for the trainer, the hospital staff, nurses, healthcare workers, village workers, so that Kala-azar is not eliminated from their knowledge. They have to know, they have to continue to know how to suspect, how to diagnose, how to refer, how to report, right? And then community awareness. Those people in the formerly non-endemic area, they probably don't know anything about Kala-azar, and of course PKDL. So now is the time that you have to raise awareness among these formerly non-endemic areas about the potential risk of Kala-azar PKDL, not only the healthcare worker, but in the communities as well. So all this we have to, and then we cannot do beyond elimination just for Kala-azar campaign, right? Because it's not realistic. So we really have to integrate. So I think in the earlier session on LF, there was the suggestion of integrated community awareness campaign, for example. We need to integrate, and I think this the program is an excellent example where you can sustain the capacity awareness of the health workers and community. You said like 3 times in a year and continuously through the health system. I think this is the way forward. So India is already doing it, but other countries are not really doing it. So our job is also to facilitate cross-learning. So the good example in one country can be replicated in another country or in another area, right? So that's one thing. Then midterm or long term, and of course, we can also, maybe this is where the research community will come in. Maybe to integrate climate change or environmental data into the epidemiology, disease data, and also vector surveillance, entomological surveillance to be strengthened, so that you can create a predictive model, so you can also anticipate the risk area, future risk area. But unless you have a good surveillance, any model, it's garbage in, garbage out, right? So you have to have a good surveillance before even going to that. So this is the top priority. And finally, again, this is already mentioned. After all, for the sustainability of the impact of any disease elimination program, we have to really tackle the root cause. So again, India has already an excellent example of the tackling the disease program, Kala-azar elimination program, tackling the housing, and also community hygiene, so that we tackle the root cause of the transmission, but also root driver of vulnerability for climate change or any potential future risk. So I think this is the 3 areas that will be the focus.
Thank you so much, Dr. Kavita. You work for drug for most neglected or marginalized population. How can we ensure that research and innovation pipelines are guided by equity, principles of equity, from drug development to drug delivery? How do you see communities and patients playing a more proactive role or a central role in this effort?
Thank you, and I believe it's one of a very interesting question. I say interesting because many of us, when we were young, when we were maybe in medical school, we used to think why this drug is not available, why it is not, my Indian patients afforded, why it is just not accessible. So it is because, many times we think, and when you also asked me the question, you started from drug development. But actually, if equity is the concept and profit is not the concept, it starts from discovery stage. It starts even when the medicinal chemist is looking at screening his compounds. Because the ask here, like you asked me, your previous question was, can we have a single dose? Yeah. So, and we asked it for a country which has a temperature of 35, 40, 45, right? So you want a oral dose. You want a dose which is stable, or you want a drug which is stable. So it means the chemist should have that clarity, what am I looking for? That's why the equity starts at the discovery stage itself. We could not have mRNA vaccines because they were not meant to be equitable. But for diseases like ours, like neglected diseases, it's very important that we share this concept right from the beginning. The second thing which we can do very well is do much more, have a leverage to do more inclusive clinical trials. And when I say inclusive trials, like you're talking about leishmaniasis, there is the undernutrition patients respond differently. Patients with HIV co-infection, with TB co-infection, they respond differently. Relapse responds differently. But if you see in a classical clinical trial, you have a very stringent inclusion criteria. You can't have pregnant women, you can't have the participation of women of childbearing potential, pediatric. So in other indications, it's okay to do different trials, right? But here, when the when you need the drug immediately, you need it for the population, how do you run such inclusive trials? Can we have leverage from the regulator to not create such stringent protocols, which we have done for our Novartis molecule? We had no option. But because if equity is at the heart of everything, then these are important points. The third point also which I would like to talk about is the concept of licensing, where the country, the government making voluntary licensing or mandatory licensing at times, if it is that big a problem, a conversation brings it on the table. We shouldn't be shying it away if our own population needs it. Lastly, the point which you had also asked was how does the community help us? Community can really become a part of, and we've in fact just Manisha is here. She just launched a community advisory group here. How do you it's easy sitting in a boardroom making your protocols. It's easy planning. This should be the end point of my trial. Is that relevant to the population you're going to work in? I'd love to share examples also of that. How much should a patient get as when he participates in a trial? How much should he get it as a wages loss? What is that? How much in that particular geography? What a wages loss means? Can a woman participate alone? Does 2 members have to go? So do we have to take care of wage loss of each of them, their travel costs? So all this information, which all this ultimately helps us towards an equitable access. And I'll give you a very small example. We have also started this process now when we are making a target product profile. Let's take the feedback from the patient. So for example, there's a disease where patient is more troubled with, say, headache, but our endpoint is fever. It's a hypothetical example. Will that acceptability of that drug would be high? Maybe not. So again, it's a tangential way of looking at equitable access. For PKDL, if you ask the patients what do they want, they'll say, daag nikal jaye. Let this disappear. This patch should not be visible. But is that what you want as a physician? No. Maybe she would say, no, within 2 days, get my, the parasite away from my the lesion the melanin pigment and the coloration can keep coming back. So that balance, advising your target product profile, your clinical trial design, your licensing, and then of course, government ensuring that there's a pot of money to procure that drug to be made available to our patients. So multiple ways we can act towards that.
Yeah. Thank you so much, ma'am. Tanu ma'am, Kala-azar is a disease that requires collaboration and concerted effort of different departments and ministries, Ministry of Housing, Education, and Nutrition as well. How has the Ministry of Health and Family Welfare has driven this convergence across different ministries, which of course could be sustained in future as well to eliminate Kala-azar transmission from the community? How we have achieved that?
So this is a very pertinent and important question over here because I think all of the experts have touched on this topic. And I really don't need to delve deeper into it like Dr. Rautre talked about Dastak Abhiyan. So let me also tell you, when I'm reviewing the states, then I realized Dastak is a very, known kind of a program for UP. But now many of the states have picked up on this and they are having such kind of programs wherein they are doing a holistic door-to-door campaign and in which they are not only just focusing on a single disease or a single situation. Situation means like the housing, the sanitation, the hygiene, the nutrition, the ICDS. And I think in Vectorborne, the best interministerial collaboration has happened in LF. And VL, of course, because we had smaller geographies affected with it, so we could do it at a very local level, like the PRIs were involved, like the DCs were involved, the block medical officers, the BDOs were involved. So we could do it at a very local level because the most of the, almost, out of the 633 endemic blocks, if you look at a total figure, almost 50% of them are not having any cases. So it was a very local kind of a thing. And that brings me back to the question of your housing, because that has been coming again and again. And we've had challenges with even with the Pradhan Mantri Awas Yojana, because as you said, they're not willing to live in that. Two, because they just want to save a little bit of money, so the cement and the brickwork is done, but the plastering is not done. And if the plastering is not done, the crevices again remain. So instead of, unnecessarily promoting such kind of a situation, which is beyond this thing, even mud plastering works well if it is done well. So we have to get rid of crevices, that's the main thing. Intersectoral, I think even in the ministry now, the thought is that we should actually even review more programs. So you are aware that there is a regional office of health and family welfare, and now NCDC branches are coming up. And so these are the areas wherein now health will be collaborating more and more with the research bodies. And in the recent past, we have been collaborating with ICMR, VCRC, RMRI. So I'm actually surprised to see Dr. Krishna is not here. Yeah. Okay, that you didn't have that feature. So the thing is that I feel that intersectoral collaboration, in fact, I feel that everything hinges on, we don't talk about the quality of life here. So if you want to give your citizens a good quality of life, then you have to really think of everything. You can't just think of, okay, fine, this person should have this drug or this drug. I mean, how many drugs can we keep on introducing in the system? So that is really very important. And then when talk about integration, you talked about IVM, that we should integrate the vector management. Here, I don't know, it's a little tricky because vector management for each drug, I mean for each disease is a little different. And if we integrate too much, then the focus on that particular activity goes. So even globally, I think there is a lot of thought process how much to integrate. So integration beyond this, like the technical integration is one, but yes, integration of the line ministries such as ICDS, Anganwadi workers, education, agriculture, because these are the line ministry, and they're very happy to integrate with us because this experience we got when we were doing LF program. So this is it's on our radar, and we are doing it a lot. And even in the malaria meeting that we had, we tried to involve. Now the challenge here is that how to involve these ministries, because everybody is busy with a lot of their own works. So if you give them some kind of a focus thing which falls within their purview, within their work allocation, then they will be able to help. But if you bring up something like you take care of our problem, then that will not happen.
Yeah.
And yeah, so that's all from my side. Thank you, Shava.
Thank you so much, ma'am. Professor Mitali, you are having a field-based some suitcase where we diagnose PKDL, but you also see leprosy patients often and misdiagnosed. How do you maintain collaboration with the leprosy program? What are your experiences of the stigma that a leprosy patient or PKDL patient faces in the community, and how do you address that? How to move forward?
Okay, so when we think about PKDL, we need to keep in mind the fact that, as we said, the challenge is the macular lesions, which are almost 50% of the cases. And that's when we realized actually that the clinical features are so similar to that of leprosy that even a specialized person, even a dermatologist actually faces this dilemma. Is this a case of leprosy or is this a case of PKDL? Especially if they don't give a history of Kala-azar, which does happen in some cases. So this was really a challenge that we realized exists, and that we have to find a solution. The same problem is there, like in leprosy, the social stigma that is associated. People don't come forward, they do not want to be treated. And as Dr. Kavita said, they are not at all happy actually with the treatment they get. When we did a survey and we asked them that, the PKDL treatment, are you happy with the treatment that you received? 12 weeks, there is even a financial incentive. And they said, no, we're not happy. And I asked, I said, why do you? He says, the lesions haven't gone. So if the lesions haven't gone, why did you, it's like, why did you inconvenience me, ask me to have a drug like miltefosine, which is really not fun to have. I mean, it's quite a toxic drug. You have episodes of, vomiting and diarrhea, and, you run the risk of ocular complications. So it's really difficult to have adherence. So the same, the leprosy and PKDL have the same problem of long treatment. So we need to be very sure that when we are treating them, we are 101% sure that this is a case of PKDL or this is a case of leprosy. And what we are finding actually, which is a very important aspect, is we are even having cases which are having PKDL and leprosy, because they both exist within the macrophage. This was something that came up, and this could only have been done when we ask them to come. So this is very important, that when we have integrated surveillance, the ASHA worker should actually be trained to pick up cases of leprosy. Keep in mind that this could be a case of leprosy or PKDL, and not be treating them in silos, because there are tests available. There is we are trying to develop a field applicable, because now what happened with the COVID-19, the plus side of having a disease like the COVID pandemic was that actually small centers also learned how to isolate RNA, learned how to do, PCR. So it's, we have the technology, we have the expertise. And, I remember I attended the meeting where the medical colleges were to be trained. And it's really a very good, very important for them. And it's actually helping them. And, they are now being able to, because I think, this is also very important. Because if we think of, every 10 to 15 years, if we think that there will be a resurgence, the commonest cause will actually be the mobile reservoir, the PKDL cases. The Kala-azar cases will come to you because they will have fever. If they're not treated, they may not, survive. So they will come to you anyway. But the PKDL cases will not come. So that's why, and we need to learn lessons from the leprosy, so like we have active surveillance for leprosy, we thought we had eliminated the disease, but now India, we are seeing a huge surge in numbers. So we need to, consider both these diseases together if we are to, make a dent as far as neglected tropical diseases are concerned.
Thank you so much, ma'am. Ma'am, with the permission of chair, ma'am, can we open the floor for questions?
I think it is high time because, you may be having a lot of questions, so you may please go ahead and ask some.
Anyone, please, if you have any question, please ask. Yeah.
Who should be on this side, actually?
I think, yeah. Please come here.
Share your experience here.
So, yes, you have told me that I'm very old. Yeah, in fact, this is almost my 30th year since I've been working on leishmaniasis. Of course, I'm not looking at leishmaniasis much now, but so at that time, we were worried about how you will be able to find a simpler test to diagnose, because we had to do bone marrow or spleen. There's no other way out. And at that time, there was no other drug other than antimonials. And I don't know how much you are familiar with using antimonials. You had to give about 5 to 7 ml intramuscular. Now, if you see those patients, they don't have any muscles. They are very wasted. They come very late, 3-4 months. So, we were in a different, paradigm at that time, is looking at it. So I'm just observing that over the last 3 decades, our needs have changed. And we don't think of people, dying of Kala-azar because we diagnose them, we have effective treatments. Now, from WHO's perspective, of course, Aya has mentioned to you what we can do. But what I really think is this morning, we were having a meeting with one of the donors. And of course, I am being a director of communicable diseases, I talked about communicable diseases, but there was not a great deal of interest in most of the communicable diseases. So where we need to pitch is we have to look at it from the USC and a PHC package. So we need to see our integrated approaches for diagnosis, for treatment, for surveillance, through that pitch. This is what I think we need to start doing. Now, Satyabrata mentioned that we need to continue to do vector-borne disease, vector control. I'll tell you, it will be very expensive to work in only for Kala-azar. You need to find a way that, maybe you don't even need IRS spraying as a campaign, but only those areas which are having cases. So surveillance is the key for us, I think, and this is where we can pitch in with NCDs and others, because, it's a very good example for integration if you look at it as a multi-disease approach, because these are things which are, getting more and more traction. And there are certain countries like Brazil, they're looking at 32 diseases to eliminate, including non-communicable diseases. So we need to learn from how they are trying to utilize these type of approaches, the platforms they use, and what is the integration. Now, one point I think what we need to keep in mind is the changing environment due to climate. And I've seen this in Nepal, because in Nepal we had reached the elimination targets in 2013 in those endemic areas. But then the cases started to be recorded from the hills. So that's where the problem started. So I don't know
because India is reaching 3 years now. Do we have the data for those hilly districts? Because we should go beyond the 4 states. This is my request. And because otherwise, we will have those questions. So we have, you need to have those data, you need to have the monitoring, all those things which are, sorry, it wasn't my fault. So that's one thing. The second thing is intersectorial. We have talked about it. So let's start talking to others. So today, next time, let's not have a Kala-azar meeting. Let's have an integrated meeting. That's the way to start. And the other point is, there is always a tendency. I give you some examples. I was at DNDI, and we were trying to push for Kala-azar, continued, research, discovery in one of the, institutes in India. So when we went there, we talked about it. They had a microbiologist who made a proposal in their scientific advisory committee, and they were told, now stop working on Kala-azar, because Kala-azar is gone. So you see, there is also a tendency from even the researchers to be asked not to work in Kala-azar. But there are still many research questions which we need to continue to answer. Because you see, at the end of the day, our ultimate, is to understand the disease and see whether we can truly eliminate Kala-azar maybe in the next 2-3 decades. So this is my request for researchers to not abandon Kala-azar. So thank you. I don't want to take too much time. Thank you. And I really congratulate. And Bhupendra mentioned about the political commitment. And I think the political commitments tries to get everybody involved. So this is critically important to continue that. So now we need to see what makes the political commitment continue. So this is what we need to understand.
Thank you so much, sir. This was very insightful. Yeah, so anybody else, do you have any question to ask from the panel or from me? Then, ma'am, can we have the closing remarks? What do you suggest, individual closing remarks from everyone?
So
Yeah.
All right. I have tried to sum it up somehow, but we can have individual also. Maybe one sentence from each, because it's really important.
Yeah.
Because so while I was, I'm not a very good fan of such kind of conversations where people who know just talk amongst themselves. So I'm more like an action-oriented person. I'm a field-oriented person, and I really like to go in field and work, and all of you are aware of that. But every time I do attend very, very reluctantly such type of meetings, I'm always enlightened. So I always think, no, I should actually come, because we do feel that we know everything, but these are the times when the certain things which have been going on in our minds, and then suddenly someone says something and it clicks and it works. So these type of sessions are also very important. So we'll hear from all the experts, and then I'll try and sum it up a little bit. So as you go ahead.
Yes, ma'am, please. Dr. Tripathi, can we start with you? Closing remarks.
So, no, thank you so much. This is very helpful. My only one point would be, at this point of time in the program, intensify surveillance. Surveillance, it can be active and passive surveillance one way. Second, it will be integrated vector surveillance. And third can be zero surveillance. Like we choose a specific cohort, it can be WHO ICMR recommendation, 5-6-year-old kids. Let's figure out whether they are carrying the antibodies or not. And then, this is going to help in reaching elimination actual. So I will focus on surveillance, good surveillance, perfect, actual data, sharing with the program and moving forward. Yeah.
Thank you so much. Dr. Aya, please.
Maybe two things. What Dr. Bhupendra mentioned is all in our regional strategic plan as a priority research. So please, researcher, take it up. So that's one thing. And then maybe I will take up from what Dr. Suman mentioned. And as I mentioned in the previous session on the financing, I think it's very important that Kala-azar in this region has so much success, but the Kala-azar community keep talking. But outside Kala-azar community, not many people actually know when I came from the Western Pacific region to this region, I have no idea about this success at all because we don't hear in the global community, outside the Kala-azar community. So and then we keep talking about LF progress, right? I think we need to communicate more about this success, but then also for resource mobilization, we have to go even outside the NTD community because we keep talking about the importance of advocacy and resource mobilization within the NTD community where nobody has money. So, but then NTD program is such a comprehensive program. Because we have so many diseases, even just Kala-azar, you do vector control, you do active surveillance, you do case management, and all these activity contribute to the health system strengthening, PHC strengthening, right? People talk about NTD as outside PHC, but Kala-azar program is very much inside the PHC. The RDT is already in PHC. People have been detected by PHC, but people again don't know. So I think there are more opportunity to collaborate or to mobilize resources outside NTD community, outside even the communicable disease, the community, where the health system, PHC strengthening, even pandemic fund, One Health. I mean, we are already, NTD program is related to everything, every function of health system. So we have to sell how much Kala-azar program, NTD program is contributing to every aspect of the health system. So that's my closing.
Thanks. Dr. Kavita, final comments, please.
I'm just reminding all the stakeholders and all the audience here that this is the 20th year of signing of the agreement between India, Bangladesh, and Nepal. And this needs to be celebrated before the year ends. So leaving a request here that let's get together. And also, what you said, Dr. Tanu, the messaging, the experiences, learnings, so that it can impact others. Same disease, other diseases is important. So let's take it up, please.
Rotre, sir, please.
Yeah, so I think we all agree that integration is the way to go forward. And as we go down with the diseases towards elimination, it's good to get all the diseases together, and programs like Dastak and SRNA are bright examples and models of integration and exactly horizontal and using the PHC system, and it's already a working model which we should be taking up. It has interdepartmental coordination, it has community participation, and these are the pillars that will help to sustain the elimination.
Thank you, sir. Professor Mitali.
I'm reminded of the little story we used to hear about when we were children, about the bundle of sticks. If you take one stick separately, you're easily able to break it. But when you hold the bundle of sticks together, you cannot break it. And I think that's really what all of us here, and I think all of you will agree, is integration, starting with surveillance. And when we say surveillance, not just, a door-to-door surveillance, but surveillance from various aspects, and we converge and then come together. And at the risk of sounding like a stuck record, I'll say that PKDL so far has been a neglected component of a neglected tropical disease, but let's not keep it neglected. I think we have done, we really have achieved a lot, and we should continue that momentum. And I think that would be the way forward. Thank you very much.
Thanks,
Thank you all.
That was very thoughtful and futuristic. Final closing remarks and summary from Tanu ma'am, please.
So I think thank you everyone. You have really given us a lot of food for thought. But it's not just food for thought. We want all your support, every one of you sitting here and there. Because it is, India has done excellent in collaborative efforts. If you talk about the National Health Mission itself, it is a very good example of collaboration. We have a flexi pool wherein now the budgets are available for all the 36 diseases that are, including RCH, including communicable, non-communicable. We just had a very successful, almost 4 to 5 months, we've had a very successful review of the project implementation plan, wherein the budgets that were given for biannual budgets, so yearly budgets were reviewed. And supposing, say for example, someone took the budget for some particular issue and they could not utilize it, the other disease needs the budget, they are shifted. CHO as a cadre has come up, a very good community health officer as a cadre has come up. And as Aya also very rightly said that the neglected tropical disease programs are very well entrenched within the primary health systems of our country, and not only the primary health centers, sub-centers, and much beyond to the village level. In fact, sometimes I feel the urban areas are the neglected lots. So now the rural areas are very well catered to, and there is a lot of information available there. And but I think taking from Dr. Mitali, I think I do agree with you. And I was talking to the leprosy program officer. We have already come up with a plan to integrate leprosy and LF, I mean lymphedema, and Kala-azar. So I think we are looking for a time to actually sit down, concretize the plan, get it approved from the highest authorities, and put it in place. So that will really help us, like the LCDC campaign which happens. So we've been talking while the LCDC campaign is happening or the ACD is happening for VL, then if there is any suspect case, it has to be cross-notified to the other program. So that will be hugely helpful. And with the type of, kind of momentum that LF has gained, and I think it has done even better than LCDC at places. So this is one platform wherein the same person, Asha, or the community health volunteer, it's the same person who's going house to house, so they do have that knowledge, and we need to take it more closely. So that is what I think is important. I think you mentioned a very important thing, that you're not getting patients for trial. Even in malaria, Dr. Anup keeps on telling me, Madam, where are the patients? How do I do my drug trials or therapeutic efficacy studies? India is a big country, and 485 is not a big number at all for us. We are a 1.4 billion people country. But even in malaria, this challenge is being faced, because when you need a huge number. So I'm happy we don't have cases, but I'm sure research has other ways of doing things rather than, yes, so regulations are stringent, but yes, of course, definitely. But we'll see how we can help you in that, definitely. And I did talk about IVM and IRS and all those activities, and I do agree that I have been saying this, and if Rautre is saying that, Dr. Rautre is saying that, no, it's still not happening, that 6 feet is covered. Why sandfly is going to restrict to 6 feet? If it has to survive, it can hop, 1 or 2 inches above. So I've found it very silly from the very beginning that we are underestimating the power to, the will to live. Every living creature wants to live, whether it's a parasite, and they have lesser job to do. We have to dress up still, sit in a panel discussion. They just need to survive. So, so they will find out ways to survive. We should not underestimate. And yes, in the vector control group, the global group, there was a discussion on LLINs, and there was a discussion on the curtains, and there was a discussion, but I think we're still waiting for those guidelines to come across, and then we will see. But then the insecticides are also limited, so we should not overdo or overuse the insecticides and then sit around with, but yeah, we have done susceptibility with VCRC, and so far, fingers crossed, the sandfly has been found to be susceptible, and they have done the cone bioassay also. So we are in a good situation there. I got a very good suggestion of a museum. So I think that's a very good suggestion. At NCBBDC, I will definitely find out a room, and I'm going to put up a museum where we can put the historical aspects, because even I am not aware. See, I've been working in this field for 3.5 years. I come from emergency and trauma field. So it has, it will be very, very, eye-opening for me also, just because in our curriculum we would read antimonials and all these things, but to have all this in place and to have a museum, this was my dream when I joined NCBBDC, but now I think, please remind me time and again that I have to do that. I will do that. And yes, community awareness is very critical, and asking people to take their health in their hands, I think that is the key to it. How long can we go on knocking at each door, dastak, which means dastak means that. So how can we, just every time you take this drug, you take this drug. Why? Why can't people themselves be responsible to, keep their surroundings clean, keep netting around the house? They know that mosquito is creating this nuisance. So I think that is very important that they take that. Health system strengthening is happening in India, but as you talked about it, there are other countries, neighboring countries, we can have these examples, because a lot of activities have been done for health system strengthening in the country. So that is good. And how you escaped the donor financing part, that was nice. I do agree that that was really nice. I do agree that government is giving a lot of fund, but the just having that TSU, just having those few people in the field who we can rely on day in and day out. So I can call anytime Zoya, or I can call anytime, Rajshri or Jairam, and then I know that, what I need or what the program needs will be, done on time. So you cannot undermine the donor support here. And not only that, to bring us on such forums and put people together and knowledge exchange, and this is also very, very critical. So donor doesn't mean that you have to give drugs and diagnostics and incentivize the patient, but this is what is the role of a donor, which we really need, that it should be continued. We need to involve medical colleges in everything, like leprosy. When I had leprosy for 6 months, I was given that program, and then I shifted to vector-borne. So then I asked my colleagues, that what is the situation of leprosy? In medical colleges, they said, still you're talking about leprosy? Didn't we eliminate it in 2005? Similar situation happened for VL. LF I haven't really asked because it is very focal and localized, but LF also, people don't know that we have almost 7 lakh lymphedema cases. So medical college involvement, even in malaria, I had medical officers coming to me, 30 medical officers from high burden districts. I called them and I asked them, how do you ensure completion of treatment? So what they said was, madam, we have read in our curriculum, but in field, we don't even, then I said, okay, I'll do your prescription audits. And then I found that they don't even prescribe for 14 days. How the patient will know he has to take for 14 days? So that is why in the last 2 days, we had block medical officers and district medical officers of 37 high endemic districts. And today in my closing remark, I told them that only thing I need from you is treatment completion to ensure that it happens, and to follow up for any side effects if Primaquine is having any. So that is really critical for us. And I will take away that from Dr. Suman, that focal spray. I think, Shabar, you need to look into that. Focal spray is really important. And one-time mapping. These are 2 things. Climate change mission itself is doing a lot of work, and we are already involved ourselves in the mission, and there are a few things which we have already been given by the Secretary Health to work on. We have started to work. Any support in that is most welcome. I think I told you also, Bhupinder. We are also actually looking into prediction models. So hopefully we will have something in place on the IHIP VBD portal. So we are looking into it. We did discuss all these things. So once again, I think I've been able to sum up mostly all the things. And to Shower, of course, you've been an excellent moderator.
Thank you so
Yeah, so thank you so much for this. An excellent audience. I don't know, you didn't doze off, so I'm sure it was a post-lunch session. Thank you so much, everyone.
Thank you, everyone. Thank you, ma'am, for chairing. Thank you, esteemed panelists. Thank you, Suman Rijal, sir. Thank you. Thank you very much. We are just on time. Yeah, thank you very much. Group photo. Ma'am,
welcome to this session on improving nutrition outcomes through innovative approaches. In the global south, particularly South Asia, communities face significant nutritional challenges stemming from poverty, food insecurity, and limited access to healthcare. Today's discussion will explore effective regional strategies that have successfully addressed these challenges and improved health outcomes for vulnerable populations. This important dialogue is hosted by the Children's Investment Fund Foundation, IP Global Limited, and the Institute of Economic Growth. I would now like to invite our distinguished panel to the dais. May I request our session chair, Sri Rajeev Kumar Sen, Senior Advisor at Niti Aayog, to please come forward. Mr. Sen oversees the Health and Women and Child Development vertical and brings nearly 3 decades of experience in key government positions. I now invite Dr. Usha Jha, former member of Nepal Planning Commission, to join us. Dr. Jha brings over 20 years of experience in health, education, and nutrition with expertise in developing strategic interventions for marginalized communities. May I also now request Dr. William Jo, Assistant Professor at the Population Research Center, Institute of Economic Growth. Dr. Jo is engaged in monitoring and evaluation work for the Ministry of Health and Family Welfare and serves on several technical advisory groups on nutrition. Please also welcome Ms. Mandira Nagrath, Lead of Sustainable Community Development Program at Hindustan Unilever Limited, with 18 years of experience across development sectors. She currently spearheads Prabhat HUL's Sustainable Community Initiatives. I invite Dr. Shachi Adyanatya, Senior Portfolio Manager for Child Health and Development at the Children's Investment Fund Foundation. With over 12 years of experience in public health, Dr. Adyanatya leads work on maternal and child health, nutrition, digital health, and AI. Finally, I welcome Dr. Naomi Saville, Principal Research Association at UCL's Institute for Global Health. With 35 years of research experience, Dr. Saville designs community-based interventions to improve maternal and child health and nutrition. And I now invite our session moderator, Mr. Raghavesh Ranjan, Senior Director of Social and Economic Empowerment Practice at IP Global. Mr. Ranjan has pioneered several transformative initiatives focused on enhancing the lives of women and children, including a successful Cash Plus intervention in Rajasthan. I now request Mr. Ranjan to take over the proceedings.
Welcome everyone to this interesting session, and I welcome all the panelists and Honorable Chair Mr. Rajiv Kumar Sen from Niti Aayog. And South Asia has pioneered several innovations in nutrition sector. If we look at the Indian landscape, programs like Poshan Tracker, Poshan Abhiyan, Pradhan Mantri Matri Vandana Yojana, and many other initiatives in India pioneered by the Government of India and several state governments have been the forefront of innovations. Similarly, if we look at our neighboring country, Nepal, Suhara program, which was implemented in several districts and provinces of Nepal, showed remarkable innovations. And the Government of Nepal's multi-sectoral approach to nutrition was another similar, I will say, innovation which we saw. And similarly, several innovations in the nutrition sector also comes from our another neighbor, Bangladesh. Now, this session I will quickly, before I move to the specific moderation, I would like to share how the session flows. So I'll conduct this session in 2 rounds. The first round is a quick snapshot that I gather from all the esteemed panelists here in terms of what has worked. And if time permits, I would definitely like to move to the next part of the moderation work, which looks into what holds next. So if these innovations have happened, what's next in the current scenario exists opportunities, either scale up, go deeper, take the learnings from Nepal to several other parts of the world or from India to several other parts of the world. So what holds next for us in the nutrition agenda? And from that perspective, this will be the 2 rounds, and then I will request the Honorable Chair at the end to wrap up. And in between, I will invite the floor for questions. Therefore, I will request also my esteemed panel members to be very specific so that we are able to finish off 2 rounds and also open the house for discussion from the very learned audience here in this room. So, if I look at Nepal, and I'll first move to our neighbor, Nepal, for quick thoughts. If we look at Nepal, Nepal has made notable changes in the undernutrition, malnutrition, whatever you want to call, levels in the country, mainly through multi-sectoral strategies and several interventions which happened at the community level. And there have been very decisive role for women in this entire process. Now, my question to you, Dr. Usha, is Nepal's multi-sectoral nutrition plan is lauded to be one of the most comprehensive strategies to tackle undernutrition in the country. So from your experience, what innovations, whether community-driven or institutional, have had the most impact on improving nutrition outcomes in remote and very underserved areas of Nepal?
Hello. Thank you, Raghavesh, for the question. I think I should first of all tell you the success in terms of indicators. Because in 2001, we had the stunting 57, And now we have got this 25. So that's the one of the major indicators of the food and nutrition in the children we see. And similarly, we had wasting 11, and now it is 8. And also underweight, we were 43, and now we are 19. But then how did it happen? As Raghavesh told, we started doing multisectoral nutrition approach from 2013. The first phase was from 2013 to 2017. The second phase of multi-sector nutrition plan, building on the first phase learnings, started in 2018 and ended in 2022. And again, now we are in the phase of 2000 and MSNP 3, we say this MSNP, multi-sector nutrition plan, that is third phase, and it will go until 2030. So these are the 3 phases, and they are so important, and they are so much linked to one another. And we built the learnings from one phase to another phase. But at the core of it, it was like the food and nutrition program and nutrition security program. It was like the food security before, and slowly people started learning about the nutrition security along with the food security. So nutrition security, it changed from food security to nutrition security, and then it came down to food and nutrition security for health. So that's how it is being spelled out now. And in the different phases that we did, we had the learning that multi-sectoral, we practically said this is the multi-sector and multi-stakeholder, but it was so difficult to bring all the multi-sectoral. And during this period, our country went from the unitary system to the federalism. So there were another multi-sector, multi-layer government that was also needed to be included into that. So there were some horizontal, the government level multi-sector, like we had to bring in health education, and then we have to bring agriculture, we had to bring women and children, and then we had to bring the Mufaga for the governance, the Minister of Federal Affairs. And so those were the ministers that were linked horizontally, and similarly we linked them vertically as well with the provincial government and the local government. So there was the linkage of stakeholders the National Planning Commission tried to brought together. So in an organized way, there was a secretariat at the National Planning Commission, and virtually I was heading that. I feel very proud to say that I was heading that. And I was able to bring in all the stakeholders together. It was not that National Planning Commission was the one to achieve the result. It was other organizations who achieved the result. But National Planning Commission facilitated the coordination mechanism and the collaboration mechanism. So I think at the core of it is the institutional mechanism at the federal level, at the provincial level, and the local level. It really worked well. Though we have learnings and we have to, it's never end. We have to keep on improving all the time. But then it really worked, and people from all the sectors, from the, as you said, Suhara, and there are programs being done by World Bank, there are programs being done by SNV, there are programs being done by other NGOs. So everybody, the civil society, the government stakeholders, the private stakeholders, everybody was there on that board. And we were all talking to each other, sharing to each other, and we talked about what are the bottlenecks and how can we complement each other, not compete with each other. So that's where the starting point was. How can we really complement? So complementation increased our reach to 72 districts. So that was the success, I would say, and even during the COVID phase, the graph of going down on stunting and wasting and underweight, it didn't get any disturbance, and it went down and down. So I think the multi-sectoral approach and the community engagement through the civil society, it's a mix of both, and we need to do both to really get the success. Thank you.
Thank you so much for being so precise, Dr. Usha. Now, from someone in the government very close to our country, I'll move to one of the academicians in the house, William. You have analyzed nutrition through the lens of scrutinizing data, and for quite a long period of time. From your perspective, what emerging innovations, if I have to pick cash transfers, behavioral interventions, technological solutions which have been embedded in the programming, or otherwise which you feel and find, you see as having the most substantial evidence for improving nutrition in India? And would you like to amplify your answer if what you find could be extrapolated also to South Asia or not?
Yeah, thank you. Thank you, Raghuji. I hope it's working. Yeah. So I think broadly, as you are saying, the South Asian experience and what India is doing, broadly the lessons are similar. And to take up what can be done in this space? I think that overall, like through all different programs which work on nutrition, although we may focus on, say, during the pregnancy stage or maybe after that, the overall, I think the understanding which is converging is towards the fact that we need a more balanced diet for pregnant women, and right from beginning it should start. That is like a very strong learning coming out, because even if you look at any kind of micronutrient deficiency, you can pick, say, anemia, for example. We have been focusing on iron. It's true that iron deficiency is a big thing, but what is more even determining factor is a lack of overall balanced diet. Now, how we can achieve that? This is something a government cannot actually plan for a balanced diet type of program in a straightforward, direct way. We have to be very incremental. And that is the role where I think the development sector has to show how it can be done. And there we have a lot of evidence emerging, but we have to just like combine all these insights together into a program. So I will just very briefly mention about cash transfers. So why cash transfers are very important? And it was a very interesting question that IP Global had, that during the pregnancy stage, small amount of cash is provided for supporting nutrition requirements. But why a small amount of cash will work? That's the question. That's very important. Why even a small amount of cash would work? So that led to our understanding of three elements. One is very strong improvements in bargaining power at the household level. So we support that through cash transfers. Second is it leads to empowerment. There is more commitment towards actually consumption, more autonomy in terms of understanding consumption. And third is that through that mechanism of cash transfers, we are linking them more closely with our system. So we have our frontline workers who are reaching out more systematically, and then they are also providing more nutrition literacy. So even a small thing is working, but it is actually creating more trust in the system, also more trust among the household members, which is leading to these kind of changes. So this is combining all the different things which is triggered by a cash transfer and leading to a change which is required for improving nutrition. So a piecemeal approach may not work, and we need a more important approach towards balanced diet. And I think this will lead to more innovative models, but we have to just like understand that from where it starts and it triggers, and how different things can be pulled together at a simple level. Thank you.
Thank you so much, Professor Joe. I'll move to our panel member from Hindustan Unilever. Mandira, Unilever in India has been championing Prabhat Poshan program, and this is a program which blends a lot of innovations in the field, working very closely with the frontline workers, with the community members themselves, and also establishing solid connections with the local district administration and the government counterparts. So from the private sector's perspective, what are the most scalable and replicable models you have seen which can drive significant change in nutrition-related outcomes?
Thanks so much for having me here. I think I'll articulate it more in terms of what we have done, and I feel that itself is a replicable model. There may be more. But to begin with, exactly like you said, we started in 2019. It came from a need that we realized that our communities are not well fed. There is a nutritional gap there. And then when we started it, it very naturally, expanded, replicated to multiple locations. So at the moment, we are in multiple states, 12 sites, each site catering to about 60 villages. So it's a fairly large spread. I feel the model itself has turned out to be very replicable because it has solid pillars. So it rests on a good foundation. So the first thing is it has a cadre of local women which we've trained, who are really your last mile people who are reaching door to door, who are local, who are women, and that really helps you build a quick connect with the local women, and yet the acceptance level is very high. So we don't have to implant them, they're already a part of the society. The second thing that's worked very well for us is we are complementing what the government is already doing. So we are very close to the ICDS system. We integrate with the Anganwadi, we integrate with the work that the Anganwadi does. So acceptance, and it's complementary, right? So that works very well. The third thing is we have internal knowledge and information regarding nutrition because we're in the business of foods ourselves. So we've leveraged a lot of our own internal people to say, can you help us make recipe booklets? Can you look at our modules? Do they make sense? Can they make better? So, leveraging internal strengths. And the fourth would, of course, be working with partners who are experts in the field. And I'd like to add a layer to that. So while our implementing partners are definitely experts, but they're also people who are willing to co-create with us. So every geography has slight nuances. There are cultural difference between UP and Silvassa. So we have to have that ability to have a model, but then moderate it as per the local needs. So I think these 3-4 things has given us a model which we internally also have realized has gone from 1 site to 12. And I'm sure there are multiple such models that corporates have done, but this is what has worked well for us.
Thank you, Mandira. I'll move to Sachi. SIF has been at the forefront of supporting, I will say, very entrepreneurial programs in India and globally. Now, I know it is going to be a very difficult question for you for the vividity of programs you have supported, but I will still pin you to identify maybe one specific innovation which to you stands out, which had scale and impact, and what are some of the learnings or insights you would like to share if you pick one of them?
Thanks, Raghavesh, and thank you to all the panelists as well. So I think one of the things you have to I'm going to start with a disclaimer where when we talk about innovation, our mind immediately goes to something digital, application, device, technology. But I think innovation can also be something that's really simple. It could be about a new approach. It could be about a shift in mindset. It could be about a different way of delivering something very familiar. And I think that, again, I just want to set the stage to be able to talk about this one particular investment, which is called Rajpusht. So we worked in the government of Rajasthan, partnering with the state government and with IPE. And our goal was to strengthen PMMVY and M3PY. These are cash transfer systems for cash benefits or cash direct DBT, which is done for first and second time pregnant women. The innovation here wasn't the cash itself. It was more the idea of adding layers to this which would support it. And that would actually help convert this financial assistance into better health and better nutrition outcomes. So here we paired this sort of cash plus approach with a multi-tiered targeted behavior change. Now, what were these different layers of behavior change? We had participatory learning and action, which was about not only bringing women together, but bringing the whole community together to recognize, own the problem and the solution. We obviously had interpersonal communication with women themselves. Then we had targeted behavior change towards mother-in-laws, because we know in the South Asian space, this is a very powerful person within a household when it comes to nutrition decisions, especially during pregnancy and lactation and for children. Then we had a digital media approach which brought the husbands on board. It was very directed towards men because the money is in the hand of the men in South Asian culture and in India as well. What this did was it brought all of that together, the empowerment through cash, the empowerment through behavior change and knowledge, the empowerment through the community stepping forward, and it shifted the needle in dietary diversity. Women's weight gain during pregnancy improved, birth weights were better, there was a stronger uptake of antenatal care services, and there was improved health-seeking behavior and care-seeking behavior in women themselves. So what would I say is why this worked is what I would want to sort of touch upon slightly before I talk more about what we learned through it. So why it worked is, I think it was 3 very simple steps. The first was we embedded it within an existing system. We did not create a parallel system. The second was, and also obviously like partnering with the government. The second was that it was data driven. Data doesn't have to be about dashboards, it can be about action. And so these this data gave visibility on, are payments happening? Are they delayed? Which are the areas, geographies, blocks, villages where it's not happening? Why is it not happening? How are the frontline workers performing? And finally, there was a lot of effort into building capacity and providing support to frontline workers themselves. Now, what we have learned through this is that first, as I said, innovation can be as simple as putting the right pieces together. So, cash plus counseling plus community. And it can make such a wide difference. Behavior change cannot just be about talking to pregnant women. We have to be wider. Everybody has to be at the table. Data cannot be just for dashboards. It has to be actionable data. Everybody's collecting data. What are we doing with it, right? Frontline workers are essential. This has definitely been something that time and time again, I think a lot of us are waking up to. With the right tools and with the right support, they don't just deliver services, they can transform a system. And so these are the places where, as I would say, as an investor at least, where we've seen our learnings and our successes. And as people that have worked in this program or have followed this program over time would know, we were supporting and providing technical assistance in 5 districts in the state, with the aim that, even with our partnership with the government, when we show results 5 years down the line, they would be able to scale it up everywhere. They did it midway. Midway through, the state government was able to see that the beneficiaries are so supported and, enthused about this program. The frontline workers are so enthusiastic. The state government themselves scaled it up to all districts by year 2 of this program. And I think that would be one of the pieces that I can talk about in terms of what we were successful in through innovation for nutrition at scale. Yeah, thank you.
Thank you. Thank you so much, Sachi. Naomi, I will connect what Sachi said about women participatory action and those kind of things. I've read some of your work, which actually establishes connection between women's participation or participatory approaches, if I may say, in a different tone, have been the needle shifter in the health systems, And they have also delivered high on improving nutrition outcome, as some of your papers talk about. Now my quick question is, if you were to dig deeper into this specific phenomenon that you studied in many countries within the South Asia, which specific innovation, in terms of enhancing community participation or communities taking charge of their own lives and driving nutritional outcomes, will you say has been most effective, number one? And number two, part of this question will be why you believe that they have been successful in the contexts where they were implemented. And in most of the cases, they happened in what I will say resource-constrained environments. Over to you.
Thanks very much for the question. Yes, so my response really resonates with what Sachi has just been talking about, because we've done a lot of trials using the participatory learning and action approach, including one with SIF that's ongoing at the moment in Jharkhand. But I wanted to share some of our experiences using this PLA approach. I think one of the most important aspects of it is this attitude of adult learning, where we're looking at the caregivers and the people who are learning about how to improve nutrition, not as empty vessels to be filled with our messages, but as people who are coming with their own experience and their own knowledge, which we can build upon and that they can learn to use for themselves. So it's really crucial to the approach is that having identified problems together, the communities decide on which problem and which barriers are affecting them in their own community, and then they come up with their own tailored solutions for how they want to overcome those barriers. So that's one very important aspect. The other aspect is when we're doing counselling also, that needs to be in a dialogical manner, so we need to be asking to the family, and as Sachi said, not just engaging with the mother, but engaging with with the mother-in-law, the husbands, and trying to get other family members engaged to look at what are the barriers. You know, it's no good just saying you've got to eat fruit or you've got to go out and get your supplements. You know, people need to be able to actually access those, and they may need support from the husband to go to the market and bring the right foods home for them and so on. So it's about engaging with the entire family and working out tailored approaches for each. So we've tested out some of these PLA approaches in randomized controlled trials, cluster randomized controlled trials, and we've seen in the low birth weight South Asia trial, we actually compared the cash interventions together with food, and what we found was that combining PLA with cash improved its sort of empowerment outcomes, and that people were able to choose their own foods and dietary diversity improved, but actually the impact on birth weight was greater when we gave the protein energy supplements. What we found with the caring trial, where we combined PLA with a series of counselling sessions from pregnancy all the way through to 18 months of age, was that it was actually really difficult in Jharkhand to improve stunting because of poverty levels. So we saw an increase in dietary diversity, but the poverty level was still so high that the impact upon stunting was limited. But then in Bangladesh, what we saw with my colleagues who did a very impressive trial there, the D-Magic trial showed that using the PLA, they were able to reduce type 2 diabetes and hypoglycemia by 20% over a 3-year project. So the PLA's got a lot of scope, but it does need to be combined together with social transfers, in my opinion, in the most disadvantaged populations. Thank you.
Great. Thank you so much for blending the learnings coming from Jharkhand in India and also what you observed in Bangladesh. And and thank you, my dear panelists, for being so great on time. So thank you so much. And now, before we move to the round 2, which is more on the road ahead, which is about scaling with equity and impact. That's what I will label it. I would like to quickly sum up what some of the specifics were emerged during this session, not to definitely undermine the summation and the road ahead thing that our Honorable Chair is going to talk about. So the key highlights were multi-sectoral approach to nutrition, which Nepal demonstrated, which was a blend of what I will say locally driven solutions, steered with huge amount of reforms which happened within the institutional structures of delivery. The second piece that I learned from the work of Hindustan Unilever is about women as the agents of change, how improving or making positive deviances and using positive deviances as the case for societal transformation works brilliantly well, at a very localized level. Sachi talked about how innovations can be simple, cash plus counseling plus community engagement is the way to go. Naomi talked about the power of participatory learning approaches to shift the needle on nutritional outcomes. And also she said that PLA blended with cash or other kinds of transfers are more enabling situations to steer nutritional outcomes. Now I'll move on to the round 2 of the program of this session, and I'll go back to Dr. Usha Jha. And there is a need to talk about the current geopolitical situation which is happening and which we see, which is affecting most of the developing nations. Nepal has been one of the major recipients of international aid, and significant amount of what I will say homegrown yet Nepalese innovations were funded by international organizations. Now, as you are shifting from what I will call donor-led models to what is called domestically financed structures, how do you see the innovations which happened in Nepal are sustaining and institutionalized within the government structures, and more specifically at the local government levels where it's like Nagar Palikas or Gaon Palikas, as they say in Nepal? Over to you, Dr. Usha.
Thank you, Raghavesh. The one thing is that I've been hearing all of my panelists, and I see most of us are on the same page. We are at the age of localization, and we are at the age of cash plus, and we are considering the community engagement. And when we talk about food and nutrition, women are at the core. We can't move on without women. So these are all the basic things that is very common to all of us. Now about the question that you have asked about the USAID and all these things, I would say that there are positive and negative interpretation of this as well. So what I see is USAID was funding Nepal since so many years, and there has been a foundation already set in Nepal. And Nepal has been able to develop so many legal environment. There has been a positive move. And though if the funding stopped, the funding has stopped, and people are really very much worried, and there is a discussion going on everywhere. How do we do it? How do we really reach the people with the funding? USAID was supporting us to reach those people. There are so many questions raised, but then again, innovations are being discussed as well. So there are some innovations that has come. One is the National Planning Commission as a part of the World Food Summit 2021. We had a series of discussions at the provincial level and the federal level, and we have now on board the food system transformation strategy, and which is in a very localized model, where it's very much of the work is put to the local municipalities. So local municipality, it's now going to be the leader of food systems, because what we have been missing through all this is that we are really losing the indigenous food. We are really spoiled the food system that is at the indigenous level. So we now have started thinking of rebuilding that. So that is one thing that we have been able to define through the food systems dialogue. It was continuously, there were 10 dialogues in all of the provinces and federal system, and we now have a transformation strategy that talks about 6 action tracks over there, which really talks about the access, affordability, and utilization and sustainability and inclusion. So these are the 6 action tracks that is in the current context about the climate resilience. So food system action tracks, it's very much a part of the food transformation strategy. That is one that has been endorsed by the ministry for now. So we will be using that. And there is another that has come as a legal environment and very much supportive and very much decentralized, is Right to Food and Food Sovereignty Act. And that act is now facilitating all of us through the Ministry of Agriculture, engaging all other ministries as well, multi-sectors and everybody, and National Planning Commission would still lead that. The coordination part and the collaboration part comes to National Planning Commission. Otherwise, it is implementation. Everything will be done by the local. And there will be policy support from the federal level and the technical support from the provincial level. So that's how it is being defined. So there are certain innovations as a part of the problem that has come here in discussion. And we have got these 2 major instruments with us. And these 2 instruments is basically helping us localize all our knowledge and build on the local knowledges, and try to make it cost effective as much as possible. So, and there are so many other things that is already happening over there, as we were talking about the Cash Plus program. The government of Nepal has defined the Cash Plus for all the under 5 children in all of the district, and it is already on there, and especially in Karnali, it is for every children. And in all of the countrywide, it is for the Dalit population only. So for the marginalized population, there is a special consideration that is being done by the government of Nepal. So certain interventions are coming as a result of the problem that we are in. And I hope we will be getting more innovations as we discuss further and we learn from the South Asian experiences. Thank you.
Thank you. Thank you so much, Usha ji. I'll go back again to Professor William. Now my question is more forward-looking, William, like it was posed to Dr. Usha. How do we better integrate data, and monitoring systems, to ensure real-time tracking and more directed towards what I will say is adaptive management of the different schemes and programs on nutrition, especially as we scale innovations across diverse geographies in India?
Yeah, thank you again. It's a very complex question. Like, I think all the programs, they capture their own data. But thing is that they don't talk to each other then after collection of data. Plus, the way the data is captured is, it's like all the indicators are there, but at the end, we are not able to derive meaningful inferences from the data, which is possible, but still we are helpless. So I think while designing the framework itself, we have to be very conscious about what we are going to learn from that and how we will communicate that at the highest level. If you want support for the program, we have to show evidence for the program. And there is nothing better than administrative data to show that. To do that, I think we have to then think of new ways. Now with all digital, I think technology is coming up with AI discussions everywhere. It's quite feasible, and even government is also thinking of new ways to integrate all the different data systems, maybe within ministries, but I think it's important that if you take a beneficiary perspective, we have to take that also into consideration, that how we integrate that data. And there comes like bigger challenges about, despite our intent, we are not able to achieve that. So this is something that first we have to resolve at the application level, how we can integrate all the different data that we have. And to do that, I think there are lots of solutions available, but many important other aspects which we have to consider is the way we aggregate data. Is it like at the individual level, or is it at a, say, geographical identity, which is a very big kind of a dichotomy when we go about administrative statistics. So if we go into geography, then we are not able to study more about the individual, whereas we want tracking. But the difficulty with tracking is that we are then not able to use that data with other things, or we are just tracking in silos. We track for, say, 9 months, then we track it differently for the child and differently during ANC. So we have to think in a more continuum about how we can pick up data. So that's very important. And I think like going forward, a proper review of how we use those indicators, because I see like a lot of data points are available which are necessary like to derive inferences, but we are not able to convert them. Either denominator is a problem or a numerator is not very clear. So some of these things we have to take into account. But from technology front, I am very optimistic that there are ways to resolve this. There can be more efficiency, and with more automation, I think our data managers will be more happier to actually work with new systems. It will reduce their burden on data collection, the efforts that goes into. One other important thing is that the duplication of data, which is in terms of reporting or in terms of efforts required for reporting. The same thing you have to report in multiple formats, that can be also improved. Once we adopt more forward-looking technologies, integrate the data, but thing is that we have to work on a framework for that. And that's very critical, and it's not only within a particular ministry, because there are multiple ministries working on a particular beneficiary group. And their outcomes may be linked, but the programs are different. So they are not talking to each other, but I think that more sharing will be necessary in that point. So I see like a lot of scope for that, and probably some of these efforts should start like straight away. I think all of us are expecting that we get a good kind of continuity between, say, the Anganwadi center data and the sub-center data. So these are actually currently like, this is the most fundamental requirement that we have. And if once we start with that, I think things will fall in place, and we can then continue learn from that experience and integrate more data. Thank you.
Thanks, Professor William. So, two things I gather from what Usha ji said and William said. One was about Nepal looking at what I will say is more of an inclusive and nutritious food systems approach as a way to build up sufficiencies, affordability, accessibility, everything going until the last mile in the country. And on the data side, which is also important for a context like Nepal, this having an overarching framework which very clearly defines the trail or the pathways of different data coming and contributing to that overarching framework. And the second one was related to how do you use the power of AI/ML in terms of analyzing, interpreting, and communicating data. I think one important aspect is how do you make information or data more understandable to the larger audience, because there is a lot of disparity in the way the academics process and consume data versus the same data if it is available to layman, how do they consume it, right? So thanks very much for going there, and suggesting these pathways on two different aspects. I'll come back again to you, Mandira. And the question is that I'm aware that you are thinking of taking Prabhat in an expanded as well as in an intensive manner, which is both breadth and depth side of things, Now, one thing, the first leg of the question I will pose to you is that you did mention about some of the lessons, but what are the additional lessons that you are considering in ensuring this alignment between the corporate intent and the public health outcomes in part of your expansion and going deeper into the Prabhat process? And the second leg is, how do you think we can ensure that such private-public efforts are amplified and are both equitable and sustainable in longer run?
It's a great question. The first learning really is that, and it's not something that we've learned, I'm sure everybody who works in the sector has learned it, and we've had our own trajectory of learning. But it's really that a program starts small, but then has to have layers, So you may start by saying, let's educate, but then you realize behavior change is very hard, only educating is not helping. So now we've got another layer to say exactly what someone else was also saying. Let's work with family. Let's work with the mother-in-law. Then comes to the point of affordability. A lot of the locations on which we are present are very rural. Very tiny places. Some are peri-urban as well, but some are really rural. Women have no bargaining power at all. No income in hand. There we found a simple model to say, can we just give seeds and get them to grow their own food? Really simple to your point. Keep it simple. Because my experience is also this, that if you overcomplicate it, it fails on the field. If you keep it simple, people pick it up. That's a huge learning for us. So if you try to make really elaborate plans, it doesn't work. Keep it simple, 2 point, 3 points, people will catch on and it'll replicate on its own. So major learning has been that as you stay longer in a territory, and for us, we don't move out because we have a corporate presence there, so we continue for 8 years, 10 years. So that means the longer I am, the deeper my program has to become. It cannot be superficial. Yeah. And in terms of what do we want to do going forward, really looking at states where we can have options of, like all of you mentioning, can we have cash transfers? Can we help women access money? We haven't done it, but it's something we're looking at. Also in terms of scale, replicability, what you were mentioning, very cognizant of the fact that as a corporate, there is a limit of how much we can do. Yeah. When we look at India's total CSR spends, we are not even an iota of what the government spends. Okay? So we are very clear that we can help, but we can't completely transform. But that said, I think we are good at creating small models which work. So maybe it's also a matter of, having stronger engagement with the government where we share our models of success. To say, would they like to, because it's impossible for a corporate to really create that kind of transformation. So replicable, yes, within our ecosystem, very much. But if I want to go all over India, very hard for me to do. So I'll have to go back to government to say, can we co-create, or, can we have learnings, and then can you replicate it?
Thank you so much, Mandira. And I think you mentioned about keep it simple and straightforward. And the second thing I will borrow from Sumakar is small is beautiful, which means you are in the process of creating small, beautiful models which others take and replicate it at scale and in different parts of the geographies of their interest. Now I'll come back to you, Sachi. Going forward, how does SIF view its future nutrition sector programming, or if I have to say child health programming in India? What role does it visualize for itself? Is there going to be some shift in the way SIF has operated in the past? Role for the governments and its partners in anchoring the scale-up for long-term impact?
Okay, I'm going to have to refer to my notes a bit because that's such a long question. I'm going to break it up. Yes, yeah. So I think just I'm going to answer just briefly to begin with and to anchor my question, my answer. What roles, right? And I think that also speaks to what Mandira said. Um, the roles I think are very clear to all of us. The government is the anchor. You know, partners like HUL, SIF, we are early stage backers, we are connectors, and implementing and technical partners are co-creators. So having said that, I think at SIF we see ourselves less as traditional donor partners and more as catalysts for innovation. We do exist in a space of privilege where we can pilot boldly. We have the privilege of failing fast. We have the ability to support through building evidence, proving whether something works, doesn't work, and then sharing that with the system. And so our key priorities, I think, in that sense are fairly straightforward. The first is country-led and equity first. We want to closely partner with government to design solutions which reach the most marginalized. It is about meeting people where they are and closing access gaps. And that access gap doesn't only have to be about distance. It could be even something like being able to access the money that comes into their own accounts. The second is about supporting a public system and not working around it. And also about being a bridge. We are in a place that's capable of bridging government partners, implementers, donors, and other technical experts to make innovation happen. Learning and adapting in real time is going to become very critical. See, a sustainable impact is not about the perfect pilot. It's about being able to design something that has an embedded feedback loop right from the beginning, which allows you to course correct in the course of that program. And most importantly, we see that there is now the time to position India as a global leader. There is groundbreaking work happening here. I know all of us have been in a lot of the panels yesterday, today, and plan to be tomorrow as well. So whether it is what we're doing with Cash Plus SBCC models or digital maternal risk screening or AI, we've seen things that are succeeding. We genuinely believe that these have a huge potential globally, and we want to be able to take these beyond India as well. Whether it's toolkits, peer exchanges, cross-country dialogues. So in a way, I think what we're trying to say is if it's what works in India can work for the world. Coming back to roles, like I said, the government is the anchor. Our solutions have to be embedded into existing systems, and that has to be something that we work into our designs on day one. SIF's role, early stage backer, fail quickly, fail fast, succeed quickly, whatever it is you need to do, you have the privilege to be able to generate new ideas, generate whether something works or not, and bring people together. So we want to be able to support Indian states and institutions to also showcase their models globally. And with partners and co-creators, there's deep contextual knowledge, there's technical muscle and the ability to innovate on the ground. And that's where the roles stand. Long-term impact, very straightforward, government leadership, capacity building, strong governance, data, like William has, spoken so much about, but actionable data, and community and South-South. And I think both of them speak because on one hand, when we look at the microcosm of it, we're talking about a community from a much smaller perspective. When we're looking at larger geographies, we're saying it's about countries coming together as a community. We do have shared issues. We have shared cultural barriers. We have shared practices. And what we have learned, it will be important to share with each other to be able to overcome these together. Yeah. So I hope that was.
Brilliant. Thank you so much. I'll quickly move to Naomi. Connecting what, again, Sachi said, if you were to, and you are in fact, distance yourself because you are neither a donor nor someone like me who is into implementation, but someone who looks at implementation, donor models very critically from the lens of an practicing academic, right? Um, if you were to look at some of the principles that Mandira and Sachi mentioned, as donor organizations, in your view, what will be those principles and mechanisms that you think uh, are necessary for transfer of successful experiences in one space to another, whether within country or elsewhere? Sachi did hint upon something which I will say is a South-South collaboration model, right? What will those principles or mechanisms be, number one? And number two, how do we ensure that such principles and mechanisms also ensure equity and also, dealing with the issues of the last mile?
Really big question. Thanks very much.
Big ones.
They're all big questions. Yeah, so I think learning from what's been done with PLA Scale Up actually here in India could give us quite a lot of insights. PLA was first developed in South Asia looking at neonatal survival, and the work of Ekjut has been scaled up over entire states, and with really good effect. I think it's harder for nutrition. When we're talking about neonatal health, there's like a small window of time and a small set of behaviors, whereas when we're talking about nutrition, you've got to change people's entire kind of culture around food and behavioral practices within the household. So it is harder to do, but I think we can still learn from that scale up. Some of the things that we're doing in our community prevention of acute malnutrition trial that we're doing together with SIF and Ekjut in Jharkhand at the moment is that we're ensuring that there's a very strong ownership of the program by the government, number one. So that resonates with what Sachi was saying. The other thing is looking at coordination between different government actors. So it's not just the National Health Mission, but also the Department of Women and Child Development, leveraging those, the ICDS program, getting the Anganwadi workers and the ASHAs working together, doing counselling together, coordinating for the referral of malnourished children, for example. And then, of course, working with the frontline workers, as Sashi has already said, we need to be working with the ASHAs. It's no good having, we've seen in our recent study, just this week, actually, we brought out 4 new papers about preconception nutrition in the region. And that amongst those papers, we did one systematic review of interventions that have been testing preconception and nutrition interventions together. And what we found was that some of the most successful interventions had great impact, but they're very difficult to do at scale because they were using local employees of the NGO. So we need to be working through ASHAs and other frontline workers across the region to try and get it to scale up. But I think for getting reach and reaching the poorest, one of the things we need to be doing is looking at screening and tailoring of our responses. I mean, in very poor areas, you can do a blanket response. But if we're looking at trying to do something at scale, the resources are just not sufficient. And also the needs are very different. We've got triple burden of malnutrition here in South Asia. We've got women who are suffering with obesity, and they need something completely different from the women who are suffering with low BMI. So we need to have a screening processes in the scaled up systems. And then when we've identified those people who are undernourished, they need very targeted social protection and targeted counselling to really make it work at scale. Thank you.
Thanks so much, Naomi. And, we should do a round of applause for all our panel members for being, I will say, so great on time, because I have attended some of the other panels where the participants actually had no time to ask questions, right? So we are still, yeah, okay, brilliant. So shall I open the house for some questions before you wrap up, or you'd like to?
I think let me speak and then you
Perfect.
questions so that
Perfect. So over to you, Chair Rajiv Sensab, for summing up and also directing on what should be the way forward. Over to you.
Thank you. So, I mean, thank you very much for inviting me. And this chairware is not something that I'm here for. I am come here to learn. And I have learned a lot of things. I mean, let me tell you very frankly, I am not from the background, nutrition background at all. I am an economist by profession. And I am handling this in NITI for the last 3 years. It's fascinating. And whatever we have heard are all very, very important. And I don't think this needs any type of a summing up. These are all activities that need to be done. However, I would like to dwell on a few points, some of which are very specific to nutrition as a topic, and some general, as government, as implementers, as designers of scheme, what I think we and all of us need to keep in mind. So let me start first with the nutrition. Now, let me tell you, I myself was also not aware, and most of the people today are not aware what is nutrition. Nutrition is equated to hunger. So, first I think this awareness needs to come to all that nutrition is not hunger. You may have a filled stomach, but then also you may be highly undernutrition with this and malnutrition. And nutrition is not an issue only with the poor, it's as much an issue with the rich. So I think, in India, the awareness comes from things which hit you hard. Today, even many of us think that no, nutrition means khana nahi mil raha hai inko, to ye hai nutrition, which is not true. So I think this is intergenerational. Everyone starting from a baby in the womb to a person who's 80, 90 needs to know this. Now a lot of studies are coming in. We have what we call nutrition diversity, micronutrients, nutrition and all that. But even then it has not gone down to the level it should go down. So this first question, access, obviously, cash is an issue, ownership of means is an issue. But first they need to understand what is meant by nutrition. I think that is where a big level awareness needs to be done. I think all the private and the government, whatever you are doing, very good job. But I think please bring this aspect in to your whatever interventions you are doing. The first to be aware that what is nutrition. Secondly, behavior. Some of you have touched upon, but I think there are some things which can be done which don't cost us a bomb. And behavioral interventions are one of those. Some of them are really, this who owns the cash and all are some of them. But beyond that also, and here I would like to mention our my mentor and whom I'm working, Dr. Paul. There are great studies of how you should feed a baby. The very simple things, these are not costly things or these are not resource intensive things. But these very simple things, I'll just give you an example which we are discussing. When we are talking of anemia, we equate it, even in government, the thing is IFA tablets. But we give IFA tablets. Do we see whether they are taking it or not? Do we ask them why they are not taking it if they are not taking it? So I think these behavioral aspects we also need to bring into our model in a very, very not opaque, I mean very overt way, so that people know that, it's not only food, how you eat the food, when you eat the food, and what is the diversity that you are having. These things also need to be built into any intervention that we are making. So that was my second point. Thirdly, saturation. Again, as all of you are speaking, how do we reach the last mile? So here I would, all of you must be knowing we have in government what we call the ABP, the Aspirational Districts Program. Now that's a great model of saturation. We are going to present the third Vienna, the Voluntary National Review, which is, the progress of SDGs. We will be presenting it to the UN in July. So I am also looking after SDGs, so I am in charge of writing that report. And what I really find is very, very unique in India. And also, by the way, I don't know if you're aware, in the Brazil presidency of G20, they have come up with a group called the Action Against Hunger and Poverty. So there also, the issues of nutrition, income inequality, all those things are coming in. I have not, and since I'm interacting with many, countries and their schemes, there's a policy basket where, all the schemes that are relevant are being put in. There are no schemes, at least to my mind to date, where, the focus is on saturation. ABP is not a scheme at all. It's a scheme of schemes where we look at two things, convergence and saturation. So I think this philosophy or this model also needs to be built in. And it's not possible, as both of you have said, it's not possible for one private entity to, to scale up to a country level. It's not possible. However, if you are doing even at a smaller level, it should be a representative population and it should be taking it to the last mile. Because, taking it to the last mile also has its own lessons. Our model may be very good scientifically, it may work up to a certain level, but when you go deeper down and you try to reach the last person, as you were saying, very poor and all that, there are other challenges which come in. Those are the challenges we need to learn to overcome. And it can be immense. And these are the learnings which I think would be very, very important and relevant from government, from the trials and experiments that you are doing. That's the third one. Fourthly, on feedback loop, you had just referred to that. Let us talk to each other. Let us not talk at each other. What happens, and I'm from government also, I'm considering this is what we do, not only with the private, but even with government. Yesterday only, I was in a panel where we were discussing MVT, this medical value tourism. So in government, various departments and divisions have set up what they call their own portals. Many of them are replication of the same thing or the same set of data. So I think this, cross learnings is a very, very important, and I would like to mention that in that respect, NITI, the organization that I'm representing, we have set up this forum with the private, with the academicians, and with the states. So today what we are doing is all the good practices that one state has, we are trying to take it and disseminate to the other states. States, local bodies, NGOs at all levels. And you were talking of localization. So in SDG, what I think is the most important thing is SDG localization. And as you know, SDG is everything. So it's an outcome-based thing, and that's another area which I'd like to, let us not look at only processes or inputs or outputs for that matter. Let us look at outcomes. It's easier said than done. In the social sector specifically, it's very, very important that we look at that we need to build into our model, and that comes in when you focus on the outcomes. And in the social sector, as I said, it's very challenging. In the other sectors, infrastructure sector, you are building a bridge. That is both an output and an outcome, because if you are building a bridge, the next steps would follow, which is not the case in the social sector. So health, women and child, education, big things, learning outcomes. Half of the people don't even understand what learning outcomes are. So these, in order to reach or get into the concept of outcome, I think we need to have a mentality. Today we talk of outcomes, but actually you don't mean it. I think we should come to that stage, and that should be built into us, that our final aim is to have a at par birth child with no diseases or as little diseases as possible. And with that goal, what we need to do. Give you an example, we have this Anemia Mukt Bharat. I go to that example everywhere. Just see, we have the output-outcome framework. Now, the way we measure it is how many IFA tablets. That's not the way. Anemia Mukt Bharat means you have to bring down anemia, the level of anemia. If we think it that way, the whole gamut of what we see in front of our eyes changes. I think that's one important thing we need to keep in mind in all the good, wonderful experiments and activities that you are doing. Technology, of course, I think I need not speak. We are definitely not using technology optimally. Portion tracker, RCH tracker, they don't speak to each other. We are trying to do that, and hopefully we'll be able to do that. But, these are all things, but beyond technology also, I think there are certain things which we can do, as you had said, which are very simple. I think all data need not come to us through a very high supercomputers. Certain things can be kept at a very low level, which is basically at the level of what we call, feedback and information. So that can happen only when we talk to each other. For instance, what one particular company is doing in a particular district vis-a-vis what another company is doing, I think we need to have a platform where we can discuss and sort of cross, so get our learnings so that we know where we are going right and what we need to do better. So again, communication and, this thing. And interlinkages, of course, health, WCD, education. As I said, these are all issues which are very, very interlinked and they're intergenerational. So, I will just give you an example. In NITI, we have come out with what we call a school health policy. It's nothing new. We already have health interventions in schools in terms of what we call RBSK, RKSK. But those are not happening optimally to the level that we need to do. So the scheme is trying to plug those gaps and ensure that the child, and today, you have 100% GR at the primary level. So your whole catchment area is in schools. So if you can not only make them healthy, but also make them health aware through a proper curriculum, through a proper referral process, proper screening, the effects will not be seen the next day. It has a gestation period. But beyond that, the results will, to my mind, would be phenomenal. You talk of health resilience. Half of your health resilience is your health education. If people know what is the right thing to do, automatically half of your resilience is taken care of. You don't need super infrastructure. You need them, but this will be much more effective than building super infrastructure without people knowing what to do. So I think this interlinkage is also, when we, as Usha ji said, that the multi, but then if it has to be multi, but somewhere there has to be a unit. That connect is very important. So that framework we need to develop, whether we do it at a micro level or a macro level, that should be there. Then only we will reach the outcome. So these are some of my general overall points, and I take it, all the points that all the members have said are very, very critical, important, and relevant. But at the end of the day, I think when we look at a national outcome, I think these are the things which should also built into a micro or a macro scheme. So with that, now I think we can take questions.
Thank you so much. Now I'll open the floor for question, but what I will request is, please ask questions. Don't set contexts only. Yeah. So we can take in lots of two. Please, share your question and also direct to who is the panel member you are posing that question to. Over to the audience. Can I take there? Yeah, Abhimanyu.
Yeah, hi. I have a very basic question. We're focusing on the last mile, and our frontline workers, ASHA workers and Anganwadi workers are already swamped with a lot of work. So how do we keep them enthusiastic, like you mentioned, like with additional counseling? It's additional burden for them. They're not paid so well. So how do you manage to keep their enthusiasm up and going? So that's my just general question.
We can take one more question and then one more question to that gentleman.
Good evening, everyone. It's really important and very great to know how private entities are coming into the picture and helping leverage all these issues related to nutrition. But my question is to understand, are we doing more for our geriatric population? Because I'm pretty sure they're also nutrition deficient, and is there any plan in mind or any program in pipeline that we can have something? And I have one more specific question directed to Professor William only. Can I? So we talk a lot about how AI, ML, and all these things can actually help us understand more about data, and that could give us a more fruitful answer, which I feel like is more into digital health literacy or something related to that field only. But without having a proper framework for AI, ML, can we go into it directly, or like what should be the proper road for it? Thank you.
So,
should I start with the geriatric one? Again, as NITI, I would like to bring for your information that we are working, health, WCD and education. We are working at a intergenerational model. Okay, I wouldn't say model, at various junctures. So one, we are looking at neonatals and after birth children, where we are looking at the Anganwadi workers and what they should do, how that program ICDS can be improved, what should be a new look ICDS for the future. Then we have what you call the adolescent health, school health, what it should be. So like that, we also have taken up what we call the geriatric care. As you know, in today, there are some schemes which are across various ministries, Ministry of Social Justice, pensions are with Ministry of Finance and all. So if you see on the NITI website, we have a working paper, not paper, what is that? A status report of what are the issues that are facing the geriatric population today, which we have bucketed into main four: health, social, I think one is digital, and there's a fourth. So these four. So now with that, in hindsight, we are trying to develop an action plan where all the concerned ministries are informed as to what are the interventions that we need to have on these four fields and on what we call enablers to ensure that we have a wholesome and comprehensive policy for the geriatry. So we are working on that. We should be coming out with the report with maybe in another 2 to 3 months. It's a committee under Dr. Paul who's chairing it, and we have all the concerned ministries. We have spoken to all the stakeholders in India and abroad also. And hopefully we should be able to come out with what we call a comprehensive policy. Then of course the implementation would be with their respective ministries.
William, would you like to respond to the last question?
Yeah,
And then the first question, Usha, do you want to respond? Or oh, please go ahead.
Yes.
Yeah.
Thank you for the question, and this question is very close to my heart actually, the Anganwadi Asha workers. I would relate this to the work that is happening in Nepal and how are we really incentivizing them. So we have got 48,000 female community health workers like your Asha workers, and they are the main vehicles, and most of them are women. I mean, I would say 90% of them are women, and they have lots of burden. There's no compensation that we are giving to them. From the government side and from the non-governmental side, they are not yet compensated for the amount of work they do. But then there is an incentive in the sense that they are the one who are connected to the people. And they are the one who connect the people to the local governance. And they are the one who have been, I mean, they are trained, they are being trained, and they are the only workers in the community who get acknowledgement regularly for the work that is happening in the community. And then there are some monetary things there. It is tied up with the incentives that is given to them. And as I said before, this multi-sectoral, multi-nutrition plan, we are, from the government level, we are working very much on the governance system, because we know that the civil society and other organizations, the private sector, they are doing lots of work. But the only thing that is missing is the nutritional governance. So government of Nepal is working very much at the governance level, from the federal to the provincial and the local, and also to the ward level, the smallest unit. So wherever it is, the first preference is given to the FCHBs, and we engage them in all of the program over there. So there is some compensation, and but the other recognition which they are getting and the acknowledgement they are getting on the top of everything, and the capacity building program that is being given to them, it is a little bit of compensation, but they are doing much more than that compensation. So the last mile for them is their satisfaction of being able to save the lives of so many children in the community, because they are the one who are connecting all the programs to the, it could be UNICEF, it could be any INGO, it could be government, they are the connectors. So I think that's very important for them, and that's a great incentive for them. Thank you.
Right. I just wanted to respond from the Indian perspective, and I think that's a really wonderful question. It's a very necessary question because, like I said, a well-supported frontline worker won't only deliver a service, they will transform a system. So what are our friction points? And I'm only going to be able to give a handful of examples here, but let's look at it from an A&M's perspective. They are expected within their job description to examine, to record, and to counsel. But there's so much time that might be going in examination and recording, I don't have time for counseling. So as innovators, can we come up with a solution in partnership with the government to automate the actual reporting part of it? Can I introduce Bluetooth devices where it's automatically uploading information, and I don't have to enter a register, open an application, do anything of that sort, right? The second aspect of it is, let's assume she has so much burden, she cannot do IPC. Can I introduce a concept like group ANC, where all the women who have come for the village health sanitation day that day, all the pregnant women sit in a room together at different gravida, and different times in their pregnancies, and talk together about their journey, their problems, what they need to be doing, how they can go about it. An ASHA worker is a community mobilizer. She's a social health activist. She is supposed to mobilize the community. So can I create a situation like PLA where she also gets an incentive, a monetary incentive for PLA, where she brings the entire community together and provide her with the tools to educate the community, motivate the community, mobilize the community, and then she will see that there are problems that she's been trying to address, which the community is now going to come together and address, because she's also a part of that community. For home visits, ASHA Anganwadi workers are supposed to go for home visits. ANMs are supposed, there are SOPs in place which the government has already created. Now, for these home visits, can I provide the kind of tool which actually makes a change? Is it just about her going, knocking and saying, "Sab theek hai"? Or is it about me providing her with flip charts, a digital comic book, a dialogue, which can help her communicate what she's trying to do better? A large part of our frontline workers' essential role is about behavior change. And like Mr. Sen also said, this is something they're meant to be doing. So with a very small amount of resource allocation, which is very resource light, can we strengthen an existing process? There are SOPs in place, there are guidelines in place. So how can we support these women better? In India, we have close to 1 million frontline workers. How can we work with them for them better? Because we've given them the burden of all the health programs. So that should be part of the way we go about designing innovation. I hope that answered your question.
William, and
Yeah,
then
thank you. And thank you for the question. I think
yeah, please go ahead, William. We won't take repeat ones, so in the next slot we will request two new faces to ask the question. Sorry.
Yeah, sure.
Yeah, please go ahead.
Yeah, so thank you again. So data creates or shows you problems, but data also shows you solutions. Now, from which perspective are you coming to look at data? So a lot of us believe that if data shows me problem, I would not work on that data or try to collect that data. Or for us, like data shows a solution. So we have to go with a very unbiased kind of approach to collect data. It can give you anything. Thing is like how you deal with what information is coming, and that is a thought which is lacking in terms of how we work with our programmatic kind of information. So if you will look at any kind of programs, we have every program has a database, a system is there, but we lack a data framework. What it actually needs to collect, what it actually needs to explore. You will also agree that any data system you pick up, 90% of the data is never used. So why to collect that? Why to bother even to collect that information? It's not only about program data. You pick up NFHS. I think 90% of the NFHS data is never analyzed. It's like some of the key indicators only. So when we are not actually engaging with data, then why actually we are spending so much time burdening everyone in the system with that? So there we need a good system of data framework creation. Plus, it should not be left only to the consent program. It has to be more, I think, open up across in a convergence framework where what other department would like to see and comment. Of course, there will be a way of reconciling any differences and all, but it should be actually taken as a step forward to create a framework which is reviewed and then only meaningful indicators are kept. So cutting some of these will actually also lower the burden of all these frontline workers. They are totally the kind of registers and digital systems they have to learn, adapt. Plus, the thing is that what AI ML can do, I think it's a buzzword, it has to be there everywhere, and how to connect that. Now, AI ML, it has good applications in a scientific space, but in program, what can we do? AI is largely to discover things which will be difficult for us to fathom. It's not like we are inferior in some sense or all, but just that the computing ability is too good. How it will work? If you have that kind of data with you. So for example, if we are collecting so much of CBC profiles in our PHC, CHCs, that information is never actually coming to a stage where AI can be just applied to that and you can draw inferences. So if you can connect across program, you will see how AI will give you solutions. So solutions can be at the individual level or at a pattern level, say for some geographies, targeting can be much better. But we are not actually giving data in that format to AI to draw meaningful inferences. So unless we work on a framework, and I think with that, a lot of solutions can come, because still we believe that there is so much of unexplained problems. So anemia, we know, iron is there, we know folic acid is there, zinc is there, but you add up everything, it will be still half of that. Half will remain unexplained. And this can be learned if you apply more of this data.
Yeah, we are left with 7 minutes, so I'll request two new persons to ask one question. One to you and one to you, ma'am. Sorry about it, friends.
Is there any document, is there any standard document, standard framework where we can monitor how the partnerships or multi-sectoral coordinations is moving at each level?
Okay, and your question, ma'am?
Yeah, hi everyone, I'm Monica, I work with Population Council. My question is to understand from the systems and the community lens perspective, how do we target women who are neither in the phase of pregnancy and nor even at the adolescence phase? The women who are there, not targeted as part of any health systems overall right now, and I'm talking about women, so to say, in the reproductive age, but women who are in between pregnancies, beyond pregnancies. How do we target for nutrition for them from the health systems lens or a community systems lens? That's my question. Yeah, thank you.
To me. Yeah. For especially for Nepal, I think there are documents, and you can just visit the Planning Commission site, National Planning Commission, and you will get everything there on the multi-sectoral nutrition plan. That's the phase 1, phase 2, and phase 3, with all the indicators and the learning and the descriptions and everything is there. There are things that we have learned as well on the way, but everything is there on that, and as a result of that, we are in the food systems approach, and that is also there. So you will get them all. And about your question, I think it's a very much community thing. What I have seen is, like, I have seen the female community volunteers. They are the vehicles, and they are very much working closely with the women in the community. They know each, and if they have 25 houses in her command, she would know what is the status of every woman in that family, and she would know which of them they are planning to have a baby now in future. So she would start, she is educated on, okay, what needs to be done to her, and what needs to be done to the pregnant woman and the neonatals and all those things. There are so many programs that is focused for the pregnant woman and the women who are preparing to become pregnant and the neonatals. So I think those volunteer workers, they know, and they know what to be told to them and how to educate them and how to prepare yourself for pregnancy. They teach them. So there is a group meeting, and the women's group come together, and all the women are there, and it's a regular coaching and teaching, and it's like it is a little bit tied up with somewhere savings as well. So that savings it becomes the very strong vehicle for them to move forward. It's the economic empowerment. One's economic empowerment is also tied up over there. So that creates a solidarity group, and that helps. And again, the educated women help the other women in knowing, okay, what needs to be done to prepare yourself. So there where you get all the tablets, there where you get all the anything that is needed for the neonatal and the maternal and everything. Thank you.
I didn't get your question. Are you talking of women who are not in the reproductive age? How do we... Yeah, so that I think, I should have mentioned, there is a program called Wings, which has been tried out. It was, the basic program was conducted in Delhi, among the Delhi slums, where this component is very much there. Now we are scaling it up. We are starting with Himachal. So the Himachal has volunteered to scale up. So there we will be working on this intervention and see how the results are. That's one aspect. Secondly, of course, you can see I think, we should not, this is my personal opinion, I think we should not always be in the target mentality. There are certain things which should, through education, through knowledge sharing, things should, filter in. So for a women, again, as I said, for the old age, also for nutrition, based on the NIN last year, as you know, the nutrition guidelines have come. In NITI, we are working on what we call a age-wise strategy for nutrition. So from 0 to 2, then the school, the 2 to 6, and then adolescents, middle age, old age. So based on the NIN, we are trying to come out with a nutrition strategy for each of these age groups. And what should be there in the nutrition strategy? There are 3 things. One, what should the government do to reinforce or, to make the policies more effective? Second is, what should the community do? And third, and to be the most important thing, what should the individual do? So it is going to be a very, very simple, it's not a very, high funda or a book like that. It's a very simple thing, kya karna hai? So based on this NIN strategy, we are trying, and I think these are types of things, simple tidbits, like, ye karna hai, you have to do at this age, this point of time, when you have to take vitamin D, when you have to take calcium. I think if we can get these things imbibed in the mind of people, I think that itself will go a long way. We did not, so to say, target those groups. And this, I really didn't understand you. What do you mean by, we have whatever interventions we are doing, but see, there are lots of, being a federal structure, as you know, lots of things, lots of initiatives are being taken at the state level. So the states are working with many NGOs and they are doing a wonderful job. So, in that way, we are not sort of having everything to our knowledge. But as and when we interact with the states, we get to know that they are working with these NGOs and these groups, these private entities, and they are working. So that's my response.
I'm very sorry. I'm being told that this room needs to be prepared for the next session. So I would like to thank all the panel members and wonderful audience for being around. So a big round of applause for all of us. Thank you so much. Thanks.